senior doctors and panelists, Dr. Deepak Patel sir, Dr. Sardhara sir, and Dr. Sandeep Shah. Please come. Yeah, okay. And we'll invite our first speaker, 3D, Dr. Jayesh Sardhara. He will be speaking on 3D anatomy of CV junction, anomalies and implications in management. Jayesh.
That, but in case of an that's what the point is. The second important thing, if you see this, the vertebral artery is the exit from the inferior surface of the C2 groove here, and then it exits to make a vertebral artery groove, become a lateral, enter in the C1 foramen, and then make a medial loop or just above the C1 arch, and then it enter the dura. With this anatomy of the vertebral artery, if you see this, below the C1 arch, this is the lateral mass of approximately of 5 millimeter. So we have easy space of 3.5 millimeter to purchase a screw there. Here, just medial to the vertebral artery groove is this part is called pars or isthmus. In 3-dimensional, it's called isthmus. We know that things, but if you say in the anatomy, it's pars. So the pars is important in the CV junction anomaly because when there is an anomaly, the first effect is the bone, then affect the artery. So the bone become hypoplastic. The first hypoplasia is C1 and C2 joint. So when the C1 is anomalous, it means C1 lateral mass is hypoplastic. So the normal, if we say the screw entry point, the center point, this is the C1. Let's discuss the entry point of the C1 screws. The center of the lateral mass, the safest one. Now, trajectories, of course, towards the medial arch, 5 to 10 degree medial and superior. Now, when there is a C1 anomaly, this is narrow, less than 5 millimeter. So the alternative entry point is least point, where it is a junction between the C1 arch and this lateral mass. Third point is trans point. You can directly put the screw in the C1 lateral lamina here. It's called trans point. The only problem is you have to just manipulate the vertebral artery, you keep it safeguard, and then you put a screw directly in the C1 lamina. This is a third. So there are two rescue point, rescue screw entry point. Now come to the C2. So if you put you draw a quadrangle like this, if you put the center, and you have to know where is the vertebral artery groove and where is the medial border. This is the exit, the pars entry point, the center. Now, if you dissect the medial border of the C2 from pars, and you dissect the C2 lamina medial border, and where it turn around, that's a pedicle point. Where the lamina is turned around medially, it is the pedicle point. If you keep a number 4 dissector at the most medial part here, and you just take a lateral entry and you direct your screw trajectory towards that number 4 dissector, it will be your pedicle. So without even the C-arm, you can put a C2 pedicle like this. Now, yesterday we were talking about the C2 inferior facet. So the same entry point of the par screw, if you goes down, like we put a C3 lateral mass from here, C2 inferior facetal screw is from here like this. When we are dealing with the anomalous vertebral artery, where exactly it is crossing the C1 lateral mass and C2 facet overlying surface, sometimes it's difficult to manipulate the joint and we don't want to take a risk. One entry point is here, we call it C2 subfacetal screw. We directly bypass the C2 groove, we directly put a screw in the superior articular surface and directly into the body. The only point, we little bit have to have a larger screw so that it goes like this. These all are the rescue screws, not a normal point. So this is about the normal vertebral artery, normal anatomy we say. Video please. No, but this will not work.
You can do it full screen.
From here?
From current.
Where is the cursor?
Yeah, this is the cursor turns into hand. So you put it, it stops it. You press it, it will. Yeah.
I can't forward it?
You can.
No problem, let me make it large.
This is visible on the screen.
No, I want a big screen. Make it down. Make it large. No, but I want to make it large.
आटलू
No.
नीचे खींच नीचे भी खींच pull it down.
Can you escape this? I will run my video
Okay.
from the pen drive. Where is the pen drive?
Yeah, it's here.
Yeah, run it. Okay, fine. Okay, so now I just want to show you one video. It is very important because this is the story of CV Junction development. And I just take you to go through this story. Now this is not only tell you, the CV Junction is developed from 4 to 7, sclerotome, 4 occipital and 3 cervical. Now, this is the Pang theory, of course, not mine. The CV Junction is developed from central pillar, basio-occiput, and the lateral ring, exo-occiput. So basio-occiput develop into this central part, the C2 odontoid and C1 central arch and foramen magnum central, and then lateral ring is converted into this C2 and C1 lateral mass and C1 condyle. So the central pillar, lateral pillar. All the CV junction develop in all these 2 pillars. Now, this is the real model of 3D, which I make it from 1 month to 16 years of age. Now, if you see, up to 3 years of age, your C1, so C1 arch completely develop up to 5 years of age. So it means at the C1 arch, if you suppose say 3 years patient, your C1 is not fused. It means there is a C1 central and C1 posterior cleft. The ossification is not completed till 5 years of age. So it is very weak, less than 4 years of age. You have to consider that if you fuse the C1 and C2 only with the screw, there will be a lateral instability remain. You should also think for the occipito-cervical fusion and connector between 2 rods. It's a fundamental problem because 5 years of age, C1 and C2 is not completely developed. We consider it is that we put a screw is not good enough. C2, coming to the C2, so at the until 3 years of age, it is not fused with the C1, the odontoid and the body. This is also important, we consider the os odontium falsely. And of course, the complete CV junction developed till 16 years of age. So this is the point that occipito-cervical fusion and connect are supposed to be thing in pediatric patient. Now, how become anomalous? So at the 4th week of fetal life, there will be some defect called dysgenesis. Now the problem is the central and lateral ring dysgenesis together. That is the basic reason that the bony, vascular and neural anomaly have combined story. So first consider central pellar dysgenesis. So there are 3 stages. One is all the CV junction bones fused before birth. Then it's separate. And then after birth, it's resegment. So when there is a separation phase, the clivus in C1, if it is not separate, failed to separate, we called it occipitalized at last. And it leads to flat clivus or, occipitalized at last, platybasia or whatever. Now, child birth with this flat skull and resegmentation start after he start to walk. So with the large skull, there is a theory that gradually, this clivus, the flat clivus become more and more bent forward because this odontoid push it upward gradually at the 9 years, 10 years, and there where your progressive BI start. When it goes upward, this horizontal joint become gradually oblique and then vertical. So we are starting from 90 and then 160 and 114 and this story of progressive BI. Now because posterior fossa is made up of fixed space, tonsil herniate, and that's the reason the BI is associated with the ACM. The problem is the central ring is also defected with lateral ring. So when there is a exoccipital dysgenesis, there is a condyle and C1 fused. That's why there is a coronal tilt. This is a congenital tilt. Now once child grows, as per biomechanical rules, when there is a one side lateral tilt, there is an opposite side rotation, 12 degree of rotation. So that is the reason all of CV junction anomaly patient presented with torticollis, Cox head Robin position, we know there. So it's a story of mixture of coronal tilt and rotational dislocation on one side. Now C1 become weak, transverse ligament become weak, gradually there is a translational dislocation. Now vertebral artery always follows the bone, so there is a vertebral artery because of all this. Now to prove this, we have published this study in 2018, one of the highly quoted paper this was. There are the combination of dislocations. In 158 patients, we have studied this, C1, C2 dislocation. What we find, there are 6 types of C1, C2 congenital dislocation, but the most common was combined. There is a central dislocation, BI, coronal tilt and rotational dislocation. One of the reasons that all cannot be reduced. Even many tried. Now let's discuss the common type of C1, C2 anomaly with day-to-day. You see the lateral joint. Always look the parasagittal joint symmetry. Reducible AD, it's symmetrical, no problem. You open the capsule, you put a position, it can be fused. Irreducible AD, you see this, BI. If the joint is symmetrical, there is no problem. You see the joint is symmetrical, you still can distract it because it is a symmetrical joint. You open the capsule, it will reduce. I just take 2 minutes more, Dr. Rakesh. Now, third variety is this one, which is approximately of 10%, in which the joint is very asymmetrical. Yesterday we have discussed. You see the parasagittal joint. One is plane, one is vertical. Now, if you put a spacer on one side, your odontoid goes backward. These are the patients which deteriorate after surgery or remain same, and whatever you do, it cannot be completely reduced. Again, type 2 BI, but it is said that there is an instability we can see here. So BI with ACM, any patient per se supposed to be fused with decompression. Syndromic AD, the last topic we'll not like to discuss. Yeah, anomaly. Because we have seen why there is an anomalies of bone. Now, vertebral artery always follows the bone. So when there is a C1 is occipitalized, when the C1 is attached to the occiput, vertebral artery has no course to remain. So where it goes? There are two ways. Either it enters from more lateral and create the occipital foramen and that enter ventrally. Now consider this is very, very safe. This part is very, very safe and it is 80% of the part. So no need to worry for that. The problem is this, 20% of the artery is persistent intersegmental artery where it's make a loop over the C1 and C2 posterior lateral mass and then it enters the dura. So this is the where you have to check it. What is high riding vertebral artery? So there are 5 types of vertebral artery group as per Wang. 0 1 2 is normal, in which vertebral artery make a normal loop. But when there is an anomaly, there is a C2 hypoplasia. So C2 groove is wide. So vertebral artery take more medial and posterior loop. The problem is isthmus is so much narrow. If you put a transarticular screw or any kind of partial pedicle screw, there is a high chances of injury. And this is called high riding vertebral artery. So I'm finished here. Thank you so much.
Thank you, Jayesh. Now I request Dr. Abhidha. She is going to speak on deformity of neck proposal of surgical treatment.
You need a slide number?
With a CV junction anomaly, you see the short neck and the height of the patient is also less. So we all know that Dr. Goel revolutionized the treatment of craniovertebral junction anomalies with this technique of plate and screw fixation. And this is the technique where you put one screw in C1, one screw in C2 pedicle, and then you realign and fix the craniovertebral junction. But what you realized, as you saw in the previous presentation, is that whole of craniovertebral junction is revolving around the facets. What happens is the odontoid is secondary. It is the facet which is the problem, and if you understand the facet, you'll be able to treat it. So basilar invagination was divided then into these two groups, where group A, the odontoid prolapsed upwards, and it crossed the Wackenheim's clival line. In group B, the whole system, the clivus along with the odontoid moved up, and it crossed the Chamberlain line, but the odontoid did not cross the Wackenheim line. So this was group A and group B. Of course, at that time, group A was considered mechanically unstable and fixation was advised. Group B was considered stable and we advised foramen magnum decompression. But over the years, this philosophy has changed, and even for group B, we will now do C1, C2 fixation. So as I said, it is a story of the joints. The problem is mechanical instability, and the joints are abnormally inclined. You see, these are various progression in the way the joints manifest themselves in craniovertebral junction anomalies, and these are the worst when they actually become spondyloctosed. One joint is in front of the other. But these joints are not fixed. They're not only not fixed, they are highly mobile or hypermobile. And if you're able to maneuver the joints, you're actually going to be able to treat these anomalies. While treating these anomalies, we realized that while treating basilar invagination, there was a change in these long-standing musculoskeletal abnormalities that occurred in patients with basilar invagination. So you see this patient, with a torticollis and a shorter neck. This is the evening of the surgery, or maybe a couple of days of the surgery. The neck has become long, the torticollis has straightened. Again here, the short neck, the torticollis, post-operatively, the torticollis has gone, the neck has lengthened. So there is a possibility of reversal of these long-standing neuro and musculoskeletal anomalies. And basically these anomalies occur as a protective maneuver to protect the cord that is going. Why does the torticollis occur? Why is the joint moving? The neural structure has to be protected. So even patients with such deformities, see the neural abnormality, see the neurological dysfunction is not much because the cord has made space for himself. The vertebral column has redesigned itself to protect the traverse of the cord. So this is what Jayesh was showing in one of these images, where you see this coronal, where the joint has actually moved so much, and he was saying we cannot correct it. I don't know, I mean, this is what we also do, but you see this, we don't use the spacer now, but this is what we had done. This is the correction of the tilt by doing a differential distraction. In one side a spacer has been put, and the other thing has been put, just bone joint. Here you see how much the odontoid is lying rotated and lateral. And see the joints, but you can correct it. You can correct this if you're able to go in the joint and manually maneuver it. So what we did based on understanding of these, we divided torticollis into these three types. Type 1 is the one associated with craniovertebral junction anomaly or the protective or secondary torticollis. Type 2 is not our purview. It is spasmodic torticollis related to the sternocleidomastoid. And type 3 is an acquired facetal rotatory torticollis. So this is the one that is associated with basilar invagination. You see the BI, you see the joints, you see how the joint is. Patient comes with torticollis and a short neck, and you're able to do this maneuvering of the joints and fix it. You're able to correct the torticollis and the neck deformity. So you see both the sides, a plate and screw fixation has been done, and the torticollis and the anomaly has reversed. Again, another patient that I've recently done. See this basilar invagination, see the joints, see how abnormally inclined they are. But you can get into the joints, you can open them, you can distract them. We put bone pieces in the joint, no longer spacers, and you see the correction of the torticollis. This is immediate post-op, this is a few months after surgery. Again, another patient recently I've done. You see the basilar invagination, you see how high it is. You see, don't have a picture of the joints in this. And you see the torticollis and short neck. This is during his stay in the hospital. You see the neck has become long, the torticollis has reversed. See the reduction of the BI and the plate and screw fixation. Again, another patient, the torticollis has reversed, the neck has become long. So basically what I'm saying is this torticollis and the movement of the joints is an protection to protect the traverse of the cord. Similarly, bone fusions that occur in clipper file in cases of basilar invagination are again a maneuver to protect the traverse of the cord. Now this patient, you see the abnormal spine. You see she's a Klippel file syndrome, but she's actually no symptoms at all, not even neck pain. I have not treated this patient, I'm just observing her, but she does have an atlantoaxial instability. At some point she will come. This is another patient, you see the short neck, you see the fusions, and you see the atlantoaxial instability. You just treat the instability, you do a fixation, the neck becomes long. She had some breathing and voice abnormalities along with the neurological deficits which improved in the post-operative period. Another patient I recently did, you see the Klippel file and the atlantoaxial instability and the short neck, and here you can see one side dominant vertebral, the other side non-dominant, but I've fixed both sides and you can see the plate and screw fixation. This is some abnormal bone formations in the region of the cervical spine. This is again like, a bicycle stand. The spine is unstable. The body produces this bone, which actually runs from this is actually omovertebral bone, which runs from it's an analogy that your spine of the upper spine is being supported by that bone bridge that is going right up to the scapula. So again, the problem is atlantoaxial instability, and you treat the instability and the patient will improve in his neurological function. Coming to the other type, what is the acquired rotatory atlantoaxial facetal locking? It can be complete or incomplete. There can be translatory rotation abnormalities also. So this was our paper published in 2011. This happens in children because of the shallow and horizontal joint surface, the elasticity of ligaments, the underdeveloped neck muscles, and the large head compared to the body. What happens is one facet, so these are 3D models which we also described first time in literature. for craniovertebral junction anomalies, and our paper was published, I think, in 2010 or 11. And you see this joint is, one goes in front of the other atlas joint goes behind the axis on the other side. If it remains, if the whole system is not completely dislocated, you have this incomplete rotatory locking, but sometimes the atlas comes completely in front of the axis, and on this side the atlas goes completely posterior, and that is a complete rotatory locking that we see sometimes in patients with Grissel syndrome. Sometimes you can treat it conservatively, but if you're operating, surgery gives the best chance for this patient. You open the joints, you distract and manually manipulate, and you do a C1, C2 fixation. So you see this patient with a complete rotatory locking. You see on one side the atlas is in front, on the other side it is completely behind. Here, this is the patient. You see the abnormal, and majority of the times the atlantodental internal will not be changed in these patients. The odontoid goes up and there is a rotatory dislocation, and this is the correction. You see the torticollis has reversed and the neck has become long. So I'm just going to show you a few examples quickly. This is again a patient that I recently did. In this patient there was associated basilar, but there was an acquired torticollis, and after surgery you see the difference in the neck size. The length has actually gone up, the torticollis has reversed, and this is the fixation. The odontoid has come back to its normal position. I don't think I have time to show the video. So this is again a patient of rotatory locking which has been corrected, again corrected with doing manual manipulation of the joints. Now this patient came to us a few years back. So he came to KEM, he came like this, no deficits, neck pain, and the neck complete. What had happened was, a couple of years back, someone had hit him badly on the back of the head, and he started developing gradual torticollis. He ignored it for quite some time, and this is what happened. A neglected atlantoaxial rotatory dislocation, and some abnormal bone fusions happened, and he developed this fixed kind of deformity. We did a 3D model of this patient to understand the deformity, because it was a difficult case to treat. We could get a partial reduction, we could realign the joints, and here you see that the torticollis has not reversed completely, but significantly. You see this distance has completely come back to normal, and the patient was actually happy. So this we treated together with Sir in KEM. This is again a recent case that we had done. So you see the torticollis, you see this abnormal bone formation between the occiput and the cervical spine. It's as if this occiput is being supported by this abnormal bone. And then in this patient, we actually did two parts. We did a craniovertebral junction fixation, and then we released the contracture that had happened from the anterior aspect of the neck. This is another deformity that you see sometimes. This is a fixed flexion deformity. This patient was actually holding his head up with the chin to prevent the neck pain. And then we fixed it and he did well. This is again another fixed flexion deformity. You see this patient presented like this. Post-operatively, after manual correction, the neck became long. Sometimes extension is a better position for patients with basilar invagination. And this child was actually holding her head in extension, hyperextension. When she presented to us, this was her complaint. And then we obviously corrected it, reduced it, fixed the joint, and this patient did well. I just take a couple of minutes more. This is a recent publication on Chiari. So what happens in Chiari? We don't see in Chiari with basilar, of course you see the abnormality, you see the atlantoaxial instability, but in patients with no bone anomaly in the craniovertebral junction, it is unstable. How do you see this instability? You do a rotatory imaging. So you see this. This is a patient with mild Chiari with a syringomyelia, no change in atlantodental interval. You see the rotatory images. You see how much of the facet is exposed. This is not normal. The atlas is pretty much just at the rim of the axis. So this is rotatory dislocation, and we have many such images now. See this rotation. You see the atlas is completely just out of the facet of axis. This is rotatory dislocation that you see in patients with Chiari. And here you see there is no change in the atlantodental interval, but if you see this, do this dynamic imaging, you will see the abnormality. Now this patient, you see this, very subtle, or maybe no atlantoaxial instability. She's a child. Patient came with torticollis, presenting complaint torticollis, Chiari and a huge syrinx. This is in the immediate post-operative period. You see that the syrinx has started reducing, the Chiari has gone up a little, and the torticollis has completely reversed. I think I've done this 3 months back. Another presenting patient of rotatory atlantoaxial dislocation is spinal kyphoscoliosis. You see, you do a rotatory imaging, you see this, you will see the rotatory atlantoaxial dislocation, and the whole spine is actually remodeling itself to protect the crucial craniovertebral junction and cervicomedullary cord. Now this is the last part, this is a new concept, central atlantoaxial instability. The patient will present with symptoms of CV junction problems, cervicomedullary problems. You're not going to find anything on the scan. First diagnose it, localize it to the craniovertebral junction clinically, and then look at the atlantoaxial region. And you will see this rotatory dislocation. You are interested, they present with an abnormal constellation of signs and symptoms, autonomic signs, orthostatic hypotension, blurring of vision, ringing in the ears. You know, there are a very weird complex of signs. Sometimes these patients are labeled as psychiatric. But if you're able to identify this, this is the result. I will just show you this video. This is a patient from Canada. You see the walk. This is pre-operatively. Just see the walk. See, there is nothing in the CV junction. You see the atlantodental is normal. Facets are okay. This is the rotatory scan. See the dislocation. See the rotatory dislocation. Okay, this is the patient. This is just even before discharge. See the change. This is 4 or 5 days post-surgery. See the change in the walk. This is what you're going to be able to achieve if you diagnose correctly atlantoaxial instability. It is a common instability. Do not miss it. Learn to treat atlantoaxial instability, and you will be able to give a good new life to the patient. Thank you very much.
Thank you, Abhidha, for excellent talk. Any questions or comments?
So, Dr. Abhidha, excellent cases. I think Dr. Jayesh mentioned that about the developmental part of C1, C2 and craniovertebral junction. So what is your youngest stage when you start operating such patients, and your rate of neurological complications? Because these are two pertaining questions.
So the youngest patient I have operated is 2.5 years old, but the youngest patient Professor Goel has operated is 3 months old. So I was also assisting the case, so I was also there in the patient, but 3 months is the one that we've operated. Complications, the major complication is vertebral artery injury. If you have a vertebral artery injury, a younger patient will tolerate it. Quite well, it will be tolerated. Don't panic if you have a vertebral artery injury, but occasionally, yes, we have had problems with vertebral artery injury. They sometimes get up normally, but if you have an injury, watch them for 48 hours. Sudden deterioration might happen. That is one. Second is we've had a couple of patients who developed PCA infarcts with the vertebral artery injury, and developed 2 patients we have blindness. One patient blindness did not improve. One patient improved partially in blindness. But many a times vertebral artery injury is tolerated well. There are occasions where we have actually damaged both the sides and the patient has done well. The younger the patient, the toleration will be better.
Thank you, Abhidha. Now we may invite Dr. Kshitij Choudhary for his talk on video transoral release of irreducible BI with posterior fixation.
Thank you very much for having me. Thank you, Dr. Rakesh, Dr. Ajay. Yesterday, I think, I don't know how many of you heard the presentation. So we choose this procedure, connected?
Just switch it on.
Hold on. Yeah. So, so this is kind of a release from the anterior aspect. So we saw yesterday, I discussed about the facetal release, and Dr. Goel's work is pioneering in this, where the focus shifted on the facet joint, as Dr. Abhidha just mentioned. So there are multiple ways of releasing the facet joints. Posterior is the more conventional routine way of doing it, and there are certain situations where we prefer an anterior to a posterior release, and that has a lot to do with how much dysmorphia is there in the facet joints. The more the dysmorphic the facet joints, the more misaligned the facet joints in terms of their visual trajectory from posterior approach reaching the joint. If the joint is vertical, then trying to reach its, I think for orthopedic surgeons, it's easy to visualize a spondyloptosis model where you have an L5-S1 spondyloptosis and you're trying to get to the L5-S1 disc, which is vertical, right in front of the sacrum. So that kind of same analogy applies to some of the severe BIs where you have almost a vertical sagittal joint inclination. So in those cases, we like to do this kind of a procedure where it is an anterior release. I'll play this thing, right? So these are the displacements. You have that odontoid gone vertically. The odontoid is also retroflexed. And in the coronal plane also it is abnormal. So there are three-dimensional deformities in this region with these kind of abnormal facet dislocations. So when any deformity happens, for orthopedic surgeons it is easy to understand a deformity like congenital talipes equinovarus, right? When we do releases of the foot deformity, where do we do the releases? Nowadays they are not doing the release, but just the releases were posteromedial, right, in the concavity of that CTEV. So the same thing here, when you have a kyphosis, the tight structures are all anterior. So it's not just the facet joints, but there are a lot of structures in the front that keep that joint or the deformity in place. These are the longus colli, longus capitis. The alar ligament is actually stretched, but the capsule, the anterior capsular structures, so a lot of soft tissues in the front are stretched along with these bony deformities. So what we do during the release is to remove the anterior contracted structures that gets the odontoid down, and we also remove anything and everything that is in front of the odontoid process. So whatever is going to block that odontoid from moving in front, we are going to remove it. So if you look at normal CT scans and MRIs, the place for the tip of the odontoid is below the basion, right? So that's the usual anatomy. But in what happens in many basilar invaginations is that place is occupied by the anterior C1 arch. So next time you see these cases, see where the position of the basion is. The C1 is assimilated, and the way the C1 assimilates is that it assimilates and sticks to the place where the odontoid tip should be, right? On a lot of cases, obviously not all of cases. So then you remove all the predental tissue and the anterior C1 arch, which gives you that space for that odontoid to move forward. So this is just a graphic representation of how those muscles are cut in the front, and you kind of remove the bone that from the front. So this is just an exposure for transoral odontoid resection, but you're not doing a odontoid resection. So you're just defining the borders of the odontoid, the top, the side, and it takes about 15 minutes to do this. There are a lot of neurosurgeons in the audience. Many of them must be doing transoral surgeries, but this is not a very long procedure like a transoral odontoid resection. And then the step, and I'll show this case in the case presentation, the step-by-step how the reductions happen. So what basically the release does is gets the odontoid down. Now if you can see this case, there's no way for that odontoid to move in its normal position because that bone is going to block it. The odontoid is not retroflexed, it's anti-flexed. So if you remove this bone from the front, this is going to come in the front like that. So that's what the video does, so the video will show. And the rest of the reduction is from the posterior approach on the implants. So you do DCER like how Dr. Sharat Chandra does or how Abumi does. Whichever way you do it, you get the reduction from the back. So this is an example, and I have shown examples yesterday. So we'll go to the video. Okay. So the usual, now this patient is under traction, right? So as the patient is under traction and under fluoroscopic vision, as you do the release sequentially, you will see that odontoid coming out of the foramen magnum. And that was very surprising when we first started doing it. Obviously, this is not my idea. Dr. Lahiri started doing this, I think 15 years back after one of his friends from China published a paper. So here is the midline exposure, subperiosteal, And then as you go on the side, you'll see that contracted longus colli. And as you cut it with a bovie, you see the separation. It just goes apart. And that itself is an exposure for the facet joint from the front. So as you cut that, you will see the facet joint, and that because the Abhidha showed nice CT scans where you see that lateral mass right in front of the C2, you can nibble that off a bit, burr that off so that you have some access to the joint, and then you can put like a Penfield or some paddle shaver or something in the front to kind of distract that joint, wiggle it, release all the adhesions and from the front. Now, this all the time when you are looking at the lateral picture on the C-arm, every time as you do the release gradually, the thing keeps coming down and down, right? So this is the anterior C1 arch, or whatever the assimilated C1 arch, and you burr that down enough for you to see the tip and the sides. And then you take a small curette, an angle curette, palpate the edges of the odontoid from all sides, and make sure that that odontoid has room for that for it to move forward when you turn the patient in the prone position. So that's the drilling. So do I have a pointer? I can or show this. No. Okay, here, yeah. So this is the odontoid, right? So I'm just removing the bone that is in front of the odontoid, and then you will be able to feel the side and the So here, so on the lateral picture, you can see if I put a curette right there on the C-arm, you will see that curette. Now assessing reductions on the lateral view, as you may have experienced in the OR when there are deformities, it's difficult to judge what is happening to the craniovertebral area because it's not like normal anatomy. It's not like C1, C2 subluxation where you see a nice anterior arch and ADI distance reducing and all. So with deformities, it's difficult to judge. And I'll show in the case how we judge it. So that's the kind of a periosteum I'm putting in the joint, and then releasing it, putting it inside and wiggling it. On the C-arm, you will be able to see that that direction is vertical. And that direction to get is easier in that retropharyngeal approach because you're going tangentially like that from bottom. But then we don't prefer retropharyngeal approaches, we prefer this. So this is what you achieve. So let me pause here. What has happened? Just see what has happened. This patient had a previous fixation. Sorry. This patient had a previous fixation from the back, right? And unfortunately fixed in a malaligned position. Ajay yesterday spoke about, asked a question about patients do well even if we fix them in malaligned, so-called partial reduction, and they do well, and why do we need to go for a perfect alignment? And I gave him that answer yesterday. So this patient, same thing, fixed sort of better than what he was, improved neurologically. That neurological improvement lasted for 3 to 6 months or something, and then he deteriorated again, right? So we don't see any implant loosening, we don't see any loss of, like gross loss of malalignment, but you can see this reduction you can't really accept for even if the patient has recovered neurologically in the first few months, because this is a child and it's not going to be like a long-lasting problem that the patient can live with. So here, obviously, when things are fixed in the back and it's 6 months and the fusion is sort of consolidating, you would think that you would do a transoral odontoid resection now because that's the only choice left. Here what we did, we took down the implants as a first stage, removed the implants, took down the fusion mass from the back. So the fusion was only at the posterior, not in the facet joints. Removed the implants, put better screws from the back, occipital plate, but didn't connect the rods, went in front, did a release. You can see the bone that we have removed from the front. The odontoid came down, turned the patient back, and then realigned it. So this was possible without doing an odontoid resection even at a later stage.
Can you sum up, Dr. Kshitij?
I'm done.
Yeah, okay.
Thank you.
Thank you. Nice presentation. Now we would like to call Dr. Bharat Dave for primary C1, C2 osteoarthritis, natural history and management.
So was that necessary to do the foramen magnum? Okay.
It is worth. But then we were surprised that even after 6 months of this surgery, we were able to get the realignment so well. We didn't know that.
Sir,
From
anything you have put in the joint from anteriorly?
No, I haven't.
Okay, thank you.
So it was not very rock solid, but there was bridging bone. So it was not like very solid bone that we needed to do something. It came out with nibbler. Just like take a nibbler and then it got disconnected.
No, when you went back again posteriorly putting the
Yeah, that's what. So it was all posterior, not facetal fusion.
Okay.
Now to take down a facetal fusion is much, much harder because you have VAs and everything there. But if you have just posterior, like many times they put like a graft at the back and not in the facet, that's what this case was. So from the occiput to C2, you could put a nibbler and then just disconnect the occiput from C2.
Thank you.
Okay, thank you. Friends, seniors, colleagues, the topic is osteoarthritis, CMC, sorry, C1, C2. How many of you know this condition? Can we have the raise of hand? Oh, most of you. So then I do not need to be here then. Still, I will try to justify. A patient with severe occipital headache, normal brain MRI, with failed treatment for migraine, will come to the clinic, may be referred to psychiatrist as well, because many of the orthopods, they do not know the condition, and which has impact the significant quality of life. But how many of you know there is autofusion that occurs in this C1, C2 OA? Can we have the raise of hand? Oh, okay, then I do not need to be here, Rakesh bhai. I think the summary is there already. So it is the most mobile. Now I will tell something more as well. 50% rotation occurs. It's a huge demand joint. The price of the mobility is degeneration, as we all know. So the classic pattern is like what we see in the routine osteoarthritis, like cartilage loss, sclerosis, osteophyte formation, and then leads to instability. The risk factor considered to be age more than 60, mainly female patient. Have you all tried to correlate that with the head lifting? Anybody has found that the head lifting leads to the OA? Have you? Okay, we did not come across that correlation as well. So that is something which is against the routine finding, but then there is autofusion. So the natural history is what? There is rotation that is painful, suboccipital headache occurs, then there is unilateral persistent pain, patient comes with the holding the head, maybe there may be instability as well, and if the significant instability is there may be myelopathy as well. The classic will be the rotation on unilateral would be restricted, and that is something which is the sort of, I would say, diagnostic criteria for the C1, C2 OA. So pain progression is much faster than the instability. That is something which we have observed in our studies as well. Differential diagnosis, we all know this, could be migraine, cervical spondylosis, C2. Sometimes we have seen the tumor arising as well, giving rise to same symptom. And currently we are kindly of geriatric practice. We do see insufficiency fracture of C2, giving rise to the classic settling and then giving rise to the occipital headache as well. So imaging, the most important aspect is the open mouth view. A good radiographer who should be experienced enough to tell you, to show you the C1, C2 OA. The left one is not the good one, the right one is a good one. You have to have the flexion extension X-ray as a primary diagnostic tool for C1, C2. So somebody comes with that, you have to do that. The most important thing is in the lumbar and cervical study. In the lumbar study, we always do the coronal to see the facet, to see the SI joint. Similarly, to see the cervical studies, have to include the coronal in order to diagnose C1, C2, OA, otherwise you will miss it. So this has to be included in the cervical spine primary study of the cervical MRI. And that's what something which can be seen as MRI, bone edema, even facet effusion there as well. So that is something which is classic, and you need to have all the pictures as well. And obviously the CT scan will be showing the bony. So the MRI is for the bone edema and coronals are must, and CT diagnose the disease, but MRI exclude the other diagnoses like the rheumatoid and all that. So radiographic evaluation, as you can see, from grade 1 to joint destruction that occurs, so won't go into detail because most of you know the condition. Management. So we have confirmed the diagnosis by X-ray, MRI, CT. Explain that this is a benign condition because most of these patients will come crying, holding the head, and then they will have night disturb, sleep disturb as well. So I advise them to have this cervical collar 23 hours out of 24 hours. Meaning when they are for the bath, shower, they only remove them. And if you advise this for good few weeks, the fibrous union will occur. And then usually it becomes self-limiting condition. So make sure that we give the clear-cut message to this patient that you use it and you remove only when you have shower. Long night analgesics to be given, maybe paracetamol simple, and injection C1, C2 intraarticular. Now we had C1, C2 intraarticular injection, that was a standard protocol which we were giving earlier. And we had this patient who will put in the prone, we will align the C1, C2, we'll have the C-arm, right, left angulation, medial lateral angulation, and then we will inject posteriorly into the C1, C2 joint. But we had one mishappen, and then it went into the dura, and then we had the patient, we had to intubate. And after 6 hours, patient was extubated and went home in the same day evening. So that is what led us to think twice that, can we continue? Does anyone inject into the greater occipital now? So we have few hands. That's great. So that is something which was the mishap led to the diagnosis and the alternative medicine as well. So it will confirm two things. It will confirm the diagnosis and it will give the confidence to the treatment, and you are buying the time while the autofusion fibrous union occurs to this group of patients. So this is something which is very important. So what we do, central knuckle line 2 centimeter lateral, aspirate so that you are not injecting into the occipital artery, and that's where the greater occipital nerve is there. Patient will have instant pain relief. And then patient will become blind follower of yours, and then they will follow your treatment protocol for 23 out of 24 hours. So that is something which is just a tip that, that's a clinical tip. So that's something, and this is the case of autofusion, as you can see, open mouth view, and you can see that complete autofusion has occurred on the CT scan. So this is something we have n number of cases showing this as well. And those cases where you will see the sclerosed in the MRI as well, so sclerosed joint. So one of these case, 78-year, me and Ahmedabad were party to this patient, and he had CA prostate. And I'm sure, friends, you all do not read just reports. And this was reported as tuberculous spondylitis or rheumatoid arthritis. And because patient had CA prostate, was sent for all the investigation as well. And eventually, me and him, we injected him, and then he improved. And at 78, his pain had practically, was severe enough, but then it led to autofusion as well afterwards. And he's at the moment symptom-free, as far as I remember. He keeps calling me, during the Diwali period as well. Me and Amit, we are, sort of treating him. So this is something just to share. So they become blind follower, and then probably, your patient, sort of sent to you as well. So when to operate, our study failed considered treatment at least for 3 months at least, with the instability, with the significant pain. And if there is myelopathy, obviously you would operate them early. And there are many ways you can operate. Transarticular, if it is reducible, you can have this, the C1, C2 fusion as well. So it's a single observational study, single arm, 220 to 221 retrospective and 21 to 25 prospective study. We had 232 patients. So when I go to many meetings, and sometimes when I talk to, this guy from Vellore, he said, Bharat, I don't see C1, C2A. I said, you must be missing it. And I keep sending, when I get there, I keep sending, look, this is the C1, C2A. I have this in my OPD. So this is something which is not a rare condition, it is uncommon. And I'm sure, it will give you the best of the best treatment as well. So cohort, non-operative, operative, NDI, VASCOR, it is in the publication. recently it will get published as well. So I'm not declaring it, the results as well, but 32 surgical stabilization and 200 were the non-surgical. And these are the key findings as well. So these are the pain and disability scores as well. So 86.2% from the conservative group had good relief without surgical arthrodesis required. So take-home message is C1, C2 is underdiagnosed. Occipital headache may originate from the atlantoaxial joint, that has to be taken care. Rather to be included in the CT scan is best diagnostic investigation, but we always do MRI first and then the CT. Most of the patient improve without surgery, and carefully selected patient, it gives C1, C2 fusion, provides excellent pain relief. Nature often performs own fusion, which you don't see in many mobile joints, but this is one of the most mobile joint which immobilization is the key in the initial first few months. While painful, joint is to progress towards spontaneous ankylosis, converting into painless to painless stiff joint, painful joint to painless stiff joint. That is something which is the message. So severe clinical experience, rigid, rather semi-rigid immobilization in the first few months, and that leads to fibrous fusion. C1, C2 OA reminds us that spine surgery is challenge, often not performing the operation, but it is recognizing the diagnosis. I'm sure that is something which is a message to be taken by the esteemed crowd as well. Thank you very much for patience hearing.
Thank you, Bharat. Even I prefer Philadelphia for some time initially.
Yeah.
Then cervical collar with chin rest. Okay, that prevents some rotation, not simple soft cervical.
Yeah. The compliance is to be considered first, because they have to wear it even at night. When they wake up in the morning, if they had the collar on, they usually wake up with painless. Yes, sir, please. Kshitij.
Very nice talk for a very under-recognized condition actually. Many
Thanks,
people miss
thanks.
it. For the collar issue, I use a Miami J collar or an Aspen collar which is available in Mumbai. So it's more comfortable compared to Philadelphia collar. With the same logic as sir just mentioned. But it's interesting that you are getting good results with soft collar. So I'll try next time, because I always thought that we want the rotation to be mobile.
Yeah, the soft one is not the complete spongy one. The one with in the middle, they have that plastic part with the holes in it.
Okay.
Not the complete soft one with the spongy one. The spongy one is nothing, no good.
Oh, okay.
But the one with the plastic
So
in the
the
middle.
hard one, the sort of harder version.
Well, it's semi.
So another question I have about, your predictability of MRI diagnosing the pain source. Would the edema, like you must have seen many osteoarthritis without the edema, would they also are symptomatic or respond to the injection the same way as somebody with more?
To be honest with you, we have not had the follow-up MRI. After
No, I'm talking about just clinical response, that a person more likely to respond to injection is someone who has the bone marrow edema and the synovitis.
You can see the autofusion occurring, the sclerosis developing in the MRI. So that is something, but we have not evaluated after the injection, then the repeat MRI. But that's a food for thought.
Okay.
One question. What were the amount of this?
Yeah, sorry, Randeep.
I saw most of the cases were unilateral.
Yes.
So could you find any reason for the
No.
unilateral?
We have already done the study of the angle as well, measurement. That is again second publication. I did not discuss that here either, because I wanted to highlight the condition. But yes, that is something we have found only unilateral.
Only unilateral.
Another thing which we have not seen yet, I do not know how many of you have seen, OA.
Yeah.
I have not seen a single, except primary OA I have not seen.
And second, about the diagnostic local, whether it was a temporary cure or a permanent?
It is temporary.
It was only diagnostic?
It is no, diagnostic and therapeutic as well. It will last a little longer. Right. Because if you have injected the steroid as well.
So on MR stir coronal image, you will see brighten area. Those patients respond well. That's
Yeah, hello. Dr. Dubey, as usual, eye opening. This is same thing we are talking about rheumatoid arthritis, or it's a separate OA, or it is one of the type, or
no, rheumatoid patients are excluded.
This is not included.
No, these are primary osteoarthritis, no secondary cause.
You investigate RA factors and those kind of.
Yes. Okay. All that's been excluded. No other joint pain. Primary, only single unilateral pain.
Okay.
the spacer surgery to have that gap, would you do?
We haven't done. We put the bone graft posteriorly. We haven't done any of this.
I mean, I also just do the usual
Yeah,
fusion,
right.
but there are some reports about the spacers giving more room for the.
You can
No.
belt the cat in many ways.
No, spacers are not necessary. Actually, denude it. See, what happens is when you open these joints, you already see that fragments of, loose fixation. That attempt is going on. So all you do is curate that, put the bone chips inside and fix it.
Bharat bhai, good morning. Is it associated with lifestyle issues or it is just idiopathic C1, C2
No, so
osteoarthritis?
our study did not reveal that with the lifestyle issue.
Never
The
like
gentleman, the
excessive-
gentleman whose example I shown, architect, office work, nothing. So he didn't. So no weight lifting on the head as well was correlated as well. Thank you.
We have a small announcement.
Now we call Dr. Abhay Nene for special consideration in pediatric CV junction.
Sir, just a minute. The PPT is ready. We have just a small announcement. There's one car, GG38BF4066. The owner should connect the registration ASAP. Thank you.
So working where I am, I'm like a general spine surgeon thrown into a sea of difficult situations. This kind of a situation keeps coming at Wadia Hospital almost once every 15 days. It's a really small child, and you can't make out much what's going on because I'm not a specialist like the previous speakers were. So I'm asking myself all these questions. So we're restricting to children less than 5 years of age who come with a CVJ, symptomatic CVJ problem. And that literally happens once or twice a month at the place I'm working. And I must acknowledge Kshitij's work along with Arjun. This actually is entirely their work because they've been working hard on this topic, and we've got a few publications thanks to them. So the problem with these really small kids are that they are like miniature. They're really small. They've got a huge head. The joint is hypermobile, and there's no muscle mass there. At the same time, they are symptomatic. So you have to do something with them. You can't just immobilize or can't hang around. You got to go and act. And of course, there are poor anesthesia risks. So with that kind of a situation, I'm going to just pick on 5 key points which I thought could be covered in 10 minutes, which would be takeaway messages from this presentation. The first is that you got to be suspicious because they often they are not even walkers. So you can't even make out that they have neurology. So, for example, when the child comes with a syndrome, you got to know which syndromes are associated with CVJ anomalies. So, typically Morquio's, and that runs in families, and of course Downs. And then there are these funny named syndromes. We have a whole book of syndromes at Wadia Hospital that's that thick. And it's for nerds, not for us, but you got to refer back to it every time, someone who looks facially dysmorphic comes to you, because that could be associated with a possible, progressive CVJ anomaly. The other is there's no communication because these guys come from all over the world, all over the country. And of course, a child can't give you any history. So you've got to rely on the relatively unreliable history of the parents. And then it's very difficult to interpret x-rays and scans. So that becomes your first problem. So suspicion is the first takeaway message. For example, when this child came in, okay, it's like a less than 2-year-old child with a known Morquio's history. Even his brother had Morquio. And then they report of difficulty in walking since 3 weeks. And you're asking, was he even a walker? And you have to confirm that he was a walker who then became a non-walker. And then exaggerated reflexes are not so uncommon in children regardless. So you got to try and be communicative with the parents, and possibly you got to rely on the mother's history because she's the best person to say whether this non-walking history is a reality or it's just that the child has not reached the milestones. And then when you get an X-ray, you're not completely sure of what's going on. So you ask yourself to get an MRI scan. So once again, you don't really make out unless you push into a flexion MRI. And now, so many of us are worried in these whether a flexion MRI can trigger a problem. But there's now data and publications to prove that gradually flexed MRI is safe indeed in these kids, and that's the only one that can really point out that the problem is there. And then, of course, you get a CT, and the CT becomes your best friend. And this is where, definition of the pathoanatomy. Of course, Jayesh gave a fantastic talk. Jayesh, congratulations, really eye-opener on the anatomy and how you study it. But we thought that we had done a lot of work, and thank you Kshitij and Arjun, because you all did this work. It's about how you can derive, more information from the CT scan. So as orthopedic surgeons, we're just used to looking at plates, but it's really much more than that. So the first step is, of course, to look at films and just, try to identify from the two-dimensional films what you can see. And then most of our centers have packs. So you go down to the CT scan, the suite, and then try to sit with the radiologists who are often not themselves too bright on this. But you go through the images and try to, work it around your head. And then you put this, entire thing in a, in a multi-planar kind of a mode where you can see 3 dimensions at one go. And all this has to be done for you to be able to get all the information. You can then put this into a volume rendering. And I think Horos is the software that we've been using. And then you start, getting a 3D anatomy. So if you have a case like this where you're really lost on, what the anatomic landmarks could be and where, where the tissues could be, you can finally end up with a rendering like this, which can give you a far better, clinical judgment. And in very rare cases, the case which we did in Gujarat, actually in Surat, you then get a 3D printed model and actually do a surgery on that 3D printed model to know where, which bone is going to protrude, because you don't know where this is coming from. So, of course, not C1, C2, but in rare cases, I rely on these 3D models, otherwise not so much. So if you get a case like that, you first get a regular CT scan, do a DICOM manipulation, then do a volume rendering to get a 3D kind of a model, and then you go through the multiplanar images. So you'll get to see the pathoanatomy. Remember, as you were told before, that if there's a bony anomaly, there's a high chance there's a neural and a vascular anomaly. So you've got to get your head around all this. And then look for fixation anchors. As an orthopod, I'm only looking at which bone I can put a screw in. So if I don't have this, I don't have that answer. And intraop, it's very difficult to know. And remember, there's a lot of cartilage there. In a child who's less than 5 years of age, it's all cartilage, right? So the next is to look for innovative bone anchors. And this is where our orthopedic skills come in, because you are not going to be finding bone everywhere. As you can see here, there's really, you don't see much. So you've got to be, working with all these implants. And unfortunately, as we've evolved as surgeons, we've just been heavily screw reliant. And you've got to think out of the box, learn to use, all these. I think laminar screws have been a big escape route for us, because the C2 lamina is always big and, it's formed very early in life. So putting big screws there has been one of the go-tos. Mercilin tapes sometimes, but more often we use hooks, not that often, but hooks is a salvage. Many of us don't even know how these look, how they are deployed, what are the different types of hooks. So you got to study these and, get your armamentarium maximized before you get into these cases. This is a case of a laminar screw. You can see the lamina is always thick and there's a big bounty of a spinous process of the C2. But what we really rely on is sublaminar wires. And again, it's a lost art, and it's something that you got to be, doing it more and more, because it's a rescue wire. It's not like the entire construct is based on wires. But at one place where the screw doesn't fit in, the wire will get a good grab, like an extracortical grab, and give you a lot of solace. And you just need to know the technique, and we call it, we say it's bend it like Bhojraj. Like bend the wire in a way that's going to slip in nicely, and along with the movement of your wrist. Err on bigger fixations. Again, you heard it from Jayesh that the cartilage is not the bone is not well developed. So you may find that I can get a C1, C2 fixation on your CT scan rendering. But intraoperatively, you always want to err, for a bigger fixation. I'm saying occipitocervical fixation rather than C1, C2 fixation, because the bones are dysplastic. It's hard to judge reduction, hard to judge the placement of your anchors. For example, in this case, it's a congenital fully reducible AAD, and you would want to fix C1, C2. So you get, all the landmarks, and then you find that the vertebral artery is high riding, which happens in most of the cases. So you do this kind of complicated fixation, get a screw wherever you can, and do an occipitocervical fixation. Here's another one. You can see topsy-turvy rod screws everywhere. It's like, those sacroiliac fixations that we do. But as long as it's stable and you immobilize the child, because they're really small, you don't want to leave them alone, and then watch them through. So here's a case again, which we thought was a fully reducible AAD. So we tried to put C1, C2 screws, which looked good on imaging intraoperatively. But remember, it's hazardous to rely on this completely. And see what happened. She had a minor fall at home, and this whole thing slipped, because of course those screws were not entirely in the place where they were supposed to be. and the place where they were supposed to be was not well developed bone. So luckily we could get away with conservative treatment. Here's another one where we could not get a good fix because of various reasons, mainly arterial. So this child had a unilateral fixation, and promptly after a fall came down with a loosening. So the message here is that you got to put in as much as you can, span as much bone as you can, rather than do small segmental fixations. And then of course follow up for complications, because they don't really fuse that quickly, and these fixations are quite tacky. Right, so here's a well-done AAD according to me. This was quite recently done by Dr. Arjun and myself, and we thought we got away, but soon enough the child, developed neurological deficit while she was in the ward. And you see what looks good on the X-ray actually shows a medialized screw, because you couldn't, detect it intra-op, and then we had to go back in and redo it like this, and the child is now recovering, but it's a long haul. So just to wrap up, in the last, I'm going to say 7 years, we've had 11 kids who we've operated under the age of 5 years of age. And if you see that most of them are syndromic, like there's no one almost who's non-syndromic. And most of our fixations have been occipitocervical fixations, because that's what you want to err on. And we've had complications which we've had to rescue. And mostly these complications come with neurological worsening. So that's my end game. You got to suspect the pathology in these small kids, talk to the parents, look for syndromes, define pathoanatomy with as much radiological data as you can get, learn to use the Horos, I've learned it from Kshitij, and use innovative bone anchors. That's your strength as an orthopedic surgeon. Err on bigger fixations, as much as possible occipitocervical rather than segmental C1, C2, and then please follow up these patients for complications. Thank you.
Okay. Now we call Dr. Amit Jala for pediatric cervical spine cases.
So, and the length, 6.
Because it's a good question, but it's very variable. Like one screw.
6.
One screw could be 6, the other could be 12.
Okay.
So you've got to measure it on hand.
So I'm not going to give a talk.
Yeah. Thank you.
And in pediatric, there is a lot of C1, C2 that you have seen, all syndromic and Downs. So I'm an orthopedic surgeon. I'm going to show you some other cases of pediatrics, all right? So not C1, maybe occipitocervical only, or cervical only, but not pertaining to C1, C2, traumatic. But I will like the inputs of all the stalwarts in the audience who are here. And it's not a lecture, how to manage such a cases, and that's what is very important if I can get an interaction.
So Dr. Abhay, Nene, till then. So how many anchors you would like to get below occiput, like at least 2 level or?
At least 2 levels. The problem is that C3 is Mickey Mouse. Where you put in the C3 is a waste, but there's no other place. So we sometimes get 3 on C2, and then we get a wire or a tape at C3, because C3 pedicles are not existent. C3 lateral mass is like a Mickey Mouse bone. So wire in C3, sometimes translaminar screw in C3, which also is a flaw.
Just want to add the discussion. Yeah, fantastic presentation. So just want to share my experience on the pediatric things. 2 things want to highlight. One, the lateral mass, sometimes it is less than 4 millimeter, very narrow, particularly less than 3 years of age. So 2.5 millimeter screw is available. So 2.5 millimeter screw, many companies like Xeon, JSCO, they have available. So you can keep it in your OT. If it is failed, start with 2.5, then you may try 3.5. So for less than 5 years of age, 2.5 is fantastic, we can try. Second, just would like to, if you construct a long in pediatric age, 3 or 5 years of age, you keep C3, C4, occiput. Now, just imagine it goes 12 years of boy, 13 years of, after 10 years of boy, you fix the posterior part and the anterior part is again growing. Many cases we have seen that it's, either it's come up with failure of construct, either come with some other kind of instability or this kind of neck deformity. So we'll discuss later on this kind of cases also. This is some challenge.
So I think it was very well told by the Abhay in that in pediatric cases less than 5 years, you have to have all the armamentariums ready because you don't know what is going to help you during the surgery. And you have to be much more innovative rather than what you are having a standard constructs that you have. So this is one patient which I had, 4 years male, had a history of fall while playing with a quadriplegia. So just a question to everyone, how would you manage? Quadriplegia, 4 years, conserve versus surgery. Surgery. So this is what I had in 2012. This patient was in 2012 that I had in the patient. So what type of surgery now? Again, you know that it is C1, C2. So what type of surgery? What implants will you use?
Yeah, need more info, sir. MRI, CT.
Okay, I require this MRI. This is the MRI. No syndrome. Absolutely normal. That's a CT. Yes, Kshitij. I know that I don't have a horrors with me now.
Even if
Whatever information I have, you have to tell me.
So even if you don't have the more useful CT is what the lateral pillars show rather than the midline, because like the whole thing went onto the facet joints. So you see the facet joints, how they are. So from biomechanical point of view, like I showed yesterday, there are 3 things: instability, deformity, or compression. This is an instability issue. This is not a deformity issue. So requires stabilization. Question is going to be, how do you stabilize? So where the screw anchors will go is what your assessment is going to be.
Yeah.
It will be a C1, C2 fusion.
C1, do you think it is a normal?
I don't know. So we have to see that side. If we can't get C1
Yeah.
because of dysmorphia or whatever reason, then you go to occiput.
Okay.
So in X-ray you have shown that there was atlantoaxial dislocation.
Yes.
So it means there is a C1 ring is mobile here because in
Yes.
this position it is reduced. So
Posterior C1
definitely
ring, where is the posterior C? That is C2 posterior spinous process?
Posterior C1 arch.
C1
C1
back.
arch. You can see the C1 arch.
But on this cut, you don't see the C1 arch, that side. So it's like if it is like a hemi arch or what, there should be an arch on the first image as well. Like the sagittal image.
Yeah, this is sagittal, but you can see this is the arch.
So there is a midline defect in the posterior
Yes.
C1 arch?
Yes, yes.
So that you can't see it in that midline image.
Yes.
You can see it on the lateral side.
Okay. So fixation, 4 years.
C1, C2 fixation. Or occiput C2 fixation.
Or occiput C2.
The lamina will take because the lamina looks quite thick. So if you can't get C2, you'll get C2 lamina screw.
So everyone
Question is
goes
going to
for
be-
Yeah.
C1, C2 or occiput C1.
I would like to go C1, C2 with lateral connector because we can see the posterior cleft.
You will use screws in C2
C1, C2
and
lateral
C1,
mass,
C2.
then lateral connector.
Okay. So this is, yeah, you can do sublaminar option also. Because I had kept all these things ready with me. I had also kept these lateral mass screws as well as, but
So there
in
is one
4
problem.
years,
There is one problem in sublaminar. Like, are you going to get that C1 reduction? And what kind of fixation are you going to get in C1 with sublaminar? With a bifid arch and everything. So it will be, you are talking occiput or cervical? Sublaminar. So then? That's what. No? See na, between the
C1.
And forget the defect. You can't put a wire and behind
Wire.
C1 because it's
You cannot
with that
pull also
dislocation-
there.
Because of that dislocation, you won't be able to pass.
You will not be able to pass, and if you pull, it will pull the.
You will damage the cord if you pass it in this position. So it's not. It's arch in wire in C1 is
C1
dangerous.
is not possible, exactly.
Dangerous.
So that was the main thing that I
Occiput
wanted.
or cervical you can
so
do
we
wire.
had to do an occiput or cervical. I could not pass the lateral mass screws there at that time. This is way back. I am talking about.
that, you will kill the patient. If you even attempt it. So, people try to put it and they are not able to put it and then they give up. But that itself will damage the patient. So don't even try it.
So I never tried it. I never tried it. I never wanted it because C1 was already broken. And at that time, 2011-12, we were not doing C1 in pediatrics. So I had to resort to other alternatives which I did not have. And then I went just a rod which I had bent with the occipital wiring and the C2 wiring. And this is what I did. This is in 2012, that the cases of 2012. Okay. So coming to that's the follow-up patient improved, the same patient. Coming to the next case. Again, 4-year male, history of fall while playing, quadriplegia. All are C1, C2 experts now.
So first MRI. First, I would like to go for MRI.
What do you think in MRI?
Whether there is a...
It's not...
MRI means just to see that there is of course, there is a bilateral facet dislocation.
Okay, I'll provide you with the MRI.
Yeah, exactly. So there is a central compression now from anterior compression. And of course, there is we can see, assuming that in the CT, it will show bilateral lock facet. So I would go for APA, anterior release, followed by posterior fusion, and then convert anteriorly, and then anterior fusion. So APA, 360.
In 4 years, child.
Yeah,
we are talking about a 4-year child with 3 surgeries.
There is no other option also, no?
No, there is no anterior compression. You can just go from back, release facet dislocation, and at least 2 above, 2 below anchor.
What anchors?
Yeah, lateral
problem
mass.
is the anchors in 4 years, not doing the decompression or a release.
We get CT, smaller lateral mass screws it should take at 4 years old.
Anterior only. You know the plate of for 4 years is our adult plate doesn't fit that. Doesn't fit the anterior in 4 years. So
locking metacarpal plate can be used sometimes.
So what will you do in this case? Of course, close reduction and anterior fixation. Yeah, so you have to realign immediately. You have to realign immediately. So,
unless you were able to get, this is again 2010 or what?
this is 2019. This is 2019.
Yes, yesterday for our oration in Bombay Spine Society, Dr. Jala presented his journey over last, 30 years?
36 years.
And I could identify somewhere in the middle, during my residency. So, yeah, but it would be, time would be first important. So I'll try to get a reduction first if it is possible. Otherwise, you're going to spend a day or two deciding what to do for it first.
Okay. Yes, Ajay.
There is a technical...
What will you do?
So you are the best. What you
no,
did?
No, I am not. I am not the best. I was so many times confused what should be done in such cases, and that's why I have brought these cases actually.
Sir, cervical is the plan is the preference of the surgeon. You can do it anteriorly, you can do it posteriorly, you can do chapati. It's the preference completely of the
but
surgeon.
You have to
Everything
have the
gives the result.
You have to have a perspective that you are treating a 4-year child.
So
you want a chapati or not?
For this patient, for me, it is very easy to a posterior and SOS required an anterior. But Bharat sir will 100% do an anterior. 100% anterior. I just wanted to add one more thing in that. The shadow anteriorly is not disc. It is end plate cartilage which is there. So that is again a difficult thing perspective to get it out. It does not come easy as like a disc.
Of course,
So question is going to be, what if you can't put an implant? That's the problem here.
Definitely,
correct?
yes.
So if your lateral masses are big enough to put a screw, then fine.
So I actually did lateral mass screws with
So,
Same thing.
so that is the
I
problem.
could not get 100% reduction. Maybe
But
there is some which is left.
with a lesser.
But I accepted it.
But like Dr. Luhana said that he would do more. I would also agree with him because with small bones to do one level up, one level down may not be like enough.
Yeah, but you can see
hold
that
on
it is all protected posterior. Because you have to protect all these pediatric patients. You cannot just rely on the implants because as Abhay showed you that these implants may look good on the
So
one.
in the past, triple wiring was done. Bowman's triple wiring. So you can add triple wiring to the to the lateral mass fixation because the spinous processes are intact, and you can take rib graft and put the rib graft through the triple wiring and wire the spinous process along with the lateral mass.
Okay, sir. Just
Yes, Dr. Sudhir. Okay.
Sir.
Interfacetal screw you are talking. And
Sir,
that was
just-
I was saying. If you are dealing with the less than 5 years of age, it's very important to at least give 360-degree fusion, because very difficult to keep it 3-month and 6-month collar. This kind of child, they will run away and then all those things.
But actually they are quadriplegic, so they cannot run away.
Oh,
because
this
you are not
patient-
talking
I
about
am not
the
saying
other
about-
aspect. So these patients are quadriplegic.
Sir, I want to ask one curious
Just
question.
last
so
question,
if we
yeah.
can just reduce
One more case.
Yeah, if
Maybe
we can
cut
reduce
down.
reduce before intervening, can we give a Minerva cast to this child and
Yes, you can. After the reduction, but
Yes.
you have to realign. That's fine.
so
Yeah,
what
but
are the
it's a-
chances
Anyway.
that would
It's a ligamentous injury,
Yes, that's
complete
what
ligamentous
You
injury.
have to realign. You have to fix it, and
You have
then
to
you
fix
do.
it.
Yeah, you have to fix
okay,
it, and
so
then
only Minerva cast
No,
not
no.
no, that will
It will
not.
re-dislocate.
2.5 years old child. Was walker, history of fall, became non-walker, could not examine her for neurology because it's impossible. And power was 2 to 3/5, anterior hemivertebra. And then this is the situation. But it was post-traumatic. Abhay.
Can I?
Okay. Okay. No, it's not quadru, it's quadruparesis. Yeah, definitely.
But P plus A for me.
Okay. Posterior plus anterior. 2.5 years old. Okay, I'll not go because he is, I'll go fast, right? You want me to go fast. All right, fine. So this was the CT scan. What we did was, it was an anterior that I did. You can see that's a 5 mm cannula, suction cannula. So body size is that only. It's not that large ones. And then we reduced it. We put the cage anterior. We were able to put one plate very easily, and then we put the second plate also. So this is what that we did. And that's the immediate post-op of the same patient. And patient started actually, sorry.
Sir, which
There are
plate?
one-third tubular plates.
Fantastic.
And the patient is walking, and that's a 3-year post-op of the same patient already walking. And you can see actually the implants are now getting fused.
Fantastic.
I was able to manage everything by anterior. Yes, I was confident of anterior.
Yeah, fantastic. Excellent session. So, more discussion during coffee break. It was an excellent session, fantastic cases. So, we move on to the next session of case-based panel discussion, cervical spine. Dr. Abhay Nene would be taking us cases, and the panelists are Dr. Subir Zaveri, Dr. Gopal Shah, Dr. Niraj Vasavada, please come on front, Dr. Dhruvin Patel is here, Dr. Naveen Patel, Dr. Shailendra instead of Jaimin Shah. Dr. Mukesh Patel, sir. Yes, you stay here. Yeah. Dr. Abhay, Nene, proceed.
No, panelists are here. First, why don't you all come up here, guys? Upar aao nahi? Let them see your faces. અહીંયા બેસો ભાઈ. No? Okay. So I'm actually going to bring the discussion really down. This is a 1 hour session, so I've got like a whole bunch of cases. But let's start with the simplest.
Not 1 hour, 40 minutes.
40 minutes. I'll keep looking at you. As you give a thumbs up, we'll stop. So a simple case for Niraj, a young dentist with an acute lancinating arm pain. Okay. And worsening radiculopathy, and that's the MRI scan. She's the dentist. How do you deal with her in your clinic? Please give the mic to the faculty. One more mic, yeah. Yeah, short history.
And a soft disc, looking like a soft disc. So first, of course, the conservative plan.
And what's your conservative plan?
So we put them on NSAID and maybe, a collar. If
so collar, painkillers, anything else?
Nothing major.
What about you? Would you do anything different? Collar, painkillers?
No, sir, same.
Anyone else does something different?
If the pain is significantly radicular, I would add a short course of steroids.
Short course of oral steroids? Can you give the dosage and duration?
Typically, I give Medrol,
oral methylprednisolone.
8 milligrams 3 times a day for 3 days and then taper it down.
Anyone disagrees with steroids? Someone asked for triceps weakness. Does that make a difference to you? So someone said triceps weakness in the crowd. Yeah. How does that add into your, like grade 1 weakness? I mean, it's not grade 1, it's 4 by 5. If it was 3, would it make a difference?
Yes.
Like you would err on intervention if it was grade 3 left triceps?
Yes, because it's early, you can actually preserve neurology.
Fantastic. So in the panel, does anyone agree with this? That if it's a left hand, non-dominant hand, pro-gravity muscle of a young person, would you operate if it's sir?
So unless, it is completely grade 0 or very flicker kind of a thing, I think it doesn't make much difference in my plan.
So monoradiculopathy or weakness of a single root can be ignored at that point.
But biceps, if it was a biceps, would you ignore it?
Probably in the initial phase, maybe, I don't know. But
good, so this is a great point coming through. Let's take a vote from the audience.
Typically tends to recover over time.
Let's take a vote. Young person, radiculopathy, 1 week old, and grade 3 triceps of the non-dominant hand. Who would err on surgery? Please put your hands up. You have to put your hand up, yeah.
So if it was less than like 3 or 7 days, I would err towards surgery. If it was 3-4 weeks, I wouldn't do surgery.
Yeah, who would not do surgery if it's less than 7 days old triceps grade 1? Please put your hands up. No, grade 3 triceps. Grade 3 by 5. Thadadra sir, તમે કઈ કહેતા નથી. Huh. What did you put your hands up for?
Considering the intensity of the prolapse disc fragment, I will.
You will wait. Sir?
We can wait, and we can try the either root block or conservative.
So I think that message comes through that acute cervical disc with radiculopathy, at least the orthopedic. Jayesh, you would operate? Because neurosurgeons tend to be quite aggressive on these. So what's the funda?
Because it's a monoradiculopathy on one side soft disc, I would just put an endoscope at the back. Full cosmetic, ultra minimal invasive. We just decompress it, the nerve root, and we come back. So patient will happy, I will be happy.
So you would operate?
Yeah, absolutely.
Acute radiculopathy. Can we have a quick show of how many of our neurosurgeons, please put your hands up in the crowd. Okay, keep your hands up. How many of you would not operate this in the first week? Please keep your hands up. So, how many of you would operate? How many neurosurgeons in the crowd would operate for acute radiculopathy, like Jayesh would? Jayesh, you would put your hand up. Sir, your argument for operating early?
There is already neurological deficit. Why one should wait?
But is there a cutoff for your neurological deficit, like grade 4, grade 3, left, right, triceps, biceps, grip?
Clinical and along with the radiology.
No, what I meant is like a right biceps weakness of grade 3.
Yeah.
Would you put in the same bracket as a left triceps weakness of grade 4?
I would.
You would. You also, Jayesh. Okay.
Hello, sir.
Anyone, boss? So counsel correctly, get to know the expectations. That's again a good answer. So I have a deeper question. Yes.
How long you will treat conservatively? Let's suppose we.
How long would you, Niraj, since you started the argument?
So I guess I will give a good time period of 6 to 8 weeks.
6 to 8
and
weeks.
if patient, again as
Sir,
Sudhir
because
said,
posterolateral disc is extremely painful. So
yeah, so that's what I was coming to. Explaining the patient that what we are doing, why we are doing, and if pain is not being tolerated by the patient, there is an option where we can give this surgery. But before surgery, if medicine is also not working, there is one more intervention, which is, as you rightly mentioned, the.
So route was, quick comment.
So I was in Satya Sai Institute and we had a long waiting list of almost 4 months to 6 months. And so many acute cases, we just used to give them medicines and we'll give them the date and we'll tell them that if you deteriorate, come fast. Our experience shows that more than 80 to 90% they recover in 6 to 8 months, not 6 to 8 weeks. It takes a long time for them to recover also.
Yeah. There's there's an NEJM article, overwhelming evidence that most of them recover. So I think the argument has been sorted. But like was said, that if the patient wants early recovery and all that, how many of you in the crowd, please put your hands up, believe that if you operate early, the chance of neurological improvement is better than if you sat on it? Put your hands up. Bharat bhai, have you seen that? Like if you operate early, they get back their strength much faster, and if you don't, they just hang around. Kshitij? Ask, you ask.
If this was their own disc, how many would choose surgery?
Okay, if you have a cervical disc with radiculopathy, you would choose surgery. And who would be your surgeon? Rakesh, what do you do? You're going to be the surgeon.
I'm not talking about pain, but talking about deficit. Like classically C4-5 palsy, deltoid palsy, I would offer surgery on even day 1.
Deltoid biceps.
Deltoid
yes.
biceps. Major muscle weakness, I would like C81, you see drummer.
That's a good answer. That's a functional muscle,
yes,
right?
But sensory radiculopathy, I would not operate.
And triceps?
Triceps, okay, acceptable.
Like I personally think triceps like EHL weakness. It just notifies that it's a nerve pain, but you don't deal with it because we hardly ever use the left triceps in our regular job unless you're a tennis player or something. I mean, argue, yeah. But left triceps, how often do you use, yeah? It's a pro-gravity muscle, grade 4 power. I think in our practice we are, but someone can do the microscope draping.
See,
Sir? Grade 3 will not cause functional loss, is the argument. Okay.
So, Abhay sir, I have a question. Same patient, no pain, only deficit. How many of us would operate?
Who would operate for pain? You would, right? For pain?
No pain. I'm saying no pain.
Only deficit. So
Only
painless deficit. That's a good twist.
Yeah. So, yeah. Can I answer that?
Yes, yes.
Yeah. So if we are talking about the neurological deficit, there are also stages for that, right? Motor always comes later. It starts with numbness and all those things, then paresthesia, and then sensory loss, and then motor weakness. So when we are talking about the motor weakness, particularly patients are like that, it is not just about that, are we talking about the triceps? There is a question of progression also. If we are putting the conservative, if it is not even improving, there is also risk of further progression.
Worsening neurology.
After maybe 1 week, it may be biceps, it may be something else. Are we taking the risk? Are we taking the patient, okay, let's see if your biceps is going or not. So there is a motor
let's
deficit.
take a vote again. Let's see a patient who came with radiculopathy and grade 4 weakness, and then radiculopathy settled, so pain went away. How many of you in your practice have seen motor weakness worsening despite lack of pain? Please put your hands up.
Just to come, when
And how many believe that that will not happen? That once pain is settled, motor neurology will not worsen? Please put your hands up. So many of you are on the fence, Rakesh.
yeah, so somehow cervical radiculopathy behave differently. I have seen patient, it doesn't follow the pattern that it has to be pain followed by weakness. At times, deltoid palsy or especially T1 palsy, C8 T1, patient would not have any pain. They would just give you history that on day one she had some neck pain and develop sudden deltoid weakness. So painless motor deficit is possible in cervical radiculopathy.
So Abhay,
without any pain. C4, C5, huge disc. And he doesn't have any pain, just neck pain little bit and zero power in deltoid.
Yeah, Sudhir.
so basically a soft disc herniation is typically a radiculopathy which is inflammatory in nature, which is why it responds very well to steroids. Once the soft component just settles down, and if there is a dehydrated component, then there is actually a
So then would you do CT scan for all your discs? Dry versus... Yeah. Okay. Okay. Last comment
Yeah,
on
I
that,
want
please.
to just share my experience. One patient had a complete palsy of C5. I offered a surgery, but patient was not ready. And then patient came back 3 weeks down the line, improving recovery.
Complete
By
recovery.
6 weeks,
I think most of us have that. But
Yes.
as you see,
And,
because these cases are very varied, no, there can't be take-home message at the end. So the take-home message from a disc, acute cervical disc, my version is that most of them respond to conservative treatment. And we don't, at least we don't consider deficit of grade 4 deficit as anything, but a functional deficit of the right biceps or the deltoid or a grip, you may want to act quickly. And I think most of us believe that if you act quickly, the chance of neurological recovery is faster. And conservatively, they recover very well otherwise. So quickly moving on to a surgical scenario. Now this person has got a long-standing deficit or whatever. Anyway, you need to do surgery. So, sir, what surgery would you do? ACDF? Tame, sir.
Same.
ACDF? Anyone for anything else? Yeah? Posterior? There's
Anterior foraminotomy.
Anterior foraminotomy. So can you argue against ACDF?
Yeah, because the disc is normal, it's on the lateral side, the prolapse is there. If you just do a lateral thing, that takes care of this.
So here's a very good point that the disc height, the disc anatomy looks quite well preserved. It's not a destroyed disc. The chunk is sitting laterally like a sucker piece there. So why do you want to go through the disc? You want to argue against that, sir? Why do you want to go through the entire normal disc to get to that fragment when you can just take away the fragment? You'd rather, in your hands, that works the best. Yeah. Okay. Anyone for posterior foraminotomy?
Posterior. So.
Yeah. Can you argue for posterior versus ACDF?
Posterior endoscopic foraminotomy would direct, it's a targeted fragmentectomy. You will just reach to the disc. Your parent disc is preserved, so it is a disc replacement without an expensive implant.
Like a motion preservation.
Motion preserving surgery without an implant. Yes.
And so that's the throw up between a posterior fragmentectomy, which can be done through a very small incision or through an endoscope, versus a ACDF to take care of this. I'm going to ask these two guys here what they feel. But anterior versus posterior fragmentectomy, what's your take? And we'd like both of you to give your opinions.
So I would feel posterior foraminotomy, you directly reach to the fragment. You don't go to the disc, and vertebral artery is something which is at risk if you do anterior foraminotomy. So that's why I would prefer posterior.
Anterior foraminotomy, you don't do any of the articulating surface bone work.
Ancovertebral? No?
Yeah, ancovertebral, you go on the side, you really don't do any work, you just take out the disc fragment. And you take out the ventral disc fragment completely and see the dura. So anterior microforaminotomy is better. Posterior, you will drill still a part of the bone till the facet.
And dissect muscle and all that. So I think that is the takeaway. But with endoscope, I think things are getting more balanced. I hope the message is clear that fragmentectomy alone in a juicy fragment like this is an option. You don't have to go through the ACDF. But of course, ACDF, everything works well in the cervical in these cases. Yeah. Quick comment.
One more. The advantage of posterior versus ACDF is this patient doesn't have a neck pain. So if you see there is no neck pain, at least spine is straight. So there is only unilateral radiculopathy. The result is better in posterior endoscopy rather than SCDF because we don't want to cure
no
the
axial neck pain, anatomically well present.
Yes.
Bharat bhai, last words on this because the common situation. What do you do and why? Pass the mic.
I would do anterior.
ACDF,
And in
ACDR?
my, in my hand, it works best.
ACDF,
Yeah.
ACDR or foraminotomy?
No, ACDR.
ACDR, anterior, great. Okay, so we'll quickly move on for lack of time. So this is the next case, which is a more long-standing person, pain, axial neck pain, IT professional, has to bend on the, on the laptop all the time and has just pain. Okay, so it's a slightly different situation. You see, the fragment looks like dark, like was mentioned, and it's a more chronic, Yes, anyone from the audience who wants to make a quick yes, sir? ACDF, like here you don't think foraminotomy has a role?
There is osteophyte also there.
Right, so Rakesh? Role of foraminotomy here? No?
Your disc reaching to midline, you don't go for foraminotomy. There is a risk that you may need cord retraction, there may be residual.
Dr. Dubey, you won't have to retract if you go anteriorly here. Anterior foraminotomy, can you? So your choice of surgery here?
In this patient?
Yeah, long-standing, I'll refresh you. Long-standing axial neck pain with, progressive arm pain and IT professional.
IT professional, if she has a lot of work to do bending forward, then you can do a ACDR for
more likely ACDR than right? So I think that again is coming across because these are the factors. Plus someone mentioned rightly that this looks like a hard disk. So between these, the vote would be for ACDR. Does someone in the audience or on the panel have a real problem with ACDR?
Yes.
Yes.
A lot of problems. So all of them, most of them people will have some amount because they have been adjusted to a particular facet joint. So all of them will require a facet mobilization later on. Until you do that, patients are not very happy with the ACDR results.
Like vis-a-vis an ACDF?
Yeah, vis-a-vis a ACDF.
Right.
Because
yes.
Can I add to this? We monitor the movement 3 weeks, 6 weeks, and if you feel that it is going, the movement is reducing, then we bombard with the anti-inflammatory, mainly the itrocoxib or the indomethacin, in order to stop the, and it works
inflammation.
Well. And it works well.
And how do you do facet mobilization?
We do with the physiotherapy because you are able, it's a stable thing you do with physiotherapy,
right.
the facet mobilization.
Right. Anyone else has a problem? Sir, Tamara time this was not there. So do you feel that this is just an expensive toy, that it's an expensive cage, as people say? This fuses, right. Anyone else in the audience? So ACDR came with a lot of controversy. It was very expensive and ACDF is free. So the question is, do you need that mobility? And the question is that, does that really afford that mobility? Now there are 20-year studies that have come in from the originators in France, which show non-inferiority of the ACDR over ACDF. But it doesn't show any superiority. So most of us, have this kind of an algorithm that if there are less levels, if it's the more mobile segment, if it's a younger patient, if the adjacent level is already questionable, then you move towards an ACDR. That would be the soft indication towards, and anyone in the panel can please challenge this because this is the thought process. While ACDF is when there are more levels, if they are at the ends where mobility is anyway not such a requirement, and myelopathic discs we tend to do ACDF and not ACDR.
In fact, I guess what my understanding and whatever I have gone through is single level doesn't matter whether you do ACDF or ACDR. I think ACDR, the biggest advantage is when you have a double level problem. That's what my philosophy is.
So you do hybrid or you will do 2 AC? Okay. ACDF guy.
I have gone through whatever experts I have heard here. I think in the
Double
majority
level
of favor that if you have 2 level, 3 level, again the jury is still out.
Right.
But 2 level, I think even IDET studies, level 1 studies have mentioned that it is slightly not inferior. It's slightly
better than
Abhay, I will like to comment on this.
Yeah.
Just I'll just quote the Hillbrandt's paper, which is over emphasizing the ASD. And they have the highest numbers what they had, and they talked about the ASDs, even symptomatic, which they defined by the radiculopathy and myelopathic features. radiological again, not clinically related. So it was never accepted that whether it was because of the physiological progression, that is one. And now ADR has got long series where it is also shown that with ADR also adjacent segment disease is equally happening.
So
along with its all complications.
क्या चाहते हो?
So it is happening there.
Means
so
you say that ACDR doesn't help ASD.
So we have long series of ADRs now with adjacent segments. So the study emphasis is now on the pre-existing status of degeneration. That is one. Whether the patient is a smoker or not, whether the patient is female or not, whether there is a surgical iatrogenic induced something which as you have done or not. These are the focus rather than the talk on ASD or something like that.
Fantastic. Bharat Bhai and Sudhir, one comment.
So we have studied 5 years of follow-up, 25 comparative cases of single level TDR and single level ACDF, age, sex match. And what we have found, and there were 3 observers, what we have found, the cervical lordosis gets restored much better in the TDR cases than the ACDF cases.
And so if you are a spine surgeon and you require this, what you will do for yourself?
So that's my next, so this is not a case, but this is not a spine surgeon, but he was an Indian Olympic silver medalist shooter. And he had this disc which only on that position his finger would go numb. So there's no question I would do a ACDR. So for myself I would do an ACDR, not an ACDF.
So I know 3 big spine surgeons across and who have undergone ACDF.
ACDFs.
And, and they again had an adjacent level and they have gone for ACDF again.
Oh.
So because what happens functionally, you are dependent. If you are, see these days technology has changed, your neck has become more forward. But if you is really dependent on it and you have to do a lot of work, then you require a ACDF compared to ACDR.
And then look at this other guy, again my patient, he was a national wrestler. Okay, and he comes for surgery because he had a huge disc. It was just a soft disc, but huge disc. So he doesn't get an ACDR because he's going to get those Greco-Roman tackling. This is his photo.
So again, internationally, he will go for foraminotomy. He won't go for any ACDF, ACDR. He will go for foraminotomy.
All right. So anyway, that kind of throws light. Multi-level, think of ACDR. Functional neck, think of ACDR. More rigid head loading kind of occupation, think of ACDF. If anyone has any comments or challenges to this, so quickly we'll move to something better. So this is radiculopathy, but on examination there is brisk reflexes. So there's a hint of myelopathy, and you can see it's a single level disc, but then there's a second level here. The question is, would you do discectomy, Amit Jhala, discectomy or corpectomy? 2-level discectomy or corpectomy? Again, is anyone else for corpectomy?
Because that's very important before I do a 2-level discussion.
Kshitij, can you poke your head out and dekho 1 minute. 1 second it'll take you. This is only data. 2-level disc, myelopathy on examination, but comes with only radiculopathy. Would you do 2-level ACDF, or would you remove the bone and do one single ACDF? Bharat?
I will do corpectomy because I have seen if you leave behind the osteophyte, it usually is seen on the post-op MRI not getting adequately.
I agree. So we require a CT scan before I decide on that.
Yeah.
So you can take osteophytes out, and unless it is retrovertebral disease, I don't do corpectomy. 2-level ACDF.
So 2-level ACDF. Yeah. So I think again it's a 80-20. I'm in favor of corpectomy like Bharat because if I think that there's myelopathy, I want to get a really good view. And there's data to show that 2 levels of fusion is better than 4 levels of fusion. Like in when you have a 2-level ACDF, the chance, which of course we see very rarely, pseudoarthrosis, is less common in if there's just one graft.
But one level corpectomy is more destabilizing, and a 2-level ACDF will give rise to a better cervical alignment than a 1-level corpectomy.
Fair.
That difference is like 95 versus 97%.
Yeah.
Fair.
It's just an argument that we use. I think for me it's more visibility of the cord.
So the easier to do a corpectomy if you can't get the disc distracted well.
Yeah.
So.
Just a question that the myelopathy seems to be arising from the lower level. So any idea about the hybrid like ACDF at lower level and TDR or ACDR on the upper level?
Abhidha, you have not spoken. Anyone in favor of hybrid? I do a lot of hybrids, and the lower one is always a fusion, the upper one always a
I will do facet distraction and fixation.
posterior
Posterior.
surgery. And with cages?
Depends. If the joint space is good, yes, cage. Otherwise, just fixation.
You kept saying in your presentation, sorry, I'm here to create controversy, that you stopped using cages. Is it because of the bad press that came up, or like why have you stopped using cages? And here, why would you use cages?
Not necessary. Why put implant in when it's not necessary? The bone joint is sufficing. In the initial period, you put in adequate block of bone. Later, it fuses. So that.
But here you would put cages, and you would not do any anterior
Yes,
surgery.
yes.
That's anyone in favor of this, or anyone has a serious problem with this, sir? The seniors. Any problem with the approach by Dr. Shah? Yeah.
So I have no experience with that, but traditional teaching what says that if you distract joint posterior, it will lead to probably more kyphosis. So that's the only
Kyphosis?
consideration I might have. I have no experience with this.
Posterior distraction procedures, can it cause long-term
We have
neck
not
pain?
seen kyphosis. Maybe the lordosis, it will remain as it is. We have not seen kyphosis, at least, definitely.
Now I have even 20 years follow-up of corpectomies. So what I have seen in those patients which are corpectomy was well done, you see remodeling. Initially, if their scans were very bad and you have done a good lordosis with filling of the cage and making that, they have a remodeling of the bones, and means previously they were adjacent problems, they also look decreased. So I have seen some patients with 20 years follow-up of done corpectomies before, and they have done well. So
But what's your comment on this?
No, if a cervical spine is an anterior disease, and the cord is touching from the anterior surface. If there is an anterior compression, the best results are from anterior surgery. Means I always have.
Do you want to quickly retort to that?
So the concept is you're saying compression is the problem. I'm saying instability.
My problem is it's not you are looking at just as a compression at one level. I'm seeing as a deformity at a whole level. See, CV junctions, if you go from the sides, you are able to do ventral job from posterior aspects, but it won't change anterior things from posterior lateral aspect and these subaxial cervical spine.
It does change over a period of time.
Not,
It does.
Not that much. Means, see, you are fixing slightly like this, or maybe straighter. But in cervical, if you do a corpectomy, you are able to really distract and cause a lordosis to happen.
Great.
Which
So
will
we
have
got
a
some.
greater. If you, we all have to, as a surgeons, in cervical spine, the more lordosis you are able to give with your surgery, the lesser adjacent level disease you are going to face.
And
Jayesh, can you comment on?
And instead of two-level ACDF, you'll do corpectomy?
I will do corpectomy.
No two-level ACDF?
See, I do corpectomies all the time, and I see the osteophytes which are on the sides, especially on the sides, where your ankle joint is there. In ACDF, you're not able to remove that much bone compared to in the center.
Okay, quickly, what's the approach to this? It's a chronic disc with myelopathy. Any investigations you do?
Obviously, I would go for CT scan, but MRI is showing T2 signal changes in cord. So patient.
And why CT scan?
For ossification.
Ossification of the disc.
Yes. So patient is symptomatic, and second thing is there are T2 signal changes in MRI. So patient will definitely need surgery. One or two things I will consider in this patient, as it's a higher level disc. I will need to see the angle of mandible, but it's I think I will be able to go to C3, C4 level. I will go for SCDF, and we'll do funnel shape drilling in body.
So great points. CT scan is a must. Yes, please take the mic, or just talk loudly. In this case, you do both. Which one first?
One level anterior, because there is a disc there.
So start with anterior and then
because there
posterior.
is significant OPLL also. We cannot neglect that OPLL.
I
And
think
it was
it's
very
a-
well seen in your MRI also.
Yeah. Actually, my boss does that.
Yeah.
But posterior first, followed by anterior.
No,
If it's a
anterior first,
myelopathic-
followed by
Yeah.
posterior.
Yeah, so it's not so out of the world what he's saying. I told you, Dr. Bhojraj will often, if it's a myelopathic hard central disc with a lot of bone hanging around there, he goes and does a posterior clearance and then attends to the anterior. And he's got very good results, yeah. Yeah, he said the other way. We are saying the other way. Anyone else has got a problem with this huge approach? C1, C2 fixation also. With what benefit?
With there is a significant instability, I'll get a dynamic MRI.
At C1, C2?
Yes. Because patient has OPLL and hard disk.
C1, C2 proponents, do you agree with this argument that besides you'll do ACDF plus C1, C2, not laminectomy at the back?
Posterior limited laminectomy.
Limited, oh.
So the advantage when we go posterior is you assess the adjacent level at the same go. So if you have
So
a
it's a
problem
more
or you are tackling the
multi-level.
adjacent at that
How about
time.
C1, C2?
In this case, if it was C2, 3, I would definitely do C1, C2, but we have modified our C1, C2. We don't include the C1. We will do C2, 3. Include
Fixation.
C2, 3 fixation in the construct instead of going C1, so that your C1, C2, you're maintaining the mobility. But
Dr.
I will
Dubey,
take
what
this-
is your take on this whole new bandwagon of C1, C2 fixation for everything?
See, the thing is, it is in the end, it depends on the results. If the results are really excellent, it is no problem in doing it. There is always so many ways to bell a cat. But in my hands, means in the end, we have to talk about what we can counsel and what we can comprehend. Sometimes the wisdom comes later on in years also. So whatever we are talking now may be totally
Is your
different.
own experience. So,
Yeah.
Abhidha, just to be sure, in this case, what would your surgery be? Would it be C1, C2 fixation?
C2, 3, 3, 4, maybe 4, 5.
C2, 3 fixation from the back.
From the back.
And then C3, 4 fixation from the back. And laminectomy only so much.
Only fixation.
Only fixation, no laminectomy. And you would like to do such a limited laminectomy.
Laminotomy, not
Laminotomy.
laminectomy.
Like from here to here maybe.
Yes, yes.
And then fix C1, C2 also. Okay.
Why not
Yes.
laminoplasty? One thing which is remaining from all this discussion.
Bolo, tame bolo.
Nene, I just wanted everyone to.
Fukat ka chandan, ghas mere nandan.
All the options were there, one was remaining.
So the takeaway here is that when these are hard discs, like Jaimin rightly said, get a CT scan, don't rely on the MRI scan. Don't try to dive into the disc because you may be, at least for me, I've had 2 quadriplegias post-op when I try to just dive into the disc. So I like to normally, do it more formally like that, like to drill the bones at the bottom and the top, get a good view of normal to normal. And then if it's like this, where there is some stuff hanging around, I would rather just do a corpectomy again. So I err on the corpectomy. Visibility is much better. And I've had 2 bad experiences.
So
Dr.
a
Dubey?
lot of times, doing a fixation does revert the changes even if you don't do decompression, means that we would have seen in our experience also.
But here, would you fix and not decompress?
No, this I will do an anterior approach and take out and do a corpectomy. That's all.
Yes. Yeah. So is there any trick? CSF leak because the bone is sitting on the dura. So any trick? So how do you manage that? I mean, how do you prevent that? So it's a good point that sir says that there's ossification on the dura. So when you try to pull that out, the dura tears because it's thinned out for long. So one of the ways is to float it, like just disconnect it and let that stuff be on the dura. As long as it's not connected to any other bony structure and you float it, you can normally get away rather than peel off. Yes, one last
So
comment.
even if what arrows you have shown regarding the corpectomy, you're not still dealing with the C2, C3 posterior compression. It's very well
C2
seen,
till
the
here?
MRI cut, yeah, there, posteriorly, not anteriorly, posteriorly, yeah,
This-
just that behind.
Ah, here.
So that has not been dealt with. So the area what you're operating is not dealing the higher level.
You
if
think
you're not
it'll jack up and the ligamentum will fold up?
maybe, sir, very
not.
difficult to say.
Because CT ma dekha to nathi na, you don't see.
No, the spinal canal itself is little bit reduced if you see very clearly on the CT
Fair.
scan also. The spinal canal diameter is not equal to what is they've seen on the C2 behind body or C5, 6 behind body.
Yeah,
If you see at the C4, C3 or C4 level, the spinal canal seems to be little bit reduced.
So making a strong case for a longer laminectomy.
I
and
told one level anterior, 3 level posterior. There is no doubt
yeah,
in that.
Yeah, quick. Yeah, that ultrasonic burr. Yeah, keep drilling. Ajay, you want to pop your head out of your patient's comments and quickly, anything different? Okay, done. So that's the surgery. What about this one? This patient comes with pure myelopathy, no radiculopathy, and you can see it looks like a longish OPA. Yeah, who said corpectomy? What corpectomy? Yeah.
I think C4, 5 both.
C4, C5 corpectomy.
Yeah.
Here you won't do a laminectomy.
No.
What
Because
is
there is no posterior compression. As simple as that.
But fallback, cord fallback. Anyone would do a okay, fair. Anyone laminectomy, guys? Laminectomy fixation, isn't it? Yeah. Anyone for anterior? Put your hands up. Yeah, can you argue anterior against posterior? Because I
Yeah.
would do posterior, actually, that's what I did.
So here you can see it may be OPLL, but the compression is just at the center. So I would get flexion extension MRI. If the compression is only at the disc level, I won't bother about whether it's OPLL above or below. You just do a ACDF there.
So one level ACDF?
Yeah.
Not even ACCF?
No, ACDF.
So here, this disc, like
Yes,
4-5 disc.
Rest upper level, lower level, there is a CSF space in front, CSF space in back. I would just do ACDF. I'll get dynamic MRI, make sure that the compression only at the
only
disc
there.
level.
Yeah, Sudhir.
Natural history will show for these kind of this thing, 30 to 40% people won't have any improvement in myelopathy features. In fact, may become better over next 5 years.
Just by not doing anything.
Natural, yeah. Natural history, the papers which were in 80s, 90s and 2000s, they show for this kind of cord signal changes and myelopathy, 30 to 40% people will have same status or even some regression of symptoms over many years.
So would you conserve then?
No,
That's an interesting
I'm
point.
not doing conservation, but
Yeah.
that is also you
That's
should
one
know.
of the things.
So one of the thing is we do lot of things. You can do an endoscopic laminotomy. You can do whatever the procedures are.
But it's a good point you made that the natural history of myelopathy is not necessarily one of that, dives deep into south. I would say half the patients just remain like that for the rest of their life, and some of them actually improve. And just on that point, we had a very high profile patient with a much bigger OPLL, which was completely asymptomatic, owner of Cred India, that guy. So I took him with me to Istanbul for the GSC and got opinions from the Japanese. And all of them said, don't touch him. Because I said, he's young, he's much worse than this, but no symptoms. They said, this may just remain like this or actually get better. So to your point, I think there is stuff there, yeah.
Yes, one question I want to ask. Does the age make any difference in the plan of surgery in posterior? Whether just to do laminectomy or with fixation?
Mr. Posterior. Age.
Anterior.
And Mr. Posterior?
From the panel.
So
Like
in
I think if it's posterior.
In this case, I said anterior only.
You would say anterior. But I think age is that if it's a younger person, then I would fix. Older person with degenerated collapsed discs, autofused anterior, I would just decompress, just do laminectomy.
So
just the opinion from the panel.
Yeah,
Because
panel.
This is a very good question actually.
Approach. Posterior versus anterior will not change with
Yeah.
age, but
Fixation,
fixation, no
yes,
fixation.
yes. That depends
Anything
on
else?
degeneration.
Age. Any of you all feel anything different? Yes.
If you are going posterior, doing a laminectomy, just put at the most mobile junctions, transfacetal small 8mm screws which are used for facial this thing, you will have good results. If you don't do that, you will have some amount of dynamic changes. Means I have seen, when I have treated a lot of patients with post-laminectomy kyphosis in young who
So
have,
you think transfacetal screw will fix it?
yeah, it makes it
Let's take a
stable.
quick vote on this controversial implant. Who of you believe in a transfacetal screw? Put your hands up.
No, if you're doing just laminectomy, I'm
just
not saying that,
laminectomy.
yeah. If you're doing
And
that
who does
compared
not
to-
believe in transfacetal screws? Put your hands up. Everyone has to commit to something, there's no lunch. Okay, fine. Okay, now this person comes with, after the surgery, comes with good result, but by day 4, on the day of discharge, worsens neurologically. What would be the approach, sir? Neurology worsening and pain going high on day 4 of surgery after a good initial result. What likely do you think would be on MRI, sir?
Cord compression or the blood collection or something.
Yeah. So that's what we are coming to, hematoma. So I just want the vote from the, so this is not uncommon in the cervical spine, post-op hematoma, because the space is very restricted and we tend to close very hard. So a small hematoma can cause this. Anyone from the panel can give your final plan on this. This person has a 1 grade drop in neurology post-op and has pain, and this is the MRI picture. Would you operate or would you conserve? Operate? Jaimin?
My name is Dr. Shailendra. Dr.
Sorry.
Jaimin is not present. So
We've never met.
Yes. It's only 1 grade neurological deterioration, so I would like to conserve. If there is progressive deterioration, then I would re-explore. Otherwise, I will do symptomatic management.
Okay. Quick, Subir or anyone, quick sum up on what are the indications to re-explore?
So for me, if any drop in neurology, I'll immediately explore. I'll not wait.
So neurology re-explore, pain, steroid.
Pain, yes. I can wait on pain, but not on neurology.
Indication for re-exploration in post-op hematoma.
I think the neurological worsening, so I would go in. No
But
doubt
you would,
about it.
Shailendra, still not, if it's grade 1 drop, you would not.
I will observe for some days. If it is static,
And steroid. So quick show of hands, quick.
So from a neurosurgeon's point of view, this is a extradural hemorrhage sitting there. So there is no point in waiting for it. You can remove it. There is no harm if you are just confident of removing
But
this.
what is the neurosurgeon point there?
I'm the neurosurgeon, so I'll definitely like to remove this.
But અહીંયા પણ બધા છે ને neurosurgeons.
But that's the different prospect, sir. There is different. There is like
Okay.
EDH is very easily you can remove.
Okay.
Why to wait for this?
What is removable, please remove.
What is removable, please remove. Why to wait
Kshitij,
for
what's
this?
the literature? You're the literature nerd. Yeah, I think that is what literature also seems to say, but there are no blinded controlled trials. That's the problem.
It will never happen.
Yeah,
No.
because it's impossible
It
to
will
take
impossible to happen. So the neurodeterioration, if we are able to say that this neurodeterioration because of a hematoma, the rapidity in which things can worsen is so fast that you won't have time to react. So if there's one drop, one great drop.
Right.
get
We're
it
running out
off.
of time. So one last case I'll do.
27 seconds.
Yeah. Sorry. One great drop.
I think Dr. Nene, I think this is last.
Yeah. Finish?
Yeah,
Okay.
finish, yeah.
Okay, done.
Really in this patient.
The drain was functional for
Yeah.
the first 2 days and it was removed.
Yeah, and there was no much drain.
Yeah. After, yeah. Yeah.
Patient has not improved.
Sorry?
USG guided aspiration.
Yeah, I think we discuss more on coffee
Yeah.
break.
Yeah. This will hang around for coffee break.
Yeah. Excellent session. Dr. Abhay, Nene, fantastic job. And excellent participation from all the crowds and panelists. Thank you so much, everyone. And we'll take a quick break and we'll be back at 11 a.m. sharp for the session, best session of the day, which is plenary session. Looking forward to see you back again.
करते हुए। मेरा मैं नेक्स्ट टाइम लेता हूँ। ये तेरे पास ही रखूँ सर? मेडल तेरे को ही पहनाना है ना उसको, तो उसको लगा के, लेकिन इसको लगा देना। तेरा कहाँ है नाम? इधर है, इधर है। इसको ऐसे चिपका नहीं है। मैं तो आने दो।
બે હાર્ડ ડિસ્ક છે ને આ લોકોને કેટલું જોઈએ 800 GB જોઈએ છે તો નવી હાર્ડ ડિસ્ક મંગાવી લે ને કોઈને એ મેડમને કહે ને કોઈ જોડે નવી મંગાવી લે બીજું શું 1 TB. Good morning all. So after a quick coffee break, we move on to our next session, a plenary session. Everyone please quickly settle down. We will be starting a session that is eagerly waited and the highlight of this event. I'll invite panelists for the session who are past presidents of Spine Ashram Gujarat and have been advisory for this meet and association. Dr. Bharat Dave sir, please come on dais. Dr. Amit Jala sir, Dr. Subir Zaveri, Dr. Tharadara sir. So this is a time for presidential oration by Dr. Ajay Krishnan, a dynamic president who has been a dreamer who has led SAG and basically invented or gave a concept that we should go ahead from a one-day conference to 1.5 day and kept adding one more session, video session, quiz session and made it a fantastic event. And to introduce Ajay more, we'll have Vice President Dr. Niraj Vasavada introducing Ajay Krishnan. Yes, Niraj.
I'm not a mentalist. I'll not really reveal your secrets. So actually, Rakesh told me that I have to prepare presentation. I have prepared a presentation. But then I thought that presentation probably will not convey the emotions what I have for this gentleman. I remember first I met Ajay probably around 2010. We all were younger. We are still young, but we were younger. And I still remember I listened to his 2 talks, again on SAG program. One was on Tillich's classification. Around 2010 we had SAG. I was just probably, that was first meeting of SAG I had attended around 2010. I was at Rajkot. And second was the Linky's classification. What he explained into this talk, I think that changed my paradigm that how you should read classification. So I remember that man's academic prowess still then. I have seen him grow leaps and bounds along with Bharat sir, along with Stavya, and as an individual who stands tall today in various organizations. He is so hungry about excelling at academics, at surgery, to impart his experience, his knowledge to youngsters, that he's insatiable. We had an experience in MISABCon, which he very successfully organized recently. And he always wanted to go an extra mile, that what I can do different so that this organization, this conference, this academic feast becomes more meaningful for the delegates and for those who are coming. He has always one extra thought. I have seen that, whenever we had discussed about a meeting, an event, an academic organization, I never could satisfy him. He always wanted more from everybody around him. So it's my proud privilege to welcome my dear friend, who doesn't require any introduction actually, to come and give his presidential oration. I present you Dr. Ajay Krishnan. Thank you so much.
Have you ever wondered why some teams survive big adversities and some fail in spite of having the best intellectual mind around? There are so many hospitals, they don't survive. There are so many teams who don't survive. So what is exactly the thing where things go on for generations and families survive across generations? So that's exactly what I'm going to talk about here. The structure which we have all studied over these many years and which we are united over here, the same structure which holds us together, unites us together, and our dreams it brings together. So that is the spine. Going to this ancient parallel, this is Samudra Manthan. And this has got opposite people, the Asuras and Devas, pulling across with Vasuki in the one thing what they wanted, and that is Amrit. They have high ego, high talent, high capacities, fight around. Finally, the Amrit comes around. But along with it, there are 14 Ratnas which come out. The division and passing out of those Ratnas to each everybody or sharing is so difficult. And there are hidden leaders in this. And everybody thought that they themselves are a leader. You have to go beyond this. This itself is a 1 hour lecture at least. And that is what I believe. But that's what I'm here to talk about. The spine of a team here, which is keeping us together. And just to be a little bit nostalgic, go to the first paragraph of BD Chaurasia. These are the 5 things which is written on there. Support, structure, protection, mobility, and communication. This is not a glamorous organ. Nobody says that save my spine. Lekin sab bolte hain ki bhai save my heart. So that is the emotion which you have. But still, this is important because without this you cannot stand, walk, or even breathe. You cannot. So that is so important a structure which you have in your body, and that's why the spine we are talking about here, and that is why it is the thing which is holding teams together, leadership ahead, and taking the load. It all setups. Alignment. We are proud of alignments. Right now we think about all X-rays and we try to balance out the C7 plumb line. And I'm very happy when I see this case having done. Very happy, the patient good, everything good. But I come across so many number of patients where the C7 is not balanced. And in spite of having a very good musculature, the patient gets the pain. So you have to have essential C7 plumb line because alignment is for purpose, roles, vision, and values. I had my bad days at my place, my team, wherein there are excellent surgeons. You name it, it is there. Excellent nurses, excellent anesthetists. But OT delays, blame games. And then came the time. Our best bet, Mirant, joined us. It's now 4 years plus or something. He has united everybody. He has sat with them and given a common goal. The purpose is to make the patient happy. The patients are getting discharged at second to third day, and it has made an entire difference in things because we are aligned. So that is what is important at family, in family. When me and Preeti are aligned, my kids feel the pressure and they get aligned. So imagine and ask yourself the question, is your C7 plumb line aligned? Misalignment means frustration, fatigue, failure. The disc is a shock absorber, and this is a seminal article of Elch Nemenson. I don't want to go into the details of it, but 120 kgs of compressive loading is taken by your spine daily, and giving 100 into 10, that is to say 1000 movements of different sorts the spine is able to produce. And that is exactly the teams are supposed to do They should be able to carry the load and not put the pressure at the leader. And that is determined by the trust, the system, the culture. And that is what is important. Sharing a case, complex one. See the middle. There were 4 anesthetists united to give anesthesia to this patient. It took 2.5 hours to position this patient prone. This is an angstpon. Difficult case, lot of counseling pre. Patient has roamed around entire Ahmedabad and many places and didn't find an answer in all those he sought for, and finally surrendered to me with a surgery, and we had taken all prerequisite needs to make it better. Having the expert institute experience and preparedness, we went ahead. Everything went better than what we expected. Is it excellence? Yes. Highly ego massaging, and the second the patient walked, I asked to the patient, he smiled. I asked, "Dost itna theek hai? Do you want me to straight you more? Then I can open you in 2 to 5 days and make you more straighter." This was exactly. He said, I'm happy and I don't want anything more than this. I said, you take your time. You tell me after a week also. I'll take your deformity cervical also and make it more straighter if you wish to. I kept him in hospital for 10 days. He never changed his words. He had high praise. The family was with us. He was happy. The team was happy. We discharged him at the 10th day. In 2 days, he got admitted back with vomiting. We just dissected into the things. Blood reports, MRI came out to be normal. We suspected an infection. MRI was normal. Still, we escalated it like an infection and let 1 day pass. ID was involved already. In a daytime, next day he developed fever and headache. We know clinical suspicion it is likely meningitis. We posted immediately for debridement. By that time, there was a fluctuant swelling, in spite of the MRI first day negative, a fluctuant swelling on the iliac screw area. We posted immediate, and the anesthetic team was reluctant to post him because it took 2.5 hours for the first day position. As we had posted, by that time he was on a deteriorating cascade. It was decided that we may lose things, so it was shifted into ICU care with a T-stomy, with escalated multidisciplinary approach, and we, at that speed of escalation in a day, we could just barely manage to open up the stitches of the iliac screw to drain whatever was there. But the clinical deterioration was too fast. We were fighting against the wall. The destiny was sealed. He left with a scar on me. An unimaginable, unacceptable outcome to the patient and the relatives. It is failure. Things like this occur. In overwhelming situations like this, I console myself with the verse, Nimit matram bhava savyasachi. We all face these type of cases, and failure do occur. But whenever failures occur, think that whether it is happening for a right reason or not. If it is happening for an error, or you not showing up, take a step backward, my friend. You are not meant for it. But if it is happening with all preparedness and everything being done, you are on right track. You have to keep going to do what is possible in your hands. And you keep doing that. Core muscles, the basic thing that shares the load. No single vertebra carries the load. I heard Bharat sir saying, મડકા ના ઉપર કોઈ મસલ્સ ના હોય, લિગામેન્ટ ના હોય, 10 kg મૂકો એટલે પડી જાય, તમે 50 કિલો ઉપાડી શકો છો. The reason, it is your muscles. The basic way how he explained to the patient, I am imbibed. I see 20 to 90 patients a day. These are my consulting rooms. I see 10 rooms. If I see in 2 rooms without a team, I cannot see. There is a system in place. There are people around who share my load. I am able to finish it. I get exhausted, but what I take, I am able to finish it. and my team, they support me out. And this is just a representative image I got. It is more than this. So it is possible, but there should be a system in place. And that's why the core needs to be strength. We are thinking about avoiding collateral damage to the muscles. That is the core by all minimal invasive approaches. So become the core of the team. If your core is not stronger, the leader will be burdened. The leader will fail, conservative or operative, succumb. So be the core of the team. It is essential for any team. Flexibility without instability, that is our goal. A rigid spine fractures, a mobile spine adapts. We are seeing adjacent segments. More you fuse, immediate pain relief is excellent, beautiful. Patient दूसरे दिन खड़ा हो जाता है. But the more you fuse, you know what you are losing. They have high chances of coming back also. So, what is needed? Think about. In COVID, so much amount of rigidity was imposed on us. No surgeries, strict SOPs, no guidelines for what was emergency surgery. Everything needed to be shut down for a short weeks of time and even longer weeks. We were completely reduced to 0% work. We didn't break, we did bend. Except for initial sealing of few weeks, we got back to that 1% of work. Against that all odds, following the SOPs, but found new ways of justifying where we need to be doing things. I did good number of endoscopic surgery under local anesthesia because anesthesia was not ready to do a GA. There were patients who were coming paralyzed. Our hospital kept working. Thanks to Bharat sir, we were all on same page. We as entrepreneur could have failed. We could have gone bankrupt. But we pivoted in that thing and we changed our shift and focus, kept working. We survived. There are hospitals and teams or single surgeons or places, those who would have struggled. We have struggled, but we bent. We didn't broke. We didn't stop. So that is what we are talking about. SOPs are meant for hospitals to be run in the good way, but whenever needed, please bend. If you take care of your kid who is teen now, the same way as you were taking care of him when it was 5 years, you will fail. You have to adapt. You have to change. And that is why you need to be the core. And SAG is what taught me the flexibility. Communication, healthy. We have a board which Bharat sir uses for communication. Just keeps on writing, cheats, just writing. Just to communicate, nothing is missed out. At the end of the day, he has still more communications to be left to be communicated. But that communication pathways which he has created has made us more stronger, the core bigger, stronger. And that is what we need. Healthy nerves, communication, clear, and that should be fast and no compression. Pinched nerves, you know what it does. Numbness, weakness, pain. Do you want that? In your team, there may be two people who are sitting in a different direction. Your team is going to fail. You have to be aligned. You have to have good communication. Communicate, communicate, communicate. The nerves, the spine teaches us. If you don't, you fail. You lose your staff. You lose your people, your trained people, people who want to be with you, but communicate. Don't let this corpse angle affect your team. My personal spine has health. Do I do it? Yes. Family spine. And I'm just asking to myself, am I present or just providing? Friend spine. Who is my disc? Who absorbs my all stresses? Who is there to just tell, and when he's just listening to me? Who is there? They are my friends in my disc. My entrepreneur spine. Is my vision aligned to my core team? I always see that we have a common agenda, common things, and we should not be going in a different direction. We have to be aligned. My self spine. Am I stretching or getting old with age? Health. I have recently started misadventures and developing my avatars. I am 50 years now, and inshallah, I don't believe in religion.
I believe in God. I am spiritual. I don't follow any gospels particular. I am trying. Let's hope I remain here to be with you, to be in my better avatars after 50. I'm midlife now. I'm coming back to Samantramandan. You have to remember, there is so much. This is 2 hours lecture. We can just keep on taking on this. The leadership lesson is every team has a strong spine. Shiva consumed the poison which come as one of the ratnas out of it to protect the world. The Kurma, the Vishnu, held the base, hidden under the sea to keep everything stable. And the Asuras and the Devas were fighting, thinking that they were leaders. Yes, they were leaders, but there is a core. Who is that core? Don't try to find that core. Be in your karma. Keep working. The most important lesson, the leadership happens behind the scene. Some examples, parallels. Steve Jobs died 2011. Thought Apple would not last longer. Came Tim Cook. He turned around. Backward integration and supply chain management. He is so expert. He made it 1 trillion company by 2018, which was not achieved by Steve Jobs. Now this year it is changing. The man is John Turners. He is a hardware man. Imagine, this is going to be a complete change for an iPhone. You have not seen foldables. You have not seen advanced technologies which is coming into iPhone. Wait for 5 years. Wait for 3 years. Why? Because the culture in Apple is there. The system is there. The core is there. It was not Steve Jobs. It just goes beyond the founder. Apollo 13, a mission. This is Tom Hanks, one of my favorite heroes. It was a failed mission wherein there was an explosion in the space and 3 stranded astronauts. Without blaming anybody, any team, everybody put their effort to bring those 3 back to Earth. That is team. Western world. Americans could do it. Let's have some more corollary. Chandrayaan. We all were proud of Chandrayaan 3. Have you ever heard of Chandrayaan 2? Chandrayaan 2, that had this GSLV 3. Vikram was the lander. And that is the rover, that is Pragyan, which was to come on the surface of the land. That was to make a soft landing on moon and do its data collection, which would have enriched us by anything and make India very powerful. But it failed to land softly. But what it could achieve, the lunar orbiter it could launch. There was no blame game. This was 2019. ISRO, they collected all data which was with them. They bounded back with a bang. We already have Chandrayaan 3 with its success. It is well established on the map of the world. We are just few of the countries who have this. And that is what is going to happen further with Chandrayaan 4. So life cycle of a surgeon, we have to reinvent ourselves. We have to understand this. Every phase of growth has its own spinal demand. Be a learner, be a practitioner, be a leader, be an elder. There's a time when you have to step down. Still be the spine of that team. It's a long way. Now people overlive their vanaprastha. This all is because of the gurus. वो बोलते हैं कि अपने गुरु का इल्म तुम्हारे पास है तो तुमको कोई पछाड़ नहीं सकता है. और सेम वे तुम्हारे पेरेंट्स का साया तुम्हारे पास है, तुमको कोई रिस्क छू नहीं सकता. When the going goes tough, when exhaustion is sitting in front of you, when failure is imminent and the person who goes forward, this is Dr. Bharat Dave, the spine of Stavya. Look at this man. He's 81 years old. Last week I just came down and I was to just board and sit on my car and I realized that I'm sitting on a shining Fortuner and he's nobody else, my dad, with 2 shabby clothes in his hand. He realized that 6 o'clock I am to leave and the cleaner man is not around. He took that risk to clean this. Mind you, it's Fortuner. For cleaning the glass, you have to climb and to clean. Isn't he a superhero? He is the spine of my home. When you are leading, the question what you are supposed to ask is whether you are leader or not. Ask whether you are the spine or not. Strong enough to carry, flexible enough to adapt, humble enough to be the disc, brave enough to be the align. That is what decides the scale of your rise. And communication always essential. I step down, I hail SAG, I hail every one of you, I hail my circumstances that shaped me. Indebted. Be the spine of a team. Thank you.
Excellent, excellent, Ajay. So, memento by.
I'm going to present two slides. I think we are on time.
Yeah,
So
yeah,
I have,
no
I have two slides to present. Oration means coming something from the heart, coming something from the journey, coming something from the experience. And that is something which we all need to, on the chair, we all need to really share. So the true measure of a surgeon is not just how many spine he has operated upon, but how many stand taller because of his efforts. And that is something which we all need to know. So, friends, our ancient wisdom reminds me, nahi gnanenam sadansam pavitra miha vidyate. There is nothing more noble, more purifying than the knowledge, and probably which we got from Dr. Ajay's talk. There is nothing, a journey measured not in years alone, but in the patients healed, students inspired, colleagues supported, and lives transformed. Some surgeons leave their mark through the number of operations they perform, some through the papers they publish, but a few, however, leave an imprint on the heart of patients, the mind of students, and the conscience of their profession, and that is Dr. Ajay Krishnan. This is not just to talk good, but this is something which I feel at severe. He has been with us since past 17 years. I have privilege of watching Dr. Ajay not only as a spine surgeon, but also enrich the lives of the patients, trainees, and colleagues around him. His journey reminds us that excellence is medicine, not a destination. It is the habit which should be practiced every day. So that is something, the message to all. When others see an MRI, he sees a human story. He sees a human story in that MRI. When others see a difficult operation, he sees an opportunity to restore the dignity, This is like in a poem form which I have written. When others see a challenge, he sees that as a responsibility, The operating theatre has witnessed his precision, outpatient clinics has witnessed his compassion, and the academic podium has witnessed his scholarship, which we just observed. All those of us unfortunate enough to work alongside him have witnessed his humility as well. So an era where noise often overshadows substance, Ajay has chosen a different path to let his work speak, his patients smile, and his results tell the story. And that's what we have seen in that long case. At the end, we really fought till the last minute. We had created the whole, the structure for that patient. A good surgeon operates with his hands. A great surgeon operates with his mind. But finest surgeon heal with their hearts. And Dr. Ajay exemplifies all the three: hands, mind, and heart, all the three. As a colleague, we admire his clinical judgment. When we are all together, yesterday only the case, let's ask Dr. Ajay. That was something where we were just discussing about the biopsy, simple thing. A friend, we value his integrity. I repeat, his integrity. A fellow spine surgeon, we respect his unwavering commitment to excellence. And I repeat, to excellence. The oration is not simply a lecture which you have heard. It is the distilled wisdom of the years spent at the bedside, in the clinic, in the operation theatre, and the relentless pursuit to the better patient care. That's what we have observed with Dr. Ajay. It is therefore my privilege, honor, and my pleasure to moderate this session of a respected teacher, a trusted colleague, and a dear friend. So, Dr. Ajay has delivered this lecture. Ladies and gentlemen, let's have the round of applause for him. On a dependable colleague, the true measure of a surgeon is not how many spines he has operated upon, but how many lives he stands. So thank you very much for listening me, and thank you for giving us the opportunity to be here at the dais for Dr. Ajay.
Now it's time, after that emotional tribute from a mentee to mentor and then mentor to mentee. So now it's time to present a memento to our SAG President, Dr. Ajay Krishnan, by all the dignitaries on dais. Please come forward. And it goes on to next President, Dr. Niraj Vasavada. After that heart-touching moments, we move on to the next, that is prestigious Dr. Denish Patel oration. And to give introduction about Dr. Denish Patel oration, I'll request Dr. Bharat Dave sir to tell us about Dr. Denish Patel.
This is another touchy moment. There are things that are known, there are things that are unknown, and they are between the two doors. So the gentleman whose name is attached to this oration, which Dr. Sudhir Dubey has come to talk about, November 17, 1931, he was born, and we lost him on the 5th January 2007. And 21st January 2007 was the SECon, and he was patron at that time. And he is the spine surgeon. He can never be spineless. He's a well-known consultant. We lost him at 76 years of the age. This is the journey which I have been from 1989 when I joined 86 when I joined orthopedics in his unit. Started practicing as orthosurgeon in Ahmedabad after getting trained FRCS from UK. He used to go in the visual aids in the old ambassador car. I'm sure you may have seen the ambassador car where you have to really start from the front. You may not have seen carousels, which I still have those in my memories as well, in my library, where we have to, make the slides. And he make us run a day before the presentation. Bharat, can you go and get these slides? And then we will have those slides, the 35mm slides, which you mount onto the carousel. So initiative to do something new, which was his thing, and then when he came to Ahmedabad after doing his FRCS, he said that I was called foreign body by the Ahmedabad people, those who were practicing at that time as an orthopedic surgeon. But Bharat, I continued to work. And this was Dr. Jaju, his good friend, who is also no more. But he said this to me. He was pioneer of Gujarat Spine Association, and that's where we stand here. And I'm sure that's something which we are going to conclude in the GBM today as well. We'll move to the next level, and I'm sure the GS SAG is going on in a good, strong direction. So 1972, he was head professor, BJ Medical College. As a teacher, he guided several students. He will come in the end, after finishing his clinic at around 10 p.m. or 9 p.m. But then he will come with Bataka Bada. He will get something from the road, on the road, and he will bring that, so that we all will eat, and then he will give us the lecture. He will give us the talk. Oh, that was Dr. Denish Patel. He will look after us very well. He did look after us very well. He developed that institute, encouraging research. He strengthened the teaching program, patient service, and research activity. Sensitive poet as well. And he had the translation done, Marathi translation done on these books as well. This paraplegia safari is a concept which he brought. And what does that mean? That those patients who developed the paraplegia or who were treated at Paraplegia Institute, which is headed by our Dr. Piyush Mittal, and that's going to be the new project which was just yesterday only newspaper had. So he will let us travel, we all will go into this ambulance and we'll visit the patient. How is the patient doing? So that was Paraplegia Safari. MM Prabhakar sir gaya? Okay, sir is there. So he was also, the party to that as well. So that is something, sir's concept. I think Prabhakar sir, are you there? No, I don't see you. But anyway, a great teacher, had professional and teaching experience of more than 41 years with various government and non-government institute. A funny story, which is worth, it will make you all laugh. So there will be people coming from Gandhinagar, and they will make noise to see him. So what he will do, he'll sit them in the comfortable room, and he'll ask them to undress for the examination. And then he will see 15, 20, 30 patients, because that guy cannot dress again and come out. So that is something which the strategy he used to do. So, there will be a big crowd of patients. So he will, because that guy coming from Gandhinagar will want to see him immediately. So he'll make him undress and sit in the room. And then he will say that now you don't see, then he will stay there. So there will be pressure coming from all over. So that was something which was his way of tackling as well. He retired in '89 from Civil Hospital. The first incident of the history of Gujarat University, we have the gold medal of Denish Patel, and now we have Dr. Pankaj Patel gold medal as well. He inspired the student as well. So that's administration, education, and that is service to the patient. So well-balanced aspect, multidimensional personality, more than a doctor, poet, cartoonist, travel, photography, literature, and multilingual. He knew languages like Bengali, Madam was from Bengal, Marathi, Swahili, and Urdu. Jindagi badi honi chahiye, lambi nahi. That was his theme which he used to talk about. So these are his couple of cartoons which I have the book as well. And these are the cartoons which he would say, now I will summarize the benefit of those who could not keep awake semi-darkness during my multimedia presentation. This is the book which he wrote just before he passed away. That was his. The most important thing which he did before he passed away, a month ago, he had gone to the BJ Medical College, the anatomy department, signed that I will donate my body. Somehow he probably came to know. We lost him while he was in the bathroom. He did not open, then we just had to break the bathroom door. So he donated his body at BJ Medical College. So that is something which is the student, and that they are all standing in the BJ Medical Porsche. So service to the society never ended, nor with the end of the life. He started again journey with the student in the form of by donating his dead body. That is Sir, welcome sir. That's a student of BJ Medical College talking about this. So messages from his life: be more dedicated to making solid achievement than running after swift synthetic happiness. Devotion, Dinubhai, indomitable spirit, inspiring, noble leadership, and untraveled path. That is Dr. Dinubhai. He will remain alive within the heart of many. So I request now for the oration. Thank you very much.
Thank you so much, sir, for an introduction. Now it's time to introduce Dr. Denish Patel, orator, Dr. Sudhir Dubey, who has been mentor for many neurosurgeons, spine surgeons, and personally my mentor as well, and who taught me first time MIS system in 2013 at Ramaya, and Dr. Subir Jhaveri will introduce Dr. Sudhir Dubey.
So, Sudhir Dubey is a name that I doubt many of you would not know. He is already a man with a big stature. After his MBBS from KGMC Lucknow, he did his neurosurgery from NIMHANS, Bangalore, and at both places he was awarded the gold and once he had the silver Jubilee Award. He was one of the first Indian neurosurgeons to have received the Young Neurosurgeons Award from the World Federation of Neurological Societies. Having mastered neurosurgery from India, he went abroad and continued training at Pittsburgh, Denver, Boston, Sydney, and then eventually he started his work at the Bhopal Hospital and developed the neurosurgery department there. From there, he moved to Delhi to the Max Balaji Institute, and now is currently the chairman at Medanta, the Medicity in Delhi. He's leading the endoscopic portal neurosurgical division, and we have all seen his videos yesterday when he did his excellent presentation. He has also been involved in other non-surgical research as well, and he is a visiting faculty at multiple institutes across the world. He is also the chief editor of the Indian Journal of Neurosurgery and has been involved in multiple, as a director as well as a faculty at multiple cadaveric training programs as well as surgical live workshops. He's also one of the pioneers for functional and epilepsy surgery, and these are the trainees that he has trained over the years. So he has been a fantastic mentor, trainer, surgeon, all built into one. So I give you Dr. Sudhir Dubey, the astute clinician, surgeon, academician, and a chairman. Please.
So, few words, means this is something I'm talking from my heart. Rakesh called me, so I am here. I don't deserve these accolades. I'm just a student like you. And I had no backing in my life. I have just took one step at a time. So everything is one step at a time. So I'm just taking you through, I'm not showing you some brilliant surgeries or brilliant anything. I have traveled over the world and I have seen world change. In the past, I've been traveling from abroad for past 24 years. COVID has changed our world, and India also has changed. India changes when somebody kicks your ass, and we have been kicked very badly in the past few years, and we as a clinician should realize that we have to take the medical progress forward. And we are the people, one by one, if we are in the community we work, we will be the leaders, or we will always be the followers. You can take some examples. COVID vaccine, we are still the followers, though we supplied it, but it was designed at Oxford. We have been kicked just now in defense in this operation, whatever happening the worldwide. We are doing some actions for it. The oil getting not imported, we are changing. We have been kicked backside. And as the world goes forward, in next 10, 20 years, there will be more fights. But as an evolution of a society, we all have to evolve in a communal way. So I'm just taking you off my, whatever I have learned over a period of time in teams, because Rakesh was insistent that I have worked in teams and what the team should look like, I should talk about that. So I'm talking about that in this lecture. So this is my team. I have these young people. One of them, Deepak, you will know, he can do all surgeries as good as me. And he is a future leader for all these things. And everybody else in various stages will be the leaders in years to come. And these are my present legacy, but team will always grow, and you have to make people also grow. So I have traveled a lot, but I have stayed in few places for more than 3 months, so I will just tell you my examples of that. And this is where I belong to. This is National Institute of Mental Health and Neurosciences. So this you can see is a lake or water body. There's a turbulence in the water. There's a lotus which shows passion, and there is a moon which shows heavenly, this spirituality and going up. So we are all on turbulent waters looking at passionate things, but deep down in water there is a calm. So we should all try to achieve an internal calm which is there. So this is what Nimhans has taught me, and it has taken me forwards. And I have to be thankful to some people. I have learned from people who have suffered because of me. I have learned from people who didn't suffer from me, but they were always came back to me. So it's very important that you should always maintain a human touch, so that people, even if they don't make you better, you don't make them better, they still come to you and tell you and give a feedback. This changes you in life. And all my teachers means there are so many things I learn every day. I come to a conference, there are 10 things I learn new, and I can take that into practice. All have been my mentors, and I was here at that time. This was not SAG. I have been here in Ahmedabad at 2009. There were around 50 people. Dr. Dubey was the president of Bhopal Orthopedic Spine Society at that time. And I have been here so much time back. So just to let you know, if he remembers, I don't know. Dr. Chala was also there. So at that time. I believe monkey can become a neurosurgeon. My professor used to say that whenever I used to do a mistake. And if you train a person very perfectly, they can become a neurosurgeons or surgeons. And if I can do a surgery, I believe everyone else can do a surgery. It's just a question of your dedicating yourself enough for the anatomy, for the concepts, and having some mentorship. See, sometimes you have to visualize things. These days, cadaver lab has become so much common in usage, but previously it was not. So cadaver labs, mentors will change, and you can do whatever any other person is doing. Knowledge is the basis for everything. Opportunity plus prepared minds gives excellence. If I have all the knowledge in the world, if I don't get an opportunity, I will never be excellent. And if I don't have a prepared mind, whatever the opportunity is given to me, I will be nowhere. Something that does not break you makes you, but some things that breaks you makes you even more. So always take your failures as your strengths. And I will get personally very bored if I do the same thing years on years. You have to change. Change is the only constant thing. The way we used to practice 2 years back, if you're not doing the same thing, then we are doing something wrong. So things keep evolving. So evolution of my thoughts on the teams, I will just take you. I did my this thing, MBBS from King George's Medical College. The best team was general surgery. They had subspecialized. There was a cohesion. There was some politics also. And that team you will always remember with warmth. Medicine, they didn't used to talk to each other. They were subspecialized. But you won't remember with that warmth. Orthopedics was an excellent team. But what used to happen, people used to sit in hierarchy from that row to the front row, and a question used to be asked from intern to first year, second year, and whatever, and in the end, the third boss also used to stand. So, though it was a well-knit team, but it was severe hierarchy, and there was a problem with that. So, general surgery, I still remember, they were all friends, and they were always this thing, so you will always have a warm emotions about those things. Next, I traveled to Bangalore. There were 3 units. There was strict hierarchy. Youngsters were suffocated. Young surgeons means who were young faculty, they were not given enough cases. And there was a problem with that. What used to happen is they used to suffocate. The frustration used to get brushed down. But it was an excellent opportunity for young residents. What used to happen, that boss will talk to you directly. You can do more cases than your young assistant professors. And that was there. But there was still a cohesion there. And now the things, because there is a lot of seat which has increased, things have changed, and now the younger faculty is doing more jobs, and they are more active, and they have become much better. Then I traveled to, I went to 2 places. One was Sri Chitra Tirunal Institute of Medical Sciences in Trivandrum. These had subspecialty courses, and they were more advanced compared to any other institute in Indian, this thing. They were doing but there was the attitude. So what has happened to it, that institute also has gone down over a period of time. These are personal opinions, so means if somebody is an alumni, please don't take like that. It's my thinking and it may be totally wrong. And then my surgical life cycle, for everyone it starts as a young faculty. You build practice, you get an operative exposure. So for that, I went from Bangalore to Bhopal. There was a gas victim hospital with all the equipment. It was a very beautiful hospital managed by Supreme Court of India. Went into politics and got spoiled. But there I learned a lot of things. It was that when I went there, the spine was in very much discredit. Reason being, in 2000 year, they purchased the first spinal endoscope of India. And the surgeon was doing an endoscopic discectomy, and he pulled out an intestine from that area. So patient had a perforation, and patient had a surgical problem. The gastro department was very anti-neurosurgery at that time, and there was a lot of bad fame for that case. When I went, I saw that patient was so psychologically affected that in spite of this he had a colostomy and he said he could never walk. So first thing I did for this patient was, I told them I want the colostomy to be closed and then give the patient to me, I will take care of him. Disc had already come out on MRI. They just closed the colostomy. Within 3 days, he was walking in the ward and then in the hospital. Previously, he was a bandwagon, a flag that you have to make people become paraplegic after this thing. And the same person is now ambassador that he's doing very well and doing his activity of daily living. That one thing has changed me, and that changed the hospital and my thinking of neurosurgery. So patients are your best ambassadors. That same man who was a kind of a blot on surgical techniques became the ambassador for it. So that was it. From here, I went to New York. New York, at that time, US was more open. People used to welcome you. They used to interact with you. And then there I found out that in 2000 onwards, they were doing subspecializations. There were people who were subspecializing in modalities which were very new, like endovascular. I went for endovascular training. I can do angiography. I can coil an aneurysm also, which I'm not doing anymore, but I got trained in 2000 for that. So the thing is, in that place, I found 4 years people who were senior to me were doing new modalities, and people on top were supporting them. So this is something which opened my eyes that it is possible to develop new strategies, new thing, but until the old people give away and come and give a younger person the opportunity, this is not going to happen without that. So it can change, and we also in India have to evolve into more of this. The next thing which I went to was to Pittsburgh. There I did an endoscopic skull bake fellowship, and there was a great team in Pittsburgh. Pittsburgh is a well-known hospital for neurosurgery, in which what they used to do is, first, they were leaders in radiosurgery, then they became leaders in skull-based open surgery, then they became leaders in endoscopic skull-based surgery, then they became leaders in functional neurosurgery. And they always used to kick out the chairmen after a few years. When they used to become bigger than UPMC, the team used to get kicked out, and a new chairman used to be brought in. So this used to happen there, and that's why the team, though the name of the institute has stayed, but it has not reached that level that it could have reached that at the present day time. Then at that place, because I was there for a year, I went to different places. I went to Mayo Clinic, Cleveland Clinic, Johns Hopkins, and Barrow. So every hospital was not the same. If you look at American ethos and hospitals which have done good work, everybody has to define their ethos and whatever they want. So if you have Mayo Clinic, there is all people together, means doctors have to be together, they have to be very close-knit, and they have to do the best work for them. The Cleveland Clinic is known for quality-based outcomes, so they will always look at the outcome data and talk something about it. Johns Hopkins, they integrated a lot of technology into this, and Barrow took the vascular work to the next level. So all these institutes had a different kind of ethos, but they were all searching for excellence, and a lot of these institutes have stayed there. when a UPMC has gone up and down, but these institutes have stayed there and they have been able to practice in different ways. The next cycle for me came when I had done a lot of work at Bhopal. In Bhopal, I had the privilege of gas victims coming to me, and I had free patients, and I could do all the best surgeries in the world for them. The government, the Supreme Court-led funds used to support those things. So I'm very thankful to people of Bhopal and the gas victims, because a lot of surgery I learned there. But one thing, one of my colleagues who was there for 1 year, he taught me that your patients have to answer you. You have to get a feedback for your patients. So till now, I maintain my feedback book in which the patients will tell me what I have done for them. And if I am very busy and my practice becomes very busy, I will see the feedback becoming less. And when I work very hard and if I am there all the time, then I see my notes become very exaggerated. So you can also maintain a feedback book which will help you to gauge what the people think of you. It will make you better. Don't take criticism. See, criticism will always come. Take the points where you can change yourself, and which is very important. Now, next I was in Max. There I had the opportunity to meet Dr. Shah, who made a neurosurgical unit. But the problem with corporate hospitals, which I still find Dr. Trehan is there, who's a cardiac surgeon who works very hard compared to all of us. I met these people. So corporate hospitals, the problem is they open with a motto that they want to start with a big thing. And then after a few years, then what happens is it's the profitability, the change, there's a change in ethos of the organization and everything changes. So they find it very difficult to reinvent themselves until the competition kicks in. And when the competition kicks in, things changes. So we have yesterday's news, I was sitting here, I got a call from Dr. Trehan. He rarely calls. If he's needed, he calls. So there's a hospital coming around 5 kilometers from us. So they are just poaching teams. So he made me a member of governing council of this thing. So that is what happens. So this is all, you have to understand that these are all show-offs. But in the end, your team is very critical to you, and what you develop and what you take your patients along with you is the most important thing. You may work in your own hospital, your own setup, in corporate hospitals. What you do to your patients and what you do to your team is the most important thing which will carry you forwards. Now, at the present time, initially I worked under a team, then the team though I was the first person to tell that all my colleagues should be treated equally, people leave. And when the people leave, the team ethos changes. So the team leader has to be very strong. And team leader should be equipped in doing everything, but he should also take more pain compared to other people. And he should be able to give more than to take more. So that is very important for team to stay together. So after that, I went to one hospital, which is Vurudul Hospital, and it was very interesting. So what happened in this hospital, there was always this thing which you are seeing on the left side was written everywhere, that a patient comes, we will treat you with PLD. If you fail, we will do an interlaminar endoscopy. If you fail, we will do microdiscectomy with Diam. If we fail, we will do laminectomy. Their patients, we used to walk on this thing, and they will always, the Korean people were ready for so many surgeries, which in India, I think, is not going to work. So they had this, it was printed in there, this thing. So I'm not making it up, it was printed, and I've seen this, reading all this. So if you have pain, we will solve your problem, whatever happens. So that is what they said. So don't worry, patient, we have the next solution for you. So this is what their thinking was. So, but I learned a few things there. They were very good people who used to deliver good results with endoscopy, exceptionally talented people. There were people who were subspecial, and they subspecialized. Like there was an A-lift surgeon, O-lift surgeon. They had, at that time, they didn't used to do a lot of portal work, but they had open P-lift surgeries, and my T-lift was not so common at that time there when I went to them. And PLD and everything, they were masters. They can do in oral. They used to do 40 cases every day, and they was good. But the hospital has not, because what happened when you have so much out of structure, so many people, then you lose that. And in the end, the hospital is not kept that level of care compared to it was at one point of time. I've also gone to China for 3 months. I have stayed in Beijing. And there I found that surgeons were quite experienced, and the senior surgeons had visited the world. And they were all worldly wise. Then there was a second rung which was made up of young people who didn't speak a lot of English. They were all Chinese. But the senior surgeons were always involved in surgery. Means the juniors, the hierarchy was very strict like us. And they were like medical colleges also like us. They were allowed private practice. So they went to private sectors outside and used to operate the waiting list patients or insurance patients. So they also had some 10% which was insurance patient, and they could operate outside. So that is what is there. So our Dr. Trehan has sometimes told me that he likes to watch Animal Planets. That is what he likes the best. And he says that the doctors either behave like lions, and either they behave like elephants. So lions, what happens is, there's a pride which gets made. The old people, when they become old, then a new pride will come in, and they will replace the old pride, and that's what happens. Elephants are more intelligent. They stick together. They have long memories. They have cultural memories, and they build forests. They build long-lasting this thing. So the area where they live in, they build forests. So if elephants are there and they are roaming around in the area, it is going to be green, it is going to be like this. So that's what he thinks. But I think administrations are like wolves mostly, and that is what happens. COVID changed us. COVID really changed us, and I've told it has changed the world. So I really mean to say that we should collaborate, and we should produce our more literature from the science by collaboration. In US, recently a new thing have happened. The mortality data has become open for all diseases. The morbidity data has become open for all diseases. So people can do publications very easily, and they have a lot of this thing. So our USP is number of patients. But if we don't collaborate, we won't be able to publish to that extent. But we can all do that, because at one point of time, I used to think why the government is making so many neurosurgeons or orthopedic surgeons or various specialty. But if you look at the graph of our economic, as we are advancing, all people have space, and you cannot do all the cases on yourselves. So you require people, and there's work for anybody who can just stand with 2 hands, eyes, and a brain, and you can get work. So it's not, but training has to be proper. Your responsibility towards patient has to be proper. So building a sustainable spinal surgical center of excellence, what is actually the challenge? So you have to have a clinical productivity, you should have finances, you should have quality. If you don't think about quality now, you are not going to be very successful over the long run. You have to have academic output, you have to discuss it out so many times. See, CV Junction, what we used to discuss 10 years back, we are discussing it entirely differently today. What disc diseases, which we used to discuss long time back, has become changed. Even the extent of disc removal has been now debated so much. So a lot of things have changed, and they go on changing. Innovation is always the key, and we can innovate. Thank God our ecosystem is getting made. I went to China, their ecosystem is 10 years ahead, but we are on the place there. We are going to reach there. So we should also innovate and do this thing. And training of future leaders is very important, and these societies take an important role in that. So I think we should all have 5 minutes youngster sessions like rapid fire, and we should have senior faculty sitting on front for all the academic conferences in our country. And what we will build now, we will see the effect in 20 to 30 years. Always remember that it's not a fast game. It is not like you can bulldoze. It's not like you can bomb 2 weeks in Iran and you will get the solution. You will never get a solution like that. What you have done over the years and months and preparations is that what is going to happen. Most surgical groups do not fail because of lack of talent. Everybody is talented. They have different talents, different strengths, different everything.
if your incentives are not there, working in a team, working together, if you have ego conflicts, if you have unequal workload distribution, you have lack of succession planning. All seniors should have a succession plan. If you are a senior, you should know that if I go, this is the succession plan. And if it is transparent, your institutes are going to grow. Your practices, wherever you are in corporate hospital, self-owned hospital, small nursing home practice, think about it. Group has to be there now. The new legality, New India wants a group of people to treat them, not an individual to treat them. Absence of shared vision will have a problem. So talent into trust with shared purpose is a sustainable excellence in spine surgeries. The 3 pillars for your success will depend on a team success, clinical excellence, and economics. So economics comes from direct things and indirect things. So you have to understand my minuscules of dynamics of economic strength and academic future, and everybody should be presenting their work. Everybody, small unit, something you should always present, because when you present something, you read something about it. Your insights become more, you become more sharper, you become more quicker. So that's what happens. So that is very important. My practice, if you have a vision that it is my practice or our institution, that changes how your group practice is going to change. And work-life sustainability is very important. So if you have a pure revenue model in a place, then what will happen? There will be a competition, case hoarding, and reduced collaboration. If you have pure salary model, then people will not think about productivity. So you have to have a balanced model. It may vary, but it has to have a base stability. So this also I learned from US. In the first time when I went there, the chairman of the neurosurgery was telling a junior, see, you have this much money, you will come this, but if you want to increase this, there's a veterans hospital next to us, they will generate you this much funds if you go there regularly. So they used to think about the future of this thing. And the best thing which I found there was that I had reached just after my graduation and everything. So a first year student, medical student walks in, and the name of the chairman was John Pop. So he sits cross-legged, and there's some decision which has to be taken. So they were discussing something about a blood clot to be taken out or not. So the medical student says, cross-legged he sits and says, I don't agree with you, Pop. So that's what he said. And I was shocked. He said, cross-legged, sitting in front of the chairman, who was like white-haired and everything. And then John Pop had to explain everything from first step to the last, that why he is doing something till the last. And then the student said, okay, I agree with you, Pop. So that's what it was. And that is what has built their institutions to that extent. So our hierarchy is good, our respect to elders is good, but we should have a transparent communication, two-way communication, which is very important. Case allocation principles are also in the poor system, first come, first served, better system, best patient to best surgeon match. Benefits are better outcomes, better referrals, greater trust. Top 10 team killers are ego, financial secrecy, favoritism, unequal call burden, leadership vacuum, lack of transparency, no academic recognition, case ownership disputes, burnout, and absence of succession planning. Research is a very important this thing, and where we have to take our next step forwards is AI, imaging, and seeing the clinical data about the postures and everything. We have to take it to the next level. And we have an opportunity because we have a pool of patients which is unmatched in any other country. Great programs will have a strong culture, shared governance, transparent metrics, protected research time, leadership development, multidisciplinary collaboration, succession planning. And institution should always come before this thing. I think I have thought about this slide. So subspecialization in spine surgery. Now people may start looking at here and there, but I think time for this has come. And congenital, which will include neural tube defects, tethered cord, diastematomalacia, CV junction, Arnold-Chiari malformation, pediatric scoliosis, CV junction, pars defect, regional, cervical, thoracic, lumbosacral techniques, spine interventions, oncology and vascular, functional, and preventive spine medicines. And next generation spine team has to have this. It has to have spine physicians Can somebody tell me how many causes of backache are there? Offhand. 100, 200, 300, 400. There are more than 250 causes of low backache. So, the leadership principle, the chair director should always have a vision, should be a culture guardian, talent recruiter. You have to be a recruiter. If you don't recruit, you stop at that, you are going into a muddle of non-development, non-progression, non-everything. So you have to recruit more people and you have to be mentor. You cannot be just a case allocator or a revenue manager. The strongest departments are preparing for next generation continuously, and who leads in 5 years, we should be talking about it. Who leads in 10 years, who owns which subspecialty, who's being mentored today, legacy of anyone. Like the oration I'm giving, legacy is Dr. Bharat Dave and all the orthopedic spine surgeons who have evolved here and are standing in a good stature there. So that is the legacy of a person whose oration I'm giving today. This is what he has carried through, and this is what will remain always. This will pass on. This is like a surgical tree where a person influences the surgery of so many people along. So that is what it is. And sustainable surgical excellence come from clinical, financial strength, research, innovation, leadership development, and culture of trust that makes a great institutions. Great surgeons build practices, great leader build apartments. The greatest leaders will build institutions that continue to thrive long after they have stopped operating. The ultimate goal is not to create star surgeons. Stars fade over a million years, surgeons fade over 40 years. The ultimate goal for all of us is to create a self-sustaining ecosystem of excellence and passing the torch along. And we can always talk, can we all any time build a Mayo model? I think it is possible, it will happen. We will change our practices. Better we collaborate, be friends, make more group practices, because that is where the future is going to be. And having more competition is not bad. It is going to make us more better. It will keep us more on toes. And we will be more responsible for the person who gives us the daily bread, the patients. With that, I will thank you for your kind attention.
Thank you so much, Dr. Sudhir Dubey, sir, for giving us excellent talk on mentorship and team. And we'll ask Dr. Bharat Dave, sir, and Amit Jhala, sir, to give a memento to Dr. Sudhir Dubey. We'll move beyond academics, and Dr. Hitesh Modi would invite Dr. Abhay Nene for a talk on fitness and self.
Hi friends, I will not show any slides at the moment, but we often hear doctors tell us that stay active and keep fit. Today's speaker for SAG Annual Meet, a special talk, doesn't give that advice, but he lives at the highest level. Dr. Abhay Nene is one of the Mumbai's most distinguished spine surgeon with over 28 years of experience in complex spinal reconstruction and pediatric deformity surgeries, a globally recognized academician and a receiver of Educator of the Year 2018 award by AO Spine, and currently chairing the chair of Asia Pacific region of world's leading organizations. However, what makes Dr. Nene truly remarkable isn't just his work inside the operation theater, but he is an endurance athlete who has pushed the human body to its absolute limits. On the feet, he has completed over 20 half marathons globally. On the wheels, he has cycled perimeter of Iceland and conquered the world's toughest routes from Manali to Leh, reaching at the altitude of 17,500 feet. On the peaks, he is a high altitude trekker who has summited Stock Kangri at 20,000 plus feet height and reached to Everest and Kanchenjunga base camps. He even uses his fitness for a cause, having completed 60 hours non-stop relay cycle from Delhi to Mumbai to raise rupees 2.5 crore for cancer children. Additionally, when he is not saving lives in Operation Theatre or scaling mountains, he also serves as a consultant for the Olympic Gold Quest, helping India's top athlete maintaining peak spinal health. And for a touch of creative balance, he moonlights as a guitarist and vocalist for the rock band The Funkies. So, friends, if we discuss about his age, he is 4 years senior or elder to me, but on his accolades, he is 40 years senior to me, but if we see his fitness, he is 40 years younger to me. So, friends, please join me welcoming a surgeon, a scholar, a musician, and a true champion of fitness, Dr. Abhay Nene, to deliver his talk. Thank you.
Gujarat is truly my sasurala. My introduction was very, very elaborate. You look at me and I'm nowhere close to that. And I'm not a Gyancho, so I'm here basically to discuss why a surgeon should be fit. And at the helm of it, we all want to be the top of the heap. We all want to be the #1 spine surgeon. All of you, think about it. Your main goal is to be a good spine surgeon, okay? And the question is that, being a skilled surgeon, are you born with that art or it's something that you acquire? And that's something you got to think about. There's some things that you can't change, but there's some things that you can change. Think about what a good surgeon needs. And you would all agree that these are all the attributes that go together to make a good surgeon, whichever specialty. And you will realize that most of them are actually physical attributes. They are not, they are not inbuilt or natural talent, which means that fitness becomes a modifiable trait to improve you as a surgeon. It's a modifiable trait because all of us can turn our lives around and, invest into fitness. Right now, I'm going to sit here and say that all of us, as surgeons, we are medical sportsmen. Okay, we are not the physicians who use brains. We are the hand, touch, feel guys, all right? And if you think about what you need, just like a sportsman, you need long hours of focus surgery when Sachin is hitting 200. You need a steady head in tight spots, and you need to be aggressive when it's needed, right? So all these are sports traits. All these are traits that come out of sportsmen. And if sportsmen can spend man hours working on their fitness, besides working on their talent and their sports, there's no real reason why we shouldn't be doing that, all right? We are on a constant roller coaster ride. So this is all about the physical part. What about the mental part? Like when this patient came to me, a hi-fi, very senior politician in Bombay, and I had to do this with 5 surgeons watching, my life was on the edge because he could wake up, with anything. Worse was this situation where I put a cage which went into the heart. I mean, we are always on this roller coaster ride. Nothing that we do in life is easy. It's a very, very high stress job, and we need to bring our best game when the chips are down. We need to be making quick decisions when you're cornered, when your face is in the sand, you're expected to come up with the best answers, right? And we don't have a second option. High performance is our only option. So the second thing I want to tell you is how can you acquire Zen state? If you can produce your best results when you're at your worst, when you're in the zone of discomfort, you will probably be known as the good surgeon, okay? And according to me, facing adversity in controlled conditions is what gets you there. So besides working on your physical fitness, to work on your mental fitness, you need to really push yourself and spend more and more time in what we call the breakdown zone, in the zone where you're completely destroyed. And, that's when you can think better. And my proposal to you is that these are the 3 activities that will actually help you get there. So it's long endurance running, it is endurance cycling, and it is high mountain summits. Because all 3 are breakdown zones at some point, and they're all under controlled conditions. If you can't do it, go home and, chill. There's no problem. And this last pitch that I'm going to make before I really launch into why you should or how you should be fit is that when you look at the generic of what people want, You see that the young guys, when you're in your 25s and 30s, you want to make a lot of money and buy a car, etc. When you grow older, you want more time with the family. But most of us at my age, that is 50 and above, would have preferred to have better health. Okay, so don't wait till it's too late and invest in fitness. So how do you convert yourself from a couch potato to a relatively fit guy is what my next few slides are going to be about. And some of it will sound vain. It's vanity. It's about what I did, but it's being put out here because if I can do it, you can do it, right? I'm not a born fit guy, and neither am I fit right now. So the first question is, how do you start? So all of you out there who want to invest into fitness and are really, the inertia is too much, you got to start tomorrow or tonight. You can't wait till, after the rains I'll start, or I'll start once my list this week is over. It has to be done now. And for that, you really must want to do it. Like, unless you want it, you'll never change. You need to step out of your, regular comfort zone. And you'll have to set aside 3 weeks for a very, very easy, simple activity, like a 30-minute walk, 3 kilometers, 5 days a week for the next 3 weeks. If you do that, it becomes a habit. Something that you're forcing yourself into slowly becomes a habit, and this is what we call the exposure before the surgery. If you can just do that, something which is attainable, sustainable, something that you can work with, and all of you can do it. You can do it at night, you can do it in the morning. Set realistic goals. Don't suddenly say that I'm going to, do 200 floors every day, or I'm going to, run 5K. Just start with something that is very, very doable. And at the same time, when you do that, naturally you start counting calories, because every time you finish that 3K walk and you come and see, oh, I just burnt like 170 calories, and one samosa is like 300 calories, right? So you start then comparing, and you automatically start working on your food, because food is, in a way, it's a sin for all of us who are, senior. Our metabolic rates go down. We do not need 3 meals a day, and we indulge. So, you'll start thinking about it. It's easy to link because all of us are busy, we are really stressed for time. So what I do is what I like to do, like I like to listen to music or, watch some sport. I normally link my best performances come during the World Cup or during, the cricket matches, etc. Because I really have like 1 hour watching TV and working out. So you don't sit on your butt and watch TV. You work out, sit on a cycle and watch TV. So link it to an activity. Some of you may be, liking to watch CNBC or economics or Share Bazaar or whatever you like. Do some activity when you're doing that. So if you link it, then it becomes very, very sustainable. Make it bunk proof. How do you make it bunk proof? Which means that I decided, but tomorrow I copped out. That's our regular story, right? So so the trick I use, or what I suspect that you should use, is announce it. So if I'm doing a 5K run tomorrow morning, which could be really nothing, but I'm going to reach home at midnight. So there's going to be 20 reasons when I wake up to say that forget it, today I kal karta hu. But if I've told my friends or told my wife especially that tomorrow I'm running at 5 a.m. I'm running 5K, there are going to be questions asked if I don't do it. So the collective responsibility increases. So announce your, I actually put it on social media that I'm going to the Dolomites to cycle. And then that becomes a huge external pressure for you to perform and to do it, because people will then ask you that how did it go, what did you do? By the 4th or 5th week, you can add sport, because all of us have been sportsmen as children or as kids, badminton, tennis, cricket, football. So once you start engaging in this fitness, you can add one sporting activity which will make it more fun. You can join the net, cricket net. Add gymming, because gym is not a sin. A lot of people have a myth that gym is bad, but gym is actually designed for fitness. So everything out there is ergonomically designed for you. The advantage of gymming is no matter where you go, there's a gym in the hotel. So wherever you go, there's no excuse. It's a rain-proof and it's a time of the day proof activity. So learn the basics of gymming. I learned it by going with a buddy who taught me how to use different equipment, what is safe, what is unsafe, and of course you use your basic orthopedic understanding to add freehand exercises. This slide is especially put up here because no matter you run, cycle, gym, lift weights, mountain climb, you need to have your spine strong. And if you don't walk the talk, so if you don't do these yourselves, how are you going to tell your patients what they need to do to get their back pain off, right? So your abs should be the most ripping abs in the room. And if that's true, then you can preach your patient what they need to do. Of course, remember that at 50, you still need to have certain things with you. I've done my own cardiac CT before, about 4 or 5 years ago, and I'm probably going to repeat it. So don't take it for granted when you're 50. If you're 18 and you start exercises, that's different. A weighing scale helps because if you're overweight and you're running, you're going to damage your back. And diet, because I think 80% of people in this room, including myself, are vegetarian. And you know our diet is carb-rich and protein deficient. So if you just work out and not consume proteins, you're going to burn the muscle and not reform it. So again, it's not a myth. You can find natural protein. You don't have to buy this fancy dabba. Good old sattu has adequate, adequate proteins. Always buy a heart rate watch or a Whoop. And then up the ante. So once you've got these 6-8 weeks of what we call exposure, basic stuff, then especially in Ahmedabad and in Gujarat, there's a huge running cycling culture. So it's one of probably the leading states in the world for running and cycling. So just join a club. And the club should have people who are better than you. So you should not be the famous doctor who's joined them. You should be the last guy who's like the Shendi who's just joined and people are pushing you up. Always be the worst guy in the room. Then you get better. If you're the best guy in the room that you walk in, then it's no fun. 5K, 10K marathons happen almost every week after the summer's over. So you can set those goals. For me, the target was, so this is a bit of vanity, but sorry, endure it. It'll build your appetite for lunch. It was about breaking the time barrier. My first half marathon was 2 hours, 34 minutes. And then I did at least half a dozen sub-2 half marathons. And then what I do is wherever in the world I'm traveling, I carry my running shoes and you can't see a city better than when you're running. So, you land, and also it breaks your jet lag. So you land in New York at night, just get into your shoes and go for a run. You'll see the city, you'll get familiar with the area, you know how to handle the, next few days, and your jet lag goes away. And then you can run all over the world and, tell people. I normally run at conferences. So if it's a conference outside India, then I pick out a marathon that's there, around there, and try to do it because the weather and the road conditions, etc., are much better. To run outside India because of the weather, obviously. And then the second part is what, our organizing chair does so well, Dr. Rakesh, and that's cycling. Because most of us are senior, we have some back pain, some knee pain, so we sometimes dread high-impact activities. Cycling is one of the God's blessing to 50-year-olds who want to get fit, because it's like zero impact, high cardio, low impact, and gives you solid calorie burn. And if you don't believe me, see the guy who I cycle with. That's my boss. He's 15 years older than me, and we did 100K as far back as 2010, and we still cycle together. And then you start increasing the distances once you get your head around the idea of cycling. And my first race was actually a medical race. It was a cardio association race from London to Brighton. And then I did the Manali-Leh route, which is India's Tour de France, if you may. And it's a tough race, 1,000 kilometers, but it kind of helps you build resilience. And if you see, Anand Joshi is with me, who's now 75 or 73, and he completed it. So there were 80 people, of which 32 of us only finished, and 3 of us, Aditya Daftari is the musculoskeletal radiologist. So it was 3 doctors amongst the 32 finishers, and from Bombay. The Manali-Leh ride taught a lot because there was no TLC there. You were riding on these kind of roads, and after you finish, you have to sit in a tent and wash yourself. This was the Delhi-Bombay ride that I did with these supermen. They're all very, very successful individual professionals. And we rode all day and all night and raised some money. And then, of course, the Iceland ride. But the thing is that once you are able to do this, then you can enjoy the world on wheels. So we've got this group called the Ninja Turtles. Okay, and if you see a lot of familiar faces here. Ninja Turtles are because we can ride at our own pace, at our own time. There are so many spine surgeons in this group. And then we go to exotic locations, Lake Geneva, Venice. You see some places in the world which people don't see because you ride through routes that are not familiar. And I just came down from the Dolomites because I had invested so much in, the ability to cycle. I could see what is the mecca of cycling. That's the Dolomites, which are like the high mountains in the north of Italy. And it's sensational to come back and tell those stories because, very few people in the world would have the opportunity to witness these kind of views. And then finally, I think exploring the world from a top. The best views are at the top. And if you're fit, then you can take up trekking. Again, the place to start is Uttaranchal, then move to Himachal, then move to Nepal and Ladakh. So you slowly ascend because in the lower mountains there's greenery, so you're just building your resilience. But as you go higher, you start building your mind also. And there are some of the top summits that we could do. There are failures also, and they teach you. We failed the Kangyatse summit because we couldn't walk on ice because we are desis from level 0. But then we trained on ice, and then we went back and did some other. And you can see the views; they're just impossible to gauge. And unless you're up there, and then if you go through this kind of life-threatening experience, a vertebral artery rupture doesn't scare you. You can just deal with it because you know what to do and how to handle yourself. So I'm going to say that if you're not sitting on the edge, you're occupying too much space. Don't be comfortable. Get your ass off that chair and start thinking of living beyond spine surgery, because that's the magic mantra. And I'll be left short if I say that that's the only way. Muscle is not the only way alone. I know orthopedic surgeons, we feel that. You have to work on your other brain also. Okay, and the right side of your brain, unless it develops in equivalence with your left brain. So you have to indulge. Again, I'm not a musician. I'm just trying to play something, hanging out with guys who do stuff. Get inspired by people around you. Just look to your left and right and you'll find inspiration. There's someone doing something much better than you. Take that inspiration. And it could be someone as close to home, It doesn't have to be some, one of those great guys. So I'm going to say keep pushing your limits, because your magic will lie outside your comfort zone. And take the leap of faith. Be a lambi race ka ghoda. Thank you.
Excellent talk by Dr. Abhay Nene, and I'll request Dr. Sardhara sir to felicitate Dr. Abhay Nene with a memento. Moderators, please stay there. We'll felicitate our faculties as well. Dr. Kshitij, who had given excellent online lecture, and he could all the pain to come here and deliver excellent talk and lead a session. Dr. Abhidha Shah is here. Abhidha. And now Dr. Abhidha Shah, Professor KEM, she's here and enlightening us with the CV Junction issues. Now, GMC observer Dr. Gaurang Patel is here. We'll request to comment. And we'll request everyone to come forward. We'll have a group photo with all the faculties and delegates. How is the alignment? Not possible? Yeah, please come forward. Yeah, please make it fast, everyone. Now is the next session, which is a free paper session. Dr. Nisarg Parikh. Yeah, there is no break. Please take a seat. There is no break. No. Please take a seat, and we have a next session, which is a free paper session. Dr. Nisarg Parikh would take a lead. Oh, come. Yeah. So you invite moderator. Thank you, sir.
So I would request everyone to stay back, please, because this is a very important session for all the authors, presenters. They have done a great job. So for this session, I would like to invite Dr. Subir Jhaveri sir and Dr. Niraj Vasavada sir to moderate, as well as over there would be. So for this session, we have received 9 manuscripts, 9 papers. The allotted time for every author will be 5 minutes for the presentation, and 2 minutes of question and answer session will be there. More the questions, more intense and more interesting the session can be. So I think we have all the authors in this hall, right? 9 authors. Dr. Sachin Patel, Dr. Karan Chauhan, Dr. Zhalak Sheth, Dr. Margi Pandya, Dr. Mohammad Salar, Dr. Arjit Vashishtha, Dr. Saurabh Kulkarni, Dr. Parikshit Godasara, and Dr. Udgam Bakshi. Sir, Mark. So without wasting time, I would like to invite our first author, Dr. Sachin Patel, to present his paper.
Good afternoon, respected chairperson, esteemed faculty, and my senior colleagues. My topic is a posterior C1 C2 stabilization for the traumatic atlantoaxial dislocation using the transarticular screw and sublaminar wire technique. Myself, Dr. Sachin Patel. Why CVJ is important? Because it's a highly complex and mobile region which connects the skull to the Atlassian axis with the osseo-ligamentous complex. The traumatic atlantoaxial dislocation is an uncommon condition, but it's potentially dangerous condition. It's occurred due to the rotation, force rotation, and the distraction or severe hyperextension due to the fall or the trauma. Why need for the stabilization? Because it's a highly dangerous condition. It's a life-threatening condition which causes the respiration failure, quadriplegia, and ischemic stroke and severe pain. The posterior fixation remains the standard treatment for all the AAD, traumatic AAD management. What is the diagnostic criteria? For the diagnostic criteria, the atlantodental interval in adult more than 3 mm and in children more than 5 mm. The posterior atlantodental interval is, if less than 14 mm, is suspect that there is a AAD. The powers ratio less than 1 also suggests there is a possible AAD. And the dynamic instability on the flexion and extension view suggests that there is a chances of atlantoaxial dislocation. So what is the clinical presentation of the patient? Patient present with the neck pain, myelopathy symptom, and neurological deficit. And what is the investigation required to diagnose this? The first investigation is required is an X-ray, dynamic flexion and extension view, followed by MRI and CT scan. Sometimes CT angio is required if the patient have some vertebral artery anomaly to check. So aim of the study is to evaluate the clinical and the radiological outcome of the traumatic atlantoaxial dislocation managed with transarticular screws and the sublaminar wire fixation. The patient has a traumatic atlantoaxial dislocation. Exclusion criteria is the other non-traumatic cause of AAD like congenital, inflammatory, infective, and neoplastic. The surgical technique is the transarticular screw and sublaminar wire technique. The follow-up for the 6 to 9 months to check for the clinical, neurological, and the radiological evaluation during the follow-up. Patient is prone position in under GA. The garden wheel trunk is applied for the traction. The exposure is for the posterior midline approach from the occipital protuberance to the C6 exposure. The reducibility is checked on the fluoroscopic view. The careful C1 dissection is done for the preservation of the C2 ganglion and the venous plexus. Sublaminar wire is passed, SS loop wire passed beneath the C1 arch with the mixture forceps. Then the transarticular screw fixation is done with the K-wire drilling, and after checking the reducibility, bilateral transarticular screw inserted over the guide wire. So by simultaneous movement of the K-wire, we check the C2, C1 simultaneous movement of the vertebra, followed by the fusion and closure. Loop wire is secured to the C2 spinous process and the local autograft or the allograft placed over the fusion. Wound closure over the drain. Soft cervical collar is applied post-operatively. So here is the intra of IITV image. After the initial exposure, reducibility is checked, followed by the TBW loop wire is passed from the C1 posterior arch. Then with the K-wire drilling is done to the C2 to C1 facet, transarticular. Then checking the again AP and lateral view. After confirmatory checking both the trajectory, we remove the K-wire and insert the guide pin and insert the screw. And finally fix the post-operative protocol with the soft cervical collar is given for 6 weeks, followed by the neck isometric strength exercise, and gradual range of motion is gained. Follow 15-day. The radiological outcome. The case 1 is a patient is a ligamentous instability fixed with TBW loop and the transarticular screw. Second case is a osseous injury fixed with the same. The result with the mobilization done with immediately, followed by the soft cervical collar, and the neck was a significantly improvement. Neurological improvement is return to activity is seen. 1 month for the routine daily life, 3 months for the outside activity, and 6 to 8 months for the normal weight on the head. We can see there is a significant improvement in the flexion, extension and rotation right and left view. The complication we are seeing is the bleeding due to the venous plexus damage, hypostasis as the occipital region, and pars damage, which need to convert to Goel-Sam fixation or the occiput cervical fixation. Other complication which we not encounter during our cases is the wound adhesion, hardware failure or neurological worsening, infection or vertebral injury. So discussion is a Goel-Sam fixation is versus.
Excuse me, you need to stop. The time is over. We cannot let you run beyond 5 minutes.
Sorry.
Discussion, is there a question answer?
Yes, question and answer session will take. Any questions from the audience? So you can the last slide.
So the take-home message is the technique is a safe and effective in the selected patient, is a cost effectiveness, and which provides a good radiological fusion and clinical outcome achieved.
Say in international meetings also, in 2 minutes we have presented and got down. And it is a pride to be there, and we have to honor it. Whatever the situation is there, it is equal for everybody. So it's not just learn, nothing.
So I'll ask a question. So now there are several reports, published literature about, transarticular screws not requiring a supplemental sublaminar wire fixation. So what is your take on it, and why did you choose to do it against what is the prevailing kind of a thing in the literature right now?
Hello. Because there is an instability, but the review is suggesting there is no need for the transarticular screw.
No need for sublaminar wire.
Yes.
In addition to transarticular. Means the original description by Magrel was with the wire.
Yes.
But over time, there are a lot of papers now, they say that, you can do transarticular, it gives as good fixation as Goel-Harms technique. And then we don't use wires with Goel-Harms. So why use wires with transarticular? So what is the reason for you using the sublaminar wires?
Just to sure about the reducibility and the C1 arch reducible or not. So if the reducibility is good, then make the strong construct, nothing the
So you're using the wire to reduce the
C1 arch to the
C1 arch behind.
Are there any more questions? Thank you, Dr. Sachin. Our next speaker, Dr. Karan. Triple guidance for precision, accuracy of 200 cervical pedicle screw placements using OAM, navigation and intraoperative neuromonitoring. Dr. Karan, please.
Hello, myself Dr. Karan Chauhan. My topic is triple guidance cervical pedicle screw using OAM navigation and intraoperative neuromonitoring. As we all know, CPS provides the superior 3-column stability and higher pull-out strength compared to the lateral mass screw, but the technique is demanded due to the narrow pedicle and vertebral artery proximity. Why we use this technique? Because the OAM gives us the real 3D anatomic visualization. Navigations provides us precise trajectory planning, and IONM for the dynamic physiological safety. Our objective was evaluate the radiological accuracy of CPS using this technique, assess intraoperative neuromonitoring reliability, and analyze perioperative safety outcome. Our design was retrospective single-center observational study. We have data of 35 patients, 200 pedicle screws from C2 to C1 around March to May 26. Our inclusion and exclusion criteria. Our operative workflow is prone position in TY anesthesia. Reference frame we fix to the C2 because it provides better stability. OAM scan, then navigation planning, screw insertion, and confirmatory intraoperative OAM scan at the last. Our surgical step under GA prone position, exposure done from C2 to C7, OAM tracker applied at the C2 spinous process. This is our first OAM scan before putting the screw. This is our technique when we first choose the trajectory with the probe, then we insert the high-speed drilling burr into the trajectory. Then we insert probe and confirm with the tactile feeling, and then last we insert the screws in the appropriate trajectory. This is our image after the screw insertion. This is the final OAM scan after putting screws. So we use this classification, Gertzman-Robbins classification, for grading of the breaching. Grade A means no cortical breach, grade B means medial breach less than 2 mm. Our clinical grades A and B is clinically acceptable, grade C and E is increased neurovascular risk. Our result is 148 screws were grade A, no breach, and grade B is 52 screws. 52 grade B breaches, 48 were medial cortical breaches and 4 were lateral cortical breaches. All breaches are under the acceptable, so acceptable accuracy is 100%. Intraoperative neuromonitoring, MEP monitoring in all the cases, continuous free run EMG to detect the spontaneous muscle activity that may indicate the mechanical irritation to the root. We have found one transient alert which recovered after the screw repositioning. Our specificity is 97.1%, negative predictive value is 100%, indicates the IONM, absence of IONM alert reliably predicted absence of post-operative deficit and clinically significant malposition. OAM achieves 100% clinical acceptable accuracy, allow immediate intraoperative correction, and particularly beneficial in mid-cervical spine. Role of IONM is physiological safety net. High NPV makes absence of alert reassuring. False positive possible due to the anesthetic factor also. So causes of the breaches. frame micro movement, registration error, skiving, navigation error, deviation, narrow pedicle, thin medial pedicle wall, vertebral artery proximity, pedicle dysplasia, vertebral rotation. How to avoid secure frame to the very fixed spinous process like C2, repeat O-arm scan after decompression and alignment change, use navigated burr, verify trajectory in axial, sagittal and coronal view, combine navigation with MEP monitoring as a safety net. Our limitations. Conclusion, triple guidance ensures high accuracy and safety, 100% acceptable CPS placement, recommended for the complex cervical cases.
Any questions?
I have a question. Great paper. I want to know, how did you assess your pedicle breaches? Were they the intra-op O-arm assessment or post-op C-arm assessment?
Only intra-op O-arm last after the screw placement.
So you did not have any situation where your intra-op O-arm after putting screws were grade 3 breaches and above?
No.
So you didn't revise any screw at your final?
No, post-op, no.
So all were accurate when you placed them?
Yes.
One question. As you place it navigated, you have a planned trajectory.
Yes.
Have you compared your planned trajectory and the achieved trajectory? There is one trajectory you are planning,
yes,
and then you take a post-operative CT scan to confirm that that is the same trajectory as that. Have you done something like that? Then only it is the exact thing. Intra-op, I understand.
We decide the trajectory intra-operatively, not pre-operatively with the pre-operative CT scan. We do not have pre-operative CT scan.
But how would you validate that what you decided is what you achieved? Without a post-operative final shoot. No, you are not done, there is nothing. I am just asking.
We have 2 O-arm scans. First, before putting screw, one is after putting screw. So we assess our trajectory in the last one.
So in spite of your tracker being at C2, you did not have any situation where your C7 with screws, which is quite far from C2, had any problem that you detected in your post insertional O-arm picture?
No, sir. As we all know, in navigation, when we go far away from the tracker, the accuracy decreases. But the C7 has also a very strong fixation as compared to between C3 and C6. So the movement during the accuracy humbles due to the movement of the vertebra during the drilling of burr or putting the probe. But C7 has a very fixed, and we do not have any problem regarding C7. Yeah, we are very far from, but we do not have encounter any problem during C7. But in a
normally when people use one tapping needle, one drill, if you are using navigated drill, it becomes more accurate compared to tapping because of movement.
Yes, sir.
But all these navigation have an inherent problem. So the next generation navigation, which is going to come this year, is going to have subsidiary. You have to put some other screws at the subaxial spine, and it will segmentation will come into that navigation. So it's already been made. It's going for FDA approval. So they will be able to even do this segmental movement. This thing, yeah. So it is already made, and it is going to come. I think this year or next year it will be in India also. Thank you.
Okay, thank you. Next speaker is Dr. Jalak Sheth. Her topic is role of intraoperative neuromonitoring and efficacy of signals in cervical spine surgery.
Hello everyone. My topic for today is role of intraoperative neuromonitoring and the efficacy of signals in cervical spine surgery. Introduction. INM provides a real-time neural assessment also reduces the neural complications, enhances the surgical safety, and widely used in cervical procedures. What is the aim and objective of the study? To assess the efficacy of the IONM, correlate the signal changes, and also to determine the predictive value. Material and method, it is a retrospective study. 160 patients were analyzed from 2016 to 23, and it is a single center surgeon performed the surgeries. What are the inclusion, exclusion? 18 years above patients were taken. The cases which were included were myelopathy and stenosis cases, and excluded were the trauma and the tumor cases. What is the IONM protocol? The IONM was performed using two systems, Exceltech and the Medtronic system. The monitoring was done from the base of the intubation till the extubation time. Baseline was taken. TC-MEP monitoring was done. Mainly we have focused in the study on the monitoring of the TC-MEP rather than SACP. What are the alert and warning signs? 50% drop in amplitude. What are the muscles that has been monitored? For upper limb, we have taken the following muscles: trapezius, deltoid, biceps, triceps, and abductor pollicis. And also for the lower limb muscles has been included. These are the main outcome measures which have been taken. Nuring scale was used for grading systems, and also the Japanese orthopedic scale was used. What are the surgical procedures? These are the commonest cervical procedures in which there is the role of intraoperative neuromonitoring frequently being used. Following are the steps which we do during the monitoring in the cervical spine procedures. First, we take the baseline. The baseline gives us the accuracy of the signals, that how accurate my results are. Second is during the patient's positioning, from anterior to supine or from supine to prone position, what happens is that leads to the cord compression if the neck position is not proper. This has the main role importance of TC-MEP monitoring. The other is the anterior cervical cord compression. Next is the C1, C2 fixation. These are the results. The main role of the paper was that it says that stable IONM signals is the highly predictive value. That role of intraoperative monitoring is very essential in cervical cases. Clinical applications. These are the few images of our study. Role of IONM always justifies the early warning signs and the alert signs for the surgeon if there is any malposition or any issue during intraoperative. These are the literatures. What is recommendations? Routine IONM is in high-risk surgeries is more beneficial right now. Use of multimodal techniques, like if you include trauma and tumor cases, we can also go for D-wave monitoring with combined techniques of TC-MEP, EMG, and SSEP with D-wave included. These are the limitations of our study. What is conclusion of the study? IONM significantly improves the safety in the cervical spine surgeries. TC-MEP is the most effective one as it monitors the cortical spinal pathway. Our motor pathways have been monitored. High NPV is already the beneficial part to predict that post-operatively the patient is with no neurological deficits. Thank you.
Any questions?
So, madam, you must have noticed that there would be sometimes when you get a patient of myelopathy, and they have sometimes a fixed neuropathy as well. So what are the different neuromonitoring signals that you are able to pick up, and sometimes what happens in myelopathy? Can you just elaborate?
Yes, sir. Sir, in myelopathy cases, when I take the baseline, already my amplitude has been reduction side, which justifies that there are the severe myelopathy cases. In myelopathy, my motor deficit is already present due to some neurological deficits. So that will lead to my MEP drop.
But during intraoperative manipulation,
Yes,
manipulation in those reduced cases,
Yes, sir.
does the rule of 20% or 50% drop still apply?
Yes, sir, it still applies. Because on the basis of 20 and 50%, we come to the conclusion that what post-op my patient would be in the better situation, like what is the neurological effect on the side. So it still applies, sir, in myelopathy cases. But it is according to the grading scores, which I mentioned.
So
yes, sir.
I have a question.
Yes, sir.
In your experience
Yes,
with
sir.
electromonitoring in myelopathy patients,
Yes, sir.
have you correlated any time during your intraoperative improvement in signals and clinically meaningful recovery for this patient post-operatively? I think you have not noticed that, how many patients actually showed improvement in your signals and whether there is any clinical correlation with that.
Yes, sir, I have observed that thing, that actually what is our baseline monitoring values, we get improvement at the time of post-decompression or at the time of rod fixation or during manipulation with spinal cord, we get better MEPs from baseline. That means that is increase in our amplitude. And post-op also, when we see on the day 1 or the day 2 post-POD patients, they were comparatively reducing their symptoms like back pain, leg pain or radiculopathy. That has been decreased. So it has been observed, sir. Thank you, sir.
Thank you, madam.
Thank you all.
We move on to the next next presenter, Dr. Margi Pandya. She'll be speaking on functional recovery following cervical spine surgery, pre-post analysis of disability, neurological status and independence using NDI, MJOA and FIM.
Hello, good afternoon everyone. Myself, Dr. Margi Pandya from Zydus Hospitals, Ahmedabad. My today's presentation is about functional recovery following the cervical spine surgery, role of standardized physiotherapy rehabilitation protocol. Yes. So cervical spinal surgery often is being done in the patients with the cervical myelopathy. Before getting operated, patients often land up with the cervical problems such as the neck pain, disability in the hand functions, gait, balance imbalance, along with the coordination. So why the cervical spinal neurosurgery is being needed? Because patients often, after following a wide conservative things, they often fail and hence the surgery is needed. Now, why the physiotherapy is needed? Because once we address the surgical problems, we are not necessarily solving the functional outcomes, and that is being hampered in the activities of daily living. Now, aims and objectives. Aims is to evaluate the functional recovery following the cervical spine surgery, and my objectives are as follows. Methodology: 32 patients were taken and they were being assessed along with the outcome measures, which was MJOS scale and the FIM scale. MJOS scale mainly assessing the neurological recovery and FIMS measures the functional recovery. So these are my inclusions and the exclusion criteria. Now, main part, coming to the phases of recovery. Recovery is mainly divided into the 3 phases, stage 1, 2, and 3. Stage 1 is dealing with the early recovery phases, stage 2, functional recovery, and the stage 3, advanced functional recovery. Now, early recovery phase, what are the goals and the interventions? So, following the surgery, our main goal is to provide a safe environment for a patient to again gain their independence. So, our main goal is to promote the post-operative, is to reduce the post-operative complications by promoting the ankle pump movements, breathing exercises, and promote the early bed mobility training. So, by doing that, we are allowing the patient to at least walk properly and get discharged before they get home. So in the video, you can see a lady is able to cycle well along with the pain, and whatever the feedback is being generated with the amount of the force that is being used by her by the cycling. The numbers displays the amount of the force that she has been using while cycling. Phase 2, functional recovery, it starts from the 6 weeks to the 3 months. Here our main goal is to promote the more independence in their activities. The goals is to improve the strength and endurance along with the progressive cervical and the upper limb training if they are permitted by surgeons. Stage 3, advanced rehabilitation, it mostly focuses on the dynamic balance, task-specific trainings in order to promote the activities of daily living. Here you can see a boy who enjoys eating pakoras, you can see, and he is able to eat that effectively with the help of the orthosis, of course. Outcome measure, it's being calculated at the end of pre-operative and the post-operative along with the 2 months and the 6 months of the protocols, along with the MJO and the PIMS. Results are as follows: improvement in the pre-op and the post-op status of both the MJOA and FIMS scale. This is also being improved and seen in the form of charts. Conclusion, The study develops, indicates the progressive improvement in the MJOA scale as well as the FIM scale. Now the take-home message, whatever is being done in the OT by the surgeons does not necessarily fixes the problems. The real success lies when the patient effectively walks without pain into the daily activities of living. And this is my references. So thank you. And this is a wonderful video by one of the patient shoot. Let's have a look at his story. Thank you everyone for your sustained attention.
Thank you, madam.
Thank you, sir.
So next speaker, Dr. Mohammad Nasir Salar. Red butterfly with tubes and block ligamentum flavum resection for lumbar canal stenosis.
Good afternoon, respected teachers, faculties, colleagues and seniors. I have done lots of poetry on podium, but doing paper presentation for very first time. And myself, Dr. Nasir Salar, currently fellow at Spine 360 Hospital. And my topic is en-bloc ligamentum flavum resection for lumbar canal stenosis through tubular retractors. There are documentation regarding white butterfly using endoscopic, but using tubes there is very less documented. So we are presenting this. As we all know, lumbar canal stenosis cases are increasing very drastically. Common degenerative spinal disorder in elderly patient caused by mainly disc degeneration, facet hypertrophy, thickened ligament flavum, leads to neural compression, leg pain, and neurogenic claudication. How evaluated MIS technique? What are the needs? As we all know, in open we have to do extensive muscle dissection. There is chances of increased blood loss, postoperative pain, and risk of instability. So MIS technique evaluated due to needs of effective decompression, less tissue damage, and faster recovery. Butterfly concept. There are various techniques of ligament flavum removal techniques, but we are doing first all the bone work, upper lamina, lower lamina, base of spinous process, and over the top decompression. And then ligamentum flavum acts as a protective shield, and it acts as a barrier between drill and dura, and it reduces chances of dural injury and epidural bleeding. And we remove only after complete decompression. What our study designs, aims and methods? Our aim was assess safety, feasibility, and outcomes of the red butterfly technique. We have 30 cases of lumbar canal stenosis with failed greater than 6 months of conservative treatment. Procedure, unilateral laminectomy, bilateral decompression through 18 mm tubular retractor, and assessments using VAS score and oscillatory disability score. Surgical technique, what we are doing, first we are doing tubular docking under fluoroscopy guidance, then ipsilateral laminotomy, contralateral undercutting, ligamentum flavum preserved throughout drilling, en bloc detachment, and butterfly specimen removal. This is our IITV fluoroscopics views of tube docking, AP and lateral views, and clinical picture intra-op hand. What is red versus white butterfly? In white butterfly, endoscopic surgery, we are using continuous saline irrigation, so it looks like whitish specimen appearance. And in tubular system, red butterfly, no irrigation, so there is natural reddish appearance preserved. These are the clinical photos of both red butterfly versus white butterfly, tubular and endoscopic. Operative outcomes. Operative time, almost average 38 minutes. Estimate blood loss 45 ml. En bloc ligament flame removal almost in 100% cases, and hospital stays average 1.1 day. Then clinical outcomes using VAS score and Oswetry disability index. In preoperative, VAS score improved from 8.1 to 2.4, and ODI index improved from 62.9 from 22.9. Complication. We have complication of dural tear in one case, no neurological deficit in paresthesia in 3 cases, but it improved gradually. No major complication. Mean follow-up in months 8.7 months, and revision surgery, no revision surgery required in any patient. Why to adopt red butterfly? Familiar tubular corridor, easy to reproduce, no additional equipment, low cost, reduced bleeding, dural protection, and applicable to routine MIS practice. Safe decompression, less bleeding, dural protection, excellent clinical outcome, and reproducible and cost effective. This is our first L5S1 stenosis case, and this is a video.
You can just conclude. Time is over.
Okay. Thank you, sir.
So, Mr. Dr. Salar, what is the necessity of removing the ligamentum flavum en bloc? Can you not remove it piecemeal?
Sir, yes, we can remove it piecemeal, but in inexperienced surgeons like me, and we are there are chances of dural tear more in piecemeal resection, so it is better to remove it en bloc.
So is it removed using a curette only?
Yes,
At
sir.
the end,
Curette,
after the drilling part,
yes, sir.
Is it only removed by a curette and not by a carison?
With carison, but we release with dura or curette. Then after we remove it with.
No, there are different ways of removing it. So curette is to just release part, or carison is to just release part. Then there are 2 ways to remove. Either you directly pluck on it with a disc forceps and you pull it out because it is already separated from everything. Carison becomes blind. It is going below the bony margins or under the ligamentum flavum, which you are not able to visualize. So the thing is to flick and pull it out.
So you responded that in an inexperienced surgeon with piecemeal ligamentum flavum removal,
yes, sir.
there are higher chances of dural tear. So do you have any comparative analysis or any literature support for that, or that's just your feeling you are narrating?
No, that's my feeling that we, as newer surgeon will find this complication.
On the contrary, removing in piecemeal fashion, the handling of the suspensory ligaments can be much easier because it will be under direct vision. So have you experienced any that kind of event while removing en bloc? The suspensory ligaments can be a problem in especially advanced Shiza's grade or C or D stenosis.
Sorry, sir.
In severe lumbar canal stenosis, okay, like Shiza's grade C or D.
To make it simple, Rohit, we are in endoscopy, means removal of white ligament flavum. We are operating under the saline pressure. So any rent in the ligament flavum from any side will cause hydrodissection and make the dura away from the ligament while you are lifting it up. And when you lift, you can see the ligaments, which you can cut under micro scissors. Okay? But in case of removal of this red ligament flavum,
yes,
you do not have that advantage. So
yes,
do you think that while removing, you may pull the ligaments and chances of dural tear or puncture is
No, sir.
high.
So once I separate it from all the sides, I pass the probe dura and separate it from the undersurface of the ligamentum flavum, and then only I pull it. So till now I have encountered only one dural tear, and which was minor. It may be due to suspensory ligament. It was not severe that roots plugged out. So it is very safe. Once it has to be separate from all the sides. You have to be able to see the dura on the cranial side, on the caudal side, and then only you have to lift it. Yeah.
So now let me invite Dr. Arjit Vasishtha. His topic is on multiple road construct for occipital cervical fusion, overcoming challenges with enabling technologies.
Hi, good afternoon everyone. I'm representing Stavya to present our work on occipital cervical fusion with multi-rod construct. So I'll start by presenting this case of a 22-year-old male who presented with neck pain and imbalance since last 6 months. On examination, he was neuric grade 3 with MJO score of 14. These are his radiological images. We can see there is atlantoaxial dislocation with basilar invagination. C1 is assimilated to occiput. On MRI, we can appreciate the hyperintensities in the cord. We took him for Garden-Wet Wrongs for 1 day, and then later on we did occipital cervical fusion with foramen magnum decompression and autologous bone graft, and we did multi-rod construct for this. This is the 1-year post-op follow-up for this patient, showing good fusion posteriorly. We went all posterior, no anterior work was done. So occipital cervical fusion, as we all know, is a well-established procedure, and it has evolved from uninstrumented fusion using autologous bone grafts, which necessitated the prolonged immobilization, to the modern age use of screws, rod, plates, which enables us to mobilize the patients early. But still, why do we need multi-rod construct? Basically to avoid situations like this. So occipital cervical junction is a difficult area to achieve fusion, and the idea behind multi-rod construct is to improve the fusion rates and hence reduce the implant failure rates, which are still 7 to 9% in the existing literature. And this holds true especially in cases of complex anatomy and physiologies. So at Stavya, we routinely do these procedures with intraoperative CT scan and navigation guidance, which helps us to put pedicle screws in a more safer and a faster way. We can also capitalize on more anchors like C2 pedicle and C2 lamina as well. For foramen magnum decompression, we use the ultrasonic bone scalpel. So in this video, you can see we can place bilateral C2 laminar screws. By placing the one side, we can fix the trajectory, project it, and then with the help of this, we can place the other side as well. So we evaluated functional and clinical outcomes of multi-rod construct for internal fixation around the craniovertebral junction, and the assessment of fusion was done by CT scan. So we retrospectively evaluated 10 patients who underwent occipital cervical fusion with a multi-rod construct, and minimum follow-up period was around 12 months. These clinical parameters and these radiological parameters were assessed. CT was used to visualize the bony trabecular deformation. So most of our patients were females. 8 patients had basilar invagination with atlantoaxial dislocation. 2 patients were having odontoid pathological fracture. Clinical improvement was noted in terms of VAS, NDI, NJO, and uric grade. The clivus canal angle also improved around, mean improvement was around 11 degrees. Radiologically, all the parameters did show improvement, and CT scan suggested fusion in all of these patients at the end of 1 year follow-up. So the advantages of a multi-rod construct are well established in literature. It reduces the stresses on rods, reduces the implant failure rates by improving the fusion rates. And there is enough biomechanical and clinical literature regarding its use, its applicability in adult spinal deformities, but there is still limited literature regarding the occipital-cervical junction. One of these limited literature is this. They analyzed the biomechanical aspect of it, and along with a case series of 10 patients who they followed for 1 year, they found that multi-rod construct reduces the stresses on the primary rod and lowers the stresses on occipital and subaxial cervical spine screws. In 10 cases that they followed up, no implant failure was noted. This is another case report, case series, if I may. And they devised a new technique for triple rod construct. This they devised for redo cases. And again, they also didn't find any implant failure rates in their follow-up. So to conclude, multi-rod construct is a viable option to improve the fusion rates, reduce the implant failure rates, especially in cases where you are handling complex anatomy and physiologies. Thank you.
We assume that it is for complex cases.
Yes, sir.
Did any patient undergo anterior release?
No, sir.
Okay. My concern is you have used the multiple rods and anchors.
Yes, sir.
Still extension up to C5.
Sir, the extension up to C5 was done in cases where we are not able to get good enough hold using C2 or C3. In some cases, C2, C3 is fused and we are not able to get good hold, then we went to C4 and C5.
So I have a question.
Yes, sir.
Your premise of your study was that you said single rod construct has probably implant related issues or non-linear or something.
Yes, sir.
So your short cohort of study, did you compare it with existing literature with single rod, and did you find any difference into that kind of a grouping? Because the premise what you set in was to prevent those failures, but
yes, sir.
I could not see whether you could actually have compared that failure into this slides. I'm sure you must have done it. So what was it?
So in this study, we didn't compare it with the single rod construct, but in the existing literature, there are reports of 7 to 9% of implant failure rates with the conventional two-rod constructs. And regarding the multi-rod failure rates are still not yet established in literature, sir.
Okay, thank you.
Thank you, sir.
I would like to call upon the next presenter, Saurabh Kulkarni. Evaluation of clinical and radiological outcomes of anterior cervical hybrid surgery for multi-level cervical disc disease.
If there is an issue, we can go for the next paper and
Okay, so good morning everyone. My topic will be evaluation of clinical and radiological outcomes of anterior cervical hybrid surgery in multiple level cervical disc disease. So as we know, ACDF has always been the gold standard for the cervical disc disease with excellent clinical outcomes, but associated with increased adjacent segment stress and a risk of ASD. So to address this, TDR came into play, where it preserves motion, reduced adjacent segment loading, as well as, but it was not suitable for severe degeneration, instability, OPLL, or cases with severe arthropathy. So while addressing multi-level cervical pathologies, fusion alone will increase the adjacent segment stress, whereas TDR alone will be not suitable for all the levels. So hybrid pathway, the hybrid regime surgery provides the middle pathway, while addressing the limitations of both ACDF and TDR, providing us the option of tailoring the treatment according to the degree of degeneration at each level, whereas avoiding unnecessary multi-level fusion. So our aim was to assess whether combining this motion preservation and fusion give a satisfactory clinical outcome while preserving cervical motion and minimizing adjacent segment stress loading in multi-level disease. So this was a retrospective study of 20 patients conducted at Savya Spine Hospital with inclusion criteria of multi-level cervical disc disease managed with hybrid surgery, which was at least 1 level ACDF and 1 level TDR with a minimum follow-up of 2 years. Coming to outcome measures, the clinical parameters that were assessed were VAS score, neck disability index, and the MGOA scoring, whereas the radiological parameters, which were measured on the cervical lateral flexion extension radiographs, were the C2 to C7 ROM, superior and inferior adjacent segment ROM, and heterotopic ossifications. So total of 20 patients, mean age 41.3 years, of which 12 were males, 8 females, with a mean follow-up of 4.6 years. Total 20 patients, 17 with double-level surgery, 3 patients with 3-level surgery, 3 surgeries performed at non-contiguous levels, suggesting the versatility and tailor-made treatment. ACDF performed cranial to TDR in 8, caudal to TDR in 12, with C4-5 TDR and 5-6 ACDF in 6 cases, being the most common one. Mean duration was 125 minutes, with a blood loss of mean 138. So as we can see, the clinical outcomes were significantly improving in all the 3 domains. Radiological outcomes showing an substantial preservation of cervical range of motion and ROM at superior and inferior adjacent segment levels. We encountered disc prosthesis subsidence in 6 cases, cage subsidence in 2 cases, with none of them being symptomatic, transient dysphonia in 1, and transient dysphagia in 4 cases. So coming to the discussion, the main rationale was the objective was to improve the pain, neurological symptoms, and overall functionality. So previous literature has shown that hybrid surgery provides a comparable, not superior, but as well as a non-inferior outcomes when compared to ACDF and TDR, as well as the hybrid constructs. So which was consistent in our study, as the VAS score was improving from 6.8 to 2.4, MGOA improved from 10.6 to 14.4, and NDI from 38 to 12.6, suggesting an improvement in all the 3 clinical domains. So going beyond the clinical improvement, the principal rationale is to preserve the cervical ROM and adjacent segment biomechanics. So multiple literature has shown that hybrid surgery preserves the global ROM as well as reduces the adjacent segment stress with the hybrid construct. So we could see the result was consistent with our study, which showed substantial preservation of cervical ROM and mean adjacent superior and inferior level ROMs. So is motion preservation always beneficial? A study by Nene et al. Showed that the only fusion studies had an increased subsidence rate at the adjacent levels, but at the implant levels. Whereas a cadaveric biomechanical study shown by Martin et al. Showed that a cyclical loading and flexion extension cycle will increase and alter the biomechanical stress levels at the implant levels. So the potential benefits and potential concerns associated with this are the lower ESD, better ROM, and physiological kinematics, whereas the concerns would include implant wear, subsidence, ossification, and hypermobile segments. So diving a little more into the implant subsidence rate, which could be because of the altered sharing, adjacent fusion effect, or improper end plate preparation because of excess removal or reducing the end plate strength. So even if there was few subsidence cases, there was no case that was symptomatic, which brings me to the...
You will have to stop, time is over.
Yes, sir.
Conclude,
this is the last
just conclude.
So the conclusion would be, my conclusion is, hybrid cervical surgery is a safe and effective option for multi-level disease, cervical disc disease, providing a significant improvement in clinical as well as radiological outcomes while preserving the cervical biomechanics. While subsidence may occur, it did not affect our radiological outcomes. Clinical outcomes.
questions?
Does your study compared with the literature review regarding the two level of fusion versus your hybrid construct regarding the adjacent segment degeneration?
Actually, adjacent segment, we did not dive more into adjacent segment disease because our mean follow-up was around 4 years, while predicting adjacent segment disease will require a 5 to 10 year of follow-up.
Were there any radiological criteria wherein you decided which level you would fuse and which level you would go for a disc replacement? One. And in multi-level, usually, as the literature says, that you don't go for disc replacements when there is a multi-level problem. So what was the rationale for going in a multi-level for a disc replacement?
So while assessing the pre-operative MRIs and radiographs, if the disc space was not severely collapsed, there was no facetal arthrosis, there was no multiple osteophytes at that level, we would go for TDR at that level, whereas the level which shows signs of more degeneration, advanced degeneration, was opted with ACDF.
Thank you. We shall conclude. So, inviting our next speaker, Dr. Parikshit, full percutaneous fluoroscopy guided transcambine lumbar interbody fusion.
Good afternoon, everyone. I am here to present the full percutaneous fluoroscopic guided transcambine lumbar interbody fusion. My prospective study and prospective feasibility and safety study with 1 year follow-up. This is the single-centered cohort with 44 patients conducted between the April 2024 to April 2025. Minimally invasive lumbar interbody fusion technique has evolved to reduce the iatrogenic muscle injury, blood loss, and postoperative pain. Traditional MIS still involve the partial facetectomy, neural retraction, and offer limited disc visualization. The Cambian triangles, the extraneural corridor bounded by exiting nerve root, traversing nerve root, and roofed by the superior articular process, is established as the safe zone for the endoscopic discectomy. Endoscopic endofusion validate this corridor but demand the specialized equipment and the steep learning curve. Fluoroscopic guided transcambine offers a simplified alternative of this and using the standard MIS instrumentation. Objective of this study is to evaluate the feasibility, safety, and 1 year outcome of CALIF using a novel cannulated titanium cage. The study objective is the quantify the clinical outcome in the form of VAS for back and VAS for leg and ODI at the series point of time, and document the feasibility, safety, and complication profile. The radiological endpoint to assess the restoration of disc height, foraminal height, segmental lordosis, and global lordosis, and evaluate the fusion status at CT at the 1 year follow-up by Bridwell classification. The inclusion criteria in my study is the single level degenerative pathology of lumbar spine that include the lumbar canal stenosis, schizas type A to C with dynamic instability, degenerative spondylolisthesis, and lytic listhesis grade 1 to grade 3. Preserve or correctable lumbar lordosis on extension film, disc space collapse more than 50% height, DEXA scan for patient is more than 1.5 or between the 1.5 to 2.5 with sclerotic end plates. Monoradicular pain, mechanically provoked and absent at the rest. My exclusion criteria is multi-level disc disease, fixed segmental imbalance or non-correctable kyphosis, severely arthritic facet, severely osteoporosis, prior instrumentation or fusion, active infection or acute trauma, bilateral radiculopathy, central stenosis which require direct decompression is excluded, and the rest radicular pain or multi-root involvement are excluded in this study. My surgical technique. Patient is positioned in prone position with total intravenous anesthesia. Skin entry is 8 to 10 centimeter lateral to the midline. Jamshedi needle was directed toward the lateral border of superior articular process in the AP view and the posterior part of superior articular process margin in the lateral view. Then the Jamshedi needle was advanced toward the inferior annulus in the posterolateral corner. The end point of entry is the inferior tip of the Jamshedi needle was not crossing the midline in the AP view, and the posterior to the end plate of the inferior end plate, posterior to inferior end plate. At this level, we introduced the electrode to check the safety. We check the trigger electrode at the 6 milliampere and 4 and 6 milliampere. Threshold more than 6 milliampere is considered the safe, and it guide to proceed the further procedure. If any activity is detected, we have to redirect the needle and check further. After that, we have to advance the guide wire toward the anterior disc space, and after in the AP view, it crosses the midline crosses the midline. This is the optimal central disc to achieve the optimal central disc access. After that, on the guide wire, we have to do a sequential dilatation of tube, and the final tube is mounted on the table with the flex arm. Then after introducing the guide wire, we introduce the obturator to dilate the Cambian's triangle, and sequential dilatation and cannulated disc shaver is used to prepare the disc, and angle curette is used to prepare the end plates. After that, dolphin interbody cage is used, which have a constant 9.5 mm of width and height option available from 8 to 14 mm, which is filled with the beta TCP or demineralized bone wax minerals. The narrow craniocaudal design of the cage is allowed to pass through the Cambian's triangle with minimize the risk for the damage to the exiting nerve root. Then final fixation was done. This is the external view of the working corridor established. The first picture shows the skin marking for the trajectory of the Cambian's triangle, and the plan the pedicle screw entry point. Second, yes.
Time is up. You need to conclude, my dear.
Okay. The Caliph is a feasible, safe, and minimally invasive alternative for the single level degenerative disorder. There is a robust pain relief, functional recovery, 80% improvement in the ODI at the suspected gains in first 3 months. Radiological restoration of disc height, foraminal height, and lordosis. High fusion reliability, as 88.4% patients show solid or partial fusion. Excellence neurosafety, no permanent deficit is noticed, and this is the bridge between the MIS TLIF and endofusion technique.
Thank you. Any questions?
How many patients did you convert to MIS TLIF?
No, 0 patient.
And I'm sure there must have been in your presentation, but what about the 1 year outcomes of fusion?
So there is a.
Do you use any classification?
Yes, we use the Breedwell classification. This is CT guided. We have total 44 patients. Out of 44, 18 patients show grade 1 fusion, 20 patients shows the grade 2 fusion, and 0 patients shows the non-union.
Did you notice paresthesia, dysesthesia of the exiting nerve root in some of the patients?
Yes, we noticed the transient neuritis in the 6th patient between the postoperative 4 hour to 2 day, which lasts for about 3 to 6 weeks, which is manageable by low dose steroid course. Thank you.
Thank you. So we have the last speaker, Dr. Udgam Bakshi. He is going to talk present on subaxial cervical transfacet screws and underutilized armamentarium for posterior cervical stabilization.
Good afternoon. I am Dr. Udgam Bakshi. I am a neurosurgeon from Vadodara. Just few minutes back, we had seen lot of hands against transfacetal fixation. So here I am with my study. Comparative study of clinical outcomes between transfacetal screw fixation and the conventional lateral mass fixation with a simple question: can a simpler construct provide equivalent clinical outcomes? So in literature, there are a lot of literatures which are supporting biomechanics of transfacetal screws. That is biomechanically it is a robust construct and comparable with lateral mass fixation. Surprisingly, very limited Indian literature. The aim of our study was to compare transfacetal fixation and lateral mass fixation in cases which required posterior cervical stabilization. We studied neurological outcome evaluation using numeric grading and functional outcome using NDI, pre-operatively and post-operatively the follow-up period at 3 months. So we had, in our retrospective study, we had 20 patients which required posterior cervical stabilization. 10 patients underwent lateral mass fixation and 10 patients transfacetal fixation. As we can see, the two cohorts, they are broadly comparable. The indication in both the cohorts, degenerative cases were similar, and even trauma cases were similar. So both the groups were comparable. The surgical techniques, there are many surgical techniques which define the entry points for transfacetal screws, which is around the midpoint of lateral mass. We followed the freehand technique, identifying the anatomy of both the facets and going mediolaterally. So, seeing our result, the neurological outcome of numeric grade for lateral mass in pre-op, from the average was 4.8, post-op 2.7, which was almost similar with transfacetal screws, 4.7 to 2.5. We had a similar outcome for functional outcome. The NDI score from 47 to 30 and 48 to 29.5, which shows that both these techniques were showing almost similar results. So the question is why transfacetal screws may matter. Transfacetal screws requires less fluoroscopy, less CM exposure, means less radiation, less use of implants, no need of rods, less screws, and which eventually leads to less cost. Since there was significant comparison between neurological and functional improvement, reduced implant burden, less cost, minimal CM exposure, almost nil CM exposure in transfacetal screws, and no radiation. The limitations of this study are that it's a retrospective study, single center study, and post-operatively we have not evaluated the radiological outcomes in the follow-up. However, the question which we must ponder is, for every posterior cervical decompression, should we stick to the conventional rod and screw construct, or can a simpler fixation with use of less screws and less radiation be better? Thank you.
Thank you. Obviously, you did mention that you have not looked at, but what is the follow-up? Like, since how many months have you been doing this along with your mentor? And in those whatever months, you may have seen something come back. So is there an implant failure or something that you noticed?
Sir, for these 20 cases which we have followed up, till 6 months we have the data, and there was no implant failure, and the alignment was also similar. There was no change in the alignment for both 20 cases.
Any pain difference between the two groups? Difference in neck pain?
No, sir. The functional outcome was almost similar.
Position the patient. Is it on Mayfield or traction or on horseshoe?
It's on pin, Mayfield.
Mayfield,
yes,
with
sir.
some limited traction.
Yes, sir.
Thank you.
Over to Nisarg, sir.
Thank you everyone for being patient. Wonderful papers, wonderful session. I think we depart for our next session, lunch break. Thanks. The results shall be declared in GBM.
So we break for lunch and we'll be back 2:10.
ज्ञान
So the first case, this is a 70-year-old man, right hand dominant, early myelopathy, about 1 month symptoms, hypertensive, coronary artery disease, angioplasty on clopidogrel, and that clopidogrel was stopped before surgery, but dobutamine stress test negative. So these are the background medical problems, but he had gait imbalance, although he was independent, some difficulty buttoning and writing, numbness, but myelopathy. We will not discuss myelopathy. This was his MRI. So, for want of time, because we are discussing a complication, so I'll just say it's myelopathy, but cervical spine is kyphotic. It's at multiple levels, and this is the flexion extension X-ray, and this is the flexion extension MRI. This is a flexion extension CT scan. So I'll ask the panelist, all of you. Sir is also here. So what would be your choice of surgery for this, Dr. Dubey? Correct. Choice of surgery and the complications that you would anticipate, because we are talking about complications.
So first thing you should assess is a respiratory assessment. If you can give a incentive spirometry for 4 weeks before doing surgery, it will definitely help you. Surgery related complication depends on what approaches are you going to take for this patient. And
he's cardiac patient.
So
has an angioplasty in the past, but cardiac function is good.
No, angioplasty, how many years
2009.
So it's a long stable.
Yeah, long stable. He's on clopidogrel.
So
but ejection fraction is good, so he's not like
so
dysfunctional.
Restenosis means sudden blockage of stents is more common if it is less than 2 years of angioplasty, and it's very high if it is less than 3 months of angioplasty. So respiratory, you become the reserve, you will give Clexane, perioperatively 5 days you will stop clopidogrel, post-operatively you will immediately start this thing.
Right.
Now the choice is whether you will do anterior or posterior. With this long deformity segment, bones not looking healthy, a posterior approach is much better for it.
So you would try to correct it from a posterior approach itself. Dr. Luhana?
Yeah, I will again go posterior, because getting reasonable correction, not a pretty good, but reasonable correction versus anterior 3-level corpectomy versus posterior. So I would go posterior.
Same here, like on the dynamic X-ray, there is at least reasonable posture on that thing, and considering the cardiac issue and everything, having anterior and long segment.
So he was advised anterior, and you don't have the advantage of seeing him in person. I saw him in person, so I also felt that doing multi-level anterior and then posterior for somebody like him might be an issue. Dr. Abhidha? Posterior.
It's reducing.
So I think everybody agrees posterior, and one of the problem with doing posterior surgeries for cervical kyphosis and correcting cervical kyphosis from posterior approach is the C5 policy, because things narrow down. So that was an issue which I counseled him for. So again, I'll go through what the surgery was done. So planning, CT scan. I mean, I use pedicle screws, but there's a freehand, not navigated pedicle screws, and just because you need the power to correct that deformity. So there are reduction screws at the top and this, and I did a prophylactic foraminotomy because I knew that I'm going to do a kyphosis correction, and obviously patient was under neuromonitoring, so things didn't happen. And then I scrubbed out, held the Mayfield, no, my assistant scrubbed out, they loosened the Mayfield, I held the Mayfield, extended it as well as those reduction screws. So correction reasonable, surgery uneventful, nothing, no active bleeding at that time, wound closure, I did the closure myself.
C2 to T1 you went.
Yeah. Because you need good anchors at the top, so C2 was the topmost good anchor, and then at the bottom, so to extend it. So I think I got reasonable correction. Neuromonitoring was not was uneventful. The wound was closed over the drain. Blood loss was also acceptable. Patient was extubated same day. He moved all 4 limbs. He was transferred to the ICU. He was normal neurologically when examined in the ICU at 5 p.m. Right? That was like the post-op check before I left for home for the day. At 7 p.m., the patient started complaining of weakness in the triceps. And my fellow saw him. He was informed from the ICU that, he's not moving the legs now at 8:30 p.m. This is towards the end of the day. And he had a complete motor and sensory loss below C7. So what were the thoughts in your mind at this point in time? Obviously, like I get a phone call that patient is not moving legs. So I said, I'm coming down, you move the patient in an MRI and then we'll see. So that's what I did. And that at 9 p.m. an MRI was done and that showed a large hematoma. Now, this patient's closure I did. So I can't even blame the fellow for, not doing the hemostasis well. Because for all cervical spine surgeries, I do myself. I do the closure myself. The subcutaneous and skin the fellow does, but the soft tissues I close myself. So I was very disappointed that this happened because the surgery went so well. Obviously, there's no other choice because he was like dense quadriplegia. So immediate evacuation of the hematoma was done. 5 platelets were transfused. So I have never had such a bad hematoma ever in my life. Anybody has any experience?
Yeah,
and then all by the book, everything was done. We stopped the clopidogrel a week in advance. I never counseled him for an epidural hematoma, by the way. I counseled him for C5 palsy and all those things and all. And, neurological deficit because what we are doing with the surgery, because neurological injury can happen while correcting the kyphosis. But the epidural hematoma was not on my mind.
So one of my patient with a cervical laminectomy presented with advanced myelopathy, recovered well, went home, suture removal, and next day I got a call that he can't walk. And we got an MRI on 11th post-op day and hematoma.
But this is a massive hematoma because when I opened him, there were like thick clots. It was not like blood. It was like super thick clots underneath the closure. Hitesh? No, there was no bleeding. I did the closure. I don't close wounds with a bleed. There was no bleeding at the time of closure.
Yeah. After
same experience with me. I think that case report is already published. A young patient with mitral valve replacement and rheumatic heart disease and other things. Patient was on dual anticoagulant medicines and we operated for myelopathy. Patient was in ICU. Clexane was given because of his disease and cardiologist advice. Then patient made to stand and walk inside ICU. And once the round is finished, after half an hour, he initially felt intense pain and started losing his hands. I was in surgery, but I got call from ICU. I sent my associate colleague to the ward, and I just told him, just open up all stitches, let it be open. All hematoma drained out, and immediately within 5 minutes, patient started recovering. Then we took him in OR and did the other procedure. But this is the same experience if patient is on anticoagulant medicine, specifically dual anticoagulant, then this thing is very common and it should be
I don't think it's very common.
This, if patient is having heart disease, like my patient was 21-year-old, right? And he was on clopidogrel as well as some other Blinta or something else, or I don't know exactly. And patient was advised to give Clexane just 6 hours after the surgery with cardiologist advice.
So what is the experience of the house? When do they start anticoagulation?
Ideally, it should be started after 24 hours. but the patient was very high risk. That's why it was advised.
And then would the ideal choice be Clexane, Dr. Dubey?
No, he was heparinized. In my patient, it was given 5,000 unit heparin.
So there are two kinds of hematomas. One is venous. Historically, it looks like venous bleed, which has accumulated over a period of time. His case is an arterial bleed, which is secondary. At that time, you have coagulated.
No, I think this was arterial bleed.
No, it would be sudden onset. It will be like pain and sudden onset. Means we have venous and arterial, and we have also experienced without deterioration post-op scans in some patients. So hematoma is always invariably there.
Yeah.
But deterioration is the most important thing. You don't chase the MRI.
Yeah.
Arterial bleeds will be of sudden onset with the pain. Venous ooze bleed will be slowly progressing, and there will not be any wound pain at that place because arteries do open it up suddenly. Yeah. The best thing is to operate very early rather than waiting. There is no question of waiting. Even if it's on 3rd day or 5th day or 10th day, operation should be done.
So when do you restart anticoagulation for patients?
So it depends on what kind of this thing is
pre-existing.
Yeah, pre-existing problems are there. And we are comfortable with Clexane also. It's not that we give heparin all the people. And if it is nephrology, some problems are there, then you cannot give Clexane, then you will do something else, preparin and everything else you are giving.
Sir, this is a compartment syndrome. What I have observed, and you probably, it's not the deficit what comes early, it's a diffuse restlessness that sets on the patient and equivalent to a compartment syndrome patients जब orthopedic में देखते थे ना.
नहीं, ये तो deficit था. Means
to start
patient was comfortable. Patient was saying, look, my triceps is, I'm not able to do this. Like he was keeping his eye, I'm not able to do this. He was saying at 5 o'clock, maybe a little later after 5 o'clock, because I checked him before leaving the hospital.
And at the same time, what another observation is that the moment the patient says the deficit is observed, his pain goes.
He never complained of pain.
Pain
was not the issue.
So that is a major deficit. It doesn't recover.
How was the status of drain like? Because it has happened within few hours. Nothing in the drain.
The drain was okay. I mean, nothing was draining exceptionally at that moment. Obviously, when we opened him, there was no active bleed. Like sir is suggesting venous. I thought there will be something spurting inside, but nothing happened. I mean, we opened it and maybe because of that pressure things that stopped or whatever, but I mean, intraop, we were just removing clots. That's what happened.
In such a kind of canal stenosis, one major problem is dilated veins, which is lying, beneath the facets. At the end, when we check the hemostasis, I certainly noticed that at that time, if the BP is low, after we close and patient went to ICU and then sudden there is a 130 to 180 and 190, that all the closed vein opens. I have started to put a gel foam beneath the facet, at the part of hemostasis. When I close, I always put the strip of facet beneath the facet to push it, not over the cord. Sometimes they may help.
In fact, I have stopped using Abgel. I was using Abgel and one of the patient had a hematoma. So I read that any Abgel would swell up. And we have stopped putting it.
So that is against the quality of any absorbent. Kshitij, a question to you and everybody. Like, final hemostasis should be best before closure. That is a dictum, but we usually don't follow it or we fail to do that. Is there anything which can add on, like a ferrocrylum being put or a butroclot being put, which adds to the hemostasis instant, like your
incidence of hematoma is so low.
It's very, very rare. It's not common.
And only important thing
no, I don't agree with you.
It's not deficits because of hematoma are uncommon.
Less, but hematoma is very common.
Hematoma will be there in every patient, but hematoma causing a deficit is an uncommon situation.
Post-operative accelerated hypertension is one of the things that is probably you can monitor more vigorously.
So pain.
So this patient was like a dense
related to pain also it happens. And one more thing, just to add, specifically to Jayesh, Dubey and Rakesh and neurosurgical, I came across reviewing few of the articles wherein I was surprised to see that intradural post-operative hemorrhage following spine surgery, which was not an entity which I knew. The incidences are like these only, significant percentages of 50 to 60%. Symptomatic, we are not even knowing.
have a case like this in a thoracic spine. Post-operatively, patient had weakness. So we did a scan. There was a intradural hematoma in that patient. So it is known decompression and changing of venous flows can cause this. In oncology practice, when we do these cases, when there's a tumor involved, what we do is that first of all, when we have to take out all of the tumor, it's not in degenerative, and you have to take out from the sides above and below, and then you just take out the retractors, wait for some time, 10, 20, 30 minutes, and then only close it. That's we do in the this thing.
And would you at that time, like Dr. Jayesh suggested, like ask the anesthetist that, look, don't keep the patient, blood pressures and all.
So if we have a bleeding patient, the oozing is more or the dura has fallen more below, you just raise the blood pressure for some time.
So that's a good point. Anyway, this case has scarred me, and you know, every closure I do for a laminectomy is like a
if the dura is falling more below the facet, be more worried for this venous bleed. Arterial you cannot prevent, I think.
Anyway. I mean, the cost is an issue. As a fellow, I remember, like, you know, Dan Rue and all used flow seal every time he closed. That was his protocol. He used to put flow seal, put vancomycin powder, and used to close, like
but in
every single patient.
Some flow seal deteriorations are known and they are documented.
I know.
The more flow seals you put, the more
So we don't know. I don't use flow seal because it's expensive, but I do use gel.
This is a novel thought, just to give an idea. Gynecologist handles this bleeding too high, and they commonly use ferracrylum, botroclot. I use botroclot in most of the cases to avoid drain.
Sir, one thing to add to all this.
नहीं,
when we are using,
it is just 500 रुपए का यार. नहीं, local वहाँ डाल के wait करके निकल जाने का.
So that's a good point. That's a good point. You know, Dr. Dubey is saying, wait for a while, watch it for some time. You can add ferracrylum, whatever. Just hold on, check the blood pressure. Good point, Dr. Jayesh.
It's always better to wait 10 minutes before
and then do the closure yourself. That's another.
Yeah.
Sir.
When I started practice in Ahmedabad, I used to work at Sterling, and a lot of cardiac patients, they were there, and they will push me to operate on the third, fourth day of stopping the anticoagulants. And we ended up with quite a few. So from that day onwards, I do not suture the muscle or suture only one stitch. And then I tightly close the fascia. That is one thing. Second thing, if there is any question about developing the hematoma patient on anticoagulant, use a 14 millimeter drain. So these are the two things which we follow.
So to add to all these things, these patients, they behave differently to heparin also. I had operated a pediatrician's mother and she developed a paraplegia. So we called our friends and one of the hematologists told us that they behave very differently to heparin. So we went back and saw, and we were surprised to see that 3 to 10% of patients in India are reported to behave differently to heparin. So when we use pre-op or post-op heparin, we have to be very, very careful. The second thing, just one thing I like to add as a small comment here, that whenever we do closures for this, so sometimes we just take the muscle and then we miss to tie it, or we cannot tie it, and then it starts bleeding inside. So in these particular cases, we have to be more careful that we should not lose that knot, and each and every single knot should go very perfect. It's just adding to the comment.
That's a very important point.
Sir, my one C1, C2 blood involved.
And we could not, because it was a high risk patient. We explained the patient we need to take in, not ready. He was on
so anyway, we have more cases to finish. Anyway, this story goes on. He recovered to some extent, started walking eventually. The rehab guys did a very good job. He started walking eventually. Bladder is neurogenic. He didn't recover fully. So in the end, he was worse off than pre-op. That's for sure. So that's about this case. Then, okay, this one. We'll go faster. We'll just talk about the complication. This patient was 67-year-old male, multiple myeloma, operated outside, MRI, PET CT showed like this expansile lesion there. This story is happening outside our hospital. So there is a myeloma there, and what the surgeon decides is to fix this and then give this patient radiation. This is how they fix it. December 23 surgery, fixation done, patient failed to follow up for radiotherapy. Some stories missing in this thing. Patient comes with 8 months later, screws are broken. He's advised zolindronate, PET CT. PET CT looks worse. They give him like a massive dose of palliative radiotherapy, like 20 gray, 5 fractions over 6 days, which is like unheard of dose for a myeloma. And started on supportive chemotherapy and other things. The surgeon doesn't want to touch him back again, but this is, he is with a broken implant and a massive dose of external beam radiation to that area. And then he comes to our OPD like this. He can't move. Like he's like in bed, you make him sit and he says, I'm going to hold my neck all the time. So we kind of check with radiation oncology, and oncology opinion is taken. Obviously we need to fix his neck some way, because he's miserable, he's in a lot of pain. I am worried that he has received radiation in that area. How will I do a fixation? And then there is the MRI that shows that the disease has increased. So radiation oncology says that he's never going to get any more radiation ever again because of the kind of radiation he has received in a very short period of time. So wound complication risk is high. Since it has been given some time back, you can go ahead with surgery, address the mechanical instability. Chemotherapy obviously will have to be continued. This is the CT angiogram, reconstruction, bone reconstruction. There is khadda. There is nothing in between, right? So this is his intraoperative picture. So my plan was, let's first get him out of the pain, fix him first, and then see what happens later. So we get the implant out. Obviously that part of the C1 screw broken in the lateral mass. One side I'm able to get out because it's broken outside. The other part is broken in the lateral mass. So that we leave it behind. And I put a posterior arch screw, which is a screw through the posterior arch rather than the conventional entry point. So get C1 fixation, get occiput fixation. I get a rib graft, place it on the back, and then connect the rods, and then somehow connect multiple rods. We saw a paper about multiple rods. So get a multiple rods in with the rib graft and double rod. So this is how in the end reconstruction is. Anyway, so basically patient's pain is gone, but the khadda remains in the front, and then his wound refuses to heal. So there is like a sinus there. So now what? And then what about the anterior part?
However, posterior you make, but if there is such a huge anterior wall, it's going to fail.
I would disagree about that, but so but the longevity is good. It's myeloma only like this location,
it is worsening after all the time.
No, but he received all wrong treatment. The problem was that. So he didn't receive the right chemotherapy. He received a very short period radiation. He was not receiving the right treatment. This patient right now is alive, kept
Kshitij,
alive by our
I can
oncologist.
just share one of my similar patient where there was everything was absent. It was a thyroid CMATs, and the patient still came with the same. There was no. We had planned both anterior and posterior. The onco person says that you just do posterior. There is no need to do anterior. Because thyroid, of course, thyroid is a different, but they have a radioiodine, and then that works very well.
Right.
And then it worked with the denosumab, which was given for a long time, and it has completely reconstructed anterior.
Even myeloma is like that because they give zolindronate and all these sort of things.
Similar thing, vanishing bone disease.
Hello.
Yeah, so that's terrible disease. But this myeloma, basically this patient will live at least a few years. The problem is that, and he has, I mean, so the reason I put multiple rods because I knew that anytime soon I am not going to be able to reconstruct the anterior part. So I need some time so that this whole thing, we kind of wait it out.
So in this group of patients, when then radiation is not there as a question of being given and chemo is the thing which is given, you prepare a very good posterior bed, पूरा इलिया क्रस्ट डाल के घुसा दो, बच्चा है तो मदर का लेके डाल दो, and even off-label use of medicines.
No, I have put like a rib graft. I have taken his rib and iliac crest and I have reconstructed the whole thing from the back.
हाँ ये fuse हो जाता है.
ये fuse हो गया है. तो problem है कि it is fused from the back, and also that anterior part which looks very lytic. So basically he undergoes plastic surgery because this wound just refuses to heal. It's post-radiation wound and gets a flap. Okay, and then this is the flap. They drew a rotation flap from the skull. This is again March 2026. And you can see the bone all in the front. It is formed. That lytic part is like forming. The CT scans also show that that whole thing is, you can see the outline. Don't go by the odontoid, and that lateral pillar is forming. That odontoid margin is seen. So I was like, okay, I'm not going to touch you from the front. So anyway, the plan was to do a front, but waiting, I escaped from that front surgery. Yeah, probably. At the cost of civil, yeah. So anyway, the fusion is good. Like you see the rib graft also posteriorly like has incorporated well. So he's fine. Now the only problem is that that thing doesn't heal. In spite of the flap, he had like a screw that was prominent. This was just few months back. So then we decide, like, look, it looks fused, so let's get rid of that occipital plate. So I go back in, and then I cut that occipital plate off, take a metal cutting burr, and then cut off the occipital plate. And then this is how he is now. I said, let's not remove the implant because God knows if it breaks again. And that patient is extremely happy because his pain is gone. And he's on that chemotherapy by oncologist. So his disease, he's under remission for myeloma. So, but he still has the sinus. And so he is like, he still has the sinus. And so the patient is saying that I don't want to, I live with the sinus, I'm not doing it again. Huh? But, yeah, but a full bone form means that endpoint is going to be
full reconstruction. After anterior full reconstruction.
Maybe I'll get fresh CT done after some time.
After 1 or 2 years.
Right. So 62-year-old, this is another interesting case. Myelopathy, OPLL, there's extensive OPLL at this. Again, patient gets a surgery outside, C3 to C7, somebody does a laminectomy for him, and then the patient recovers. Okay, so he starts improving, he's fine, but then after 6 months, he starts deteriorating again. So now what? He starts deteriorating again.
MRI.
Okay. So this is his MRI. No, the spinal cord though is like full clean open. OPLL is 6 months, sir. Deterioration in 6 months. It's not after 6 years.
There has to be some dynamic MRI or something which is required.
Something is there.
Yeah, so you have to do a dynamic MRI with this.
No, still this is inadequate surgery because the compression behind the upper border of the C3
so
is
take
still
it from me that this is adequate compression because I have seen all the axial images. Everything looks open.
No, but in this
it's
pre-op
not,
scan and post-op scan.
It's not.
Get
It's
a
not.
dynamic MRI.
It's not. That's not the issue.
Get a dynamic.
I'm sorry, you don't have the luxury of seeing all the images, but if you would have seen all the axial images and all the images together, there is no compression on his static MRI.
Dynamic MRI?
Dynamic MRI is ghastly. Okay. So obviously we do dynamic MRI. That's the dynamic MRI. So in the dynamic MRI, what is happening is that that entire post-laminectomy scar is invaginating into the spinal canal with the extension. I have never seen it. Yeah, never seen it. Okay, so look at this. This patient's posterior neck, you see those muscles, they have gone wide. So there is a divarication or whatever happens here. Those muscles have, instead of being extensors, they are flexors, and they have separated like that. So which was something I thought maybe is the reason for why this is happening. But it was so odd that I asked Danru. So I sent him these images. I said, look, this is what I have. Never seen something like this. So he sends me a case report. He has only published it. So they have seen 3 cases of post-laminectomy patients deteriorating because of the invagination of the posterior soft tissues in the spinal canal. And this has happened even, I think one of these patients is a laminectomy with fusion. So it's not just a plain laminectomy. So laminectomy with fusion, on extension, everything is invaginating inside and the patient is deteriorating. So they published this in JBGS case connector. So I asked him that, look, what is the solution for this? Even if I do laminectomy now, I'll fuse this, but still the soft tissues are going to invaginate when the patient extends the neck. So, yeah, so this is what we did. We positioned in the Mayfield. So first thing was to get that laminectomy membrane off. So that's like a quite thick scar tissue. So you have to be very careful and then dissect it out. So till the dura, so that, you know, till you reach the soft part. Otherwise it's like tough scar on the dural sac. And the tougher it is, the more it is going to invaginate, like buckle inside. So we dissected out the entire scar. And this is what you would do in post-laminectomy kyphosis patients and all, when they deteriorate. So the other thing that we noticed now, that the primary surgeon had done an extremely wide laminectomy. So this laminectomy is 3 centimeter wide. So maybe that's another reason why this could have happened. I don't know, but this was an extremely wide laminectomy. So we removed that scar, again did an intraop sonography to see how much the thickness was. And then, you know, as per that case report which was published, what they did was they revised these patients with putting a crosslink across the rods, so that those crosslinks prevent that soft tissues from going inside. So then I kind of put the screws, put the crosslinks, and that did a facial release on the side to get all those muscles together, because the muscles had like gone outside. So I had to do release incisions on the side to get the muscle back inside. So that was how the closure was, to get the muscles to start acting as extensor muscles again. Anyway, so this is now, anytime, you know, if you see a patient with post-laminectomy deterioration who doesn't have kyphosis, and whose MRI looks kind of not really unusual, get a dynamic film. Dr. Jhala had a very good talk on the dynamic MRI. He has a good slide on it. Anyway, so
this is one of the reasons where we could discuss that sometimes laminoplasty is better than the laminectomy and
right, always, yeah. I prefer laminoplasty to laminectomy wherever possible. But like what I'm surprised is that this happens with laminectomy and fusions also sometimes. I don't know how common this is.
Similar for the
How
deformity
common this
corrections.
is.
In
Yeah?
deformity corrections also this has been reported.
I don't think this is very common.
No, not in laminectomy. I'm talking about the deformity, kyphosis corrections. So,
yeah.
When you do a VCR over and then you get the patient supine, the muscles impinge on.
So how much time do we have? 10 minutes. So let me show one case that I don't know what to do, rather than, which is someone else's complication again. But then solution is, okay, so this is a kid. So I have loaded it in Horos only because I think the image detail is important. So this was a patient, 10-year-old kid. Last year she was operated for this. All right, so this is, so the story is at like a year of age or something, she gets a cervical laminectomy done for compression because she had delayed milestones or something at 1 year or 2 years of age, but no fusion. And then over time, she kind of starts toppling over, and at age 10, she's frankly myelopathic. She's walking, but very, very unsteady. And this is the picture. This is how it looks. So there is like an os here. The sagittal joints look like this. Again, spondyloptosis, whatever you want to call it, its joint is vertical on this side. Also almost going in the other side is like this. I don't have the pre-op MRI. But again, this is the kind of patient I would do a transoral release and a posterior surgery. So this is, I will not do, I mean, I am not capable of doing extra articular distraction or putting any sort of a posterior release for this. It's technically quite hard thing to do. And I don't think you get a reproducible result with it. At least we have not been able to get it like
not
that.
extra articular distraction, but even with this angle, probably you would put instrument and then reduce it and then and basically joint remodeling.
Joint remodeling. So joint remodeling or extra articular distraction, but joint remodeling also in this is not really an easy thing to do. I know like the experts will be able to do it, but at the end, what kind of anatomical result are you going to get? That again is a question. But anyway, whatever, long story short, she was sort of fixed in situ. So this is her MRI now. This is her MRI. What is the date? This MRI is November. So she's fixed like this. Nothing. This is just fixed like this.
No FMD.
There are screws through the facet joints, and she's fixed like this. Now again, this is her latest. This is her latest CT scan, which is exactly an year from the surgery. And let me show. The bone images. So like there is bone graft at the back, like that, but this is the screw trajectory here. This is how the screws are. Again, what I have noticed is that facetal fusion is not there. I can see the facet line here and like, here. You can see the facet joints on the right side and on the left side. Also, you can see the facet joints. This is the facet joint here, but there's a fusion mass at the back. So there's a fusion mass at the back, but that fusion mass is not reaching the occiput. So if I show you the 3D image, I've not done the surgery yet. So this is how the posterior is. I don't think it's like bony fused. So right, there is a gap.
What is the clinical status?
She's deteriorating. No, she's not even improved. She's deteriorated. So again, like most fixations that happen sort of in a compromised position, they improve for a while, and then she started deteriorating again. And that's the reason why they are seeking an opinion, right? Because
how many months post-surgery?
She's exactly 1 year post-surgery. So this is her latest CT scan just done last week. And I really didn't know what I'm going to do on this. So, yeah.
So if you're good construct, you can use your own technique. You can just do the anterior decompression.
So that I am not sure will it work.
You can just, if you can show the CT scan or the MRI again, like.
So for that to work, that fusion.
Only anterior decompression you do, like at C1, C2 level, little bit central.
So transoral odontoid resection.
Yeah, and
yeah,
release the
odontoid
ligament.
resection is not a small surgery to do.
But
So
still,
that's
like
a-
doing nothing will
this-
be.
Odontoid resection is an option, but now this these patients' parents are from San Francisco, so Indians who are there, and they have shown all the Christopher Ames they have shown, and they have shown Serena Wu. So they have American opinions also, and they have this year they have moved to India. So they are going to get surgery in India, and there they have kind of counseled. And now Christopher Ames is a neurosurgeon, and he has said transoral odontoid resection is going to be a like a sort of a morbid, relatively dangerous procedure.
This is
so they have advised. So look, I don't know the right answer. I am asking because surgery is not done. They have advised foramen magnum decompression and occipitocervical fixation.
Because for transoral odontoid,
And transoral
it's too deep actually, too far. It will be quite morbid. Too high.
This is the case where if you see all the C2 with C1 is going up. So, and the major compression would be in the center. And
Here,
if you see the nasopalatal line, this is the classical case where transnasal endoscopy decompression work well.
But still the angle is
Because,
too
no, so that's easy because you start with clivus and going down.
Well, it's not easy transoral endoscopic odontoid resection.
No, that is possible,
Possible,
transoral,
but
but
it
here
is
in this case, if you see the angle of clivus and the odontoid is quite high. So in this
No,
case, it
he's
will
saying
be.
go above the palate.
Yeah.
He's
I'm
going.
saying
He's going above
endoscopic.
the palate. So
Endoscopic transnasal.
from here,
decompression.
you put an endoscope and remove this, which is well described procedure.
That's the only way left.
See, it is easily described, but odontoid is not central, and it is difficult to do this even endoscopically endonasal.
Yeah,
we do it.
it's very
So
difficult.
it is not easy to do
It's
in
not
this
easy.
kind of easy, but it can be done. And that is doable, yeah.
It's doable, but
And still, I would think first should go from back, take out the screws, do a foramen magnum decompression, try to put a cage in C1, C2, put a spacer into C1, C2 joint, and if you can get some realignment, and then multiple anchors occipitocervical fixation.
But the only problem is even if fix the posteriorly, this is the progressive disease. So still there is a risk of further progression of odontoid.
No, once, what I'm saying is, if you can
No,
put a
once it
spacer, you try
fixes,
to correct with that through spacer.
no, even if you correct partially and fix it, and then it doesn't. What would you do?
This is a yesterday complication somebody showed, Abhidha showed, I think, same. So you will have a deterioration if you don't have intraop imaging. If you have imaging, then you are more confident with monitoring, then you can play with the CV junction. Otherwise,
No, we have monitor and that.
So
we
then
can
you
do.
can do, then you can go posteriorly and do the first that, and then.
So what I am going to attempt is I'll go back, remove the screw, remove the bone graft. Anyway, that bone graft is not bridging. Try to do what Dr. Luhana just said, facet. And if I find that there is some movement there, then I'll flip the patient, go from the front, do the release, and then come back again from the back and then fix it. Because if I'm able to get some movement, then my confidence increases of flipping the patient. But if I like everything is like rock solid jammed there, then because the flip is a problem also. Once you start releasing them now, the flips are not safe. So you have to be really careful in flipping these patients.
Navigation would be very important in this. Neuro navigation, because it exactly tell you where the tip it is, where you are going. Otherwise, it's very high.
No, we will navigate. All that thing we'll do, but question is how much we will be able to achieve. And then the parents have they are saying whatever it is, transoral odontoid resection, we are not acceptable to the complications. Because for whatever reasons they have been put in their mind, the which is fair, I think. It is a right thing for them to think that way.
I think we stop the discussion here.
Anyway.
Thank you so much, Kshitij, for very, very interesting rare complication, and I think please update about this.
I don't show this as my own complication next time.
Hope for the best. So we'll move on to the next session. This is the last session, and followed by that there will be vote of thanks, prize distribution, memento distribution, and then GBM. I would appreciate that all the new generation as well as seniors would attend GBM. That will take our path forward. And now I'll invite panelists for last session, Dr. G.D. Tharadara sir, Dr. Khushal Shah, Dr. Denish Patel, Dr. Sharvil Gajjar, compulsory.
Good evening. Post-lunch session. I request all case presenter be in time. There is a 5-minute case presentation, 2-minute discussion. Okay, first case presentation by Dr. Hardik is ready.
No laptop. Okay. It will be better if you keep one laptop here. Yes. Yes. Good afternoon. So continuing with the complications of cervical spine, this is the case I had faced the issue of C5 palsy. That's very common, as we all know. So he is a 57-year male in the March 2023, post road traffic accident, fall from the two-wheeler. He had a severe radicular pain in both upper limb, and along with that severe paresthesia, the burning both forearm and hands. The left side hand grip was weaker than the right side, and the ball bladder was normal, and there was no clinically myelopathy signs. And these are the flexion extension X-ray of the patient. The patient was in terrible pain that he could not even sleep or even lie down because of pain. So I put the patient, these are the MR scan, and the MRI you can see multi-level disc bulges with some compression at the level of mainly 4-5, some at the 3-4 and 5-6. And I put the patient on analgesic and the IV steroids, even though he was intense pain and his hand grip was not improving. So on the third day, I had offered him a surgery, standard posterior surgery. These are the axial scan. Mainly, where is the pointer? Do you have the pointer? Yeah, so mainly the compression at the level of 4-5, a little bit of lower down and somewhat, I'm not sure which level is this, but there was a bit compression. So I did a posterior surgery, laminectomy. Post-surgery, patient was having bilateral C5 palsy on the very next after the surgery, even the same day. So I did the MR scan, and this is the MR, very well decompression with some edema at the level of 3-4. And as we all know, the chances of C5 palsy is very common, but in this case it was a bilateral. So, and this was the axial scan, a very narrow, the foramen anatomy. Actually,
This was the case. I did a foraminotomy on the right side, just as I was trying to learn the posterior approach for the foraminoplasty and discectomy. So I did just for the right side, and that side it was a narrow, but patient had a bilateral, and the other side was fine. So this was the narrow foramen at the level of 4-5 on the right side. The other side was fine. So this is a study by AO Spine Group in 2017. They published a multi-center study of 13,946 patients, and they have reported it is the post-operative C5 palsy is around 0.0 to 2.5%, but actually we see much higher. I would say around 10 to 15% of the C5 palsy, and out of that almost 54% recover and 25% partially, and 17% did not recover in that study. So intraoperative neuromonitoring, does that make any difference? So the sustained EMG activity during the surgery is a possible warning sign of irritation, but that is also not proven whether that can help you to decrease the chances of C5 palsy. The foraminotomy is also questionable. It is not concrete evidence for that. So in this, the gradually patient recovered over the period of 3 months. This is a video of 1 month, and this is the last video of 3 months. Patient completely recovered. So literature reported around 5 to 7% of bilateral C5 palsy, and the patient recovered completely, but story doesn't end here. This is in August 2024. The patient fell down again, presented with the weakness of all 4 limbs, 2 to 3 grade power. There was massive intradural that is signal changes, and there was no compression. So we keep the patient on the conservative. Sorry, we didn't do dynamic scan here, but this was the picture after that, and this was the axial scan, and the sagittal images again on the right side, a pinch. But this was the scan actually 1 year down the line again. Sorry, if I'm not wrong, yeah, that was a scan 1 year down the line. There is still intensity changes, and now 2 years after this is the final status. Patient didn't recover completely, but able to walk himself, and still there is a weakness proximal in the upper limb. Thank you.
Any questions? Okay, Bharat bhai, your comment please.
When? Now. Okay.
It's going to increase the intramedullary signals.
No. Okay. Yes.
Is there any literature which suggests that laminectomy with fusion would decrease the rates of C5 palsy as compared to laminectomy alone? Increase. Thank you.
Yeah. Thank you, sir. Yes, Bharat sir.
Yeah. I'm sure it's been discussed at a length in many meetings. So we always do with the bone scalpel and 2 millimeter medial to the spinolaminal line. So we do not go at the spinolaminal line. So that is why the root traction is practically minimum. So, and the another thing which we follow post-operative is ask the patient to support the elbows all the time, so that there is no shoulder shrugging and the traction on the shoulder. So these are the two things. Even when they walk first 3 weeks, they walk with the shrugged shoulder. Okay. And when they are lying in the bed or when they are sitting in the chair, their elbows are supported, so that there is no traction on the shoulder. So these are the things which we follow.
You notice immediately post-op.
Yes, understand.
Have you strapped the shoulder on
Yes.
table?
Yes.
That is can be another reason. Your assistant or someone will strap shoulder so tightly to lower down it. In laminectomy, usually it is not at all required. Because we have to see just to level confirm C2, it's okay. There is no need to any imaging during surgery. Why we strap shoulder so significant?
No, just the strapping just for the
This can be
skin.
the another reason.
Yeah. But
This
you
can
are,
be with the resist.
that you are suggesting some rotator tear with the strap?
Traction, C5. Already compromised canal, laminectomy, displaced cord, severe stitching of the shoulder. That can be another factor.
Okay, point
Sir,
taken.
any role of position of neck post-operatively, like putting a pillow, putting in flexion, any role of those things, anything, anyone practices for that? No. Neutral. Oh, okay, fine. Thank you.
Thank you.
Okay, thank you. Now next case, Dr. Anil Solanki.
We all are lying to learn from our complications, and here is one complication which we've had faced. Okay, so she was a 42-year female, presented with neck pain in left arm radiation for 1 month and weakness for 5 days. No bladder symptoms. She had taken cervical epidural before coming to me, and it was not working very well, and she was in still severe pain. On examination, she had shoulder abductor 1 to 2/5 and bicep for almost 0. And C5, C6 hypostasia. The rest of the findings were normal. So these are the X-rays and these are the MRIs. So here there are 2 level disc problems, C4-5 and C5-6. Definitely C5-6 is more severe, but I couldn't ignore the finding at C4-5 also. So, first of all, my question is, with this prolapse, is this neurology, bicep 0/5, is it explainable? It was not digestible for me, at least. So I suspected there must be some neurological other problems. So when patient already had taken a neurologist's opinion and EMG once NCV was already done. So this again reconfirmed that it is C5-6 radiculopathy only. And I have talked to the neurologist also, but she was more convinced about the cervical problem. But she also said that it is not common to have a 0/5 power still with this. So this was the first finding which was unusual in this case. Okay, as we have already discussed what would be the plan in multiple cases before. So my plan was to do a 2-level ACDF in this case. But I always tried to learn and I was eager to learn about the posterior foramen anatomy. So I thought that this would be the case, that I will try the posterior one first. And already I had explained the patient about the posterior anterior surgery both. And I started with the posterior. So this was the 1 level I could do by the tubes. And later we completed the surgery by 2-level ACDF. And these are the X-rays. And immediate post-operatively, patient had a right side tricep and hand grip weakness. Initially it was on the left side. I operated from the left side posteriorly, then anteriorly, and now the patient has right side tricep and hand grip weakness on the same day.
Have you got a pre-op CT scan done?
No. Why you are asking for that?
To know the status of the disc, whether it is just a soft disc or a DOC?
Yes, good question, sir. Actually, it was a hard disc at C5-6. And that was another thought which came later in my mind. But with this right side tricep and hand grip weakness, I was worried. And after 1 hour, I got a call that patient has blurring of vision. So we asked, and patient was resistant to go for MRI. So we did a multiple counseling for her, and on the next day morning she convinced for the MRI. And these are the MRI findings. So it was a panic situation for me and relatives. So because of these findings, acute infarct with hemorrhagic conversion in the right high parietal lobe and left cerebral hemisphere, it was a non-hemorrhagic infarct. There are many neurosurgeons here. This was the first thing came as a report. But after discussion with everyone, as the patient had a right side new onset deficit and the infarct here was also on the right side, so it was not clinically matching. So got a cervical spine MRI, and if you see, there are signal changes at both operated level and edema in the cervical cord. So this could possibly explain about the weakness she had. But again, it was operated under microscope, not too much of the manipulation, but still this happened. If anyone can help me in this, in explaining why this happens, or is it anything we are missing here? Yes, sir. Sir, actually this is the first case for me for the posterior. I was not confident enough. Okay.
See, this is a very good learning case. What we should learn in this is, whenever you operate any patient who is older or has comorbidities, always think of stroke and DVTs. Always think about it. You have 4 arteries which are going there on the brain, and if you put a neck retractor to retract the carotid artery, if the patient has diffuse atherosclerotic disease and you retract the carotid...
She was 40 years, sir.
No, I'm just telling you for learning.
Yes, sir.
Sometimes your retraction on carotid artery can also cause a stroke upstairs. Vertebral arteries are very near. So if you show me the axial section, you have this? No. Yeah. So your foraminotomy on one side is quite extensive actually, and you are nearing the vertebral artery, but your stroke is not in the vertebral artery territory. So whatever foraminotomy you have done, it is quite extensive. It is more than normal, which we will do.
Yes, sir.
So facet removal, it has been very extensive, and you are very near to the vertebral artery where you go anteriorly there. And you are very near to the carotid also.
And in fact, left side vertebral, you would see probably dissection there.
Yeah, dissection there.
Last one, you can see flow of vertebral artery on right, that is black. And you can see that's white, that's a thrombosed or dissection of vertebral.
Okay.
Give me pointer.
Here?
Yeah.
There is no flow in the vessel.
Sorry. Okay. So if you see that's a vertebral, flowing vertebral, that's a vertebral. But if you see here, probably a posterior foraminotomy, you went 2 front, 2 in front, and that may be the cause.
No, show me the brain MRI. Actually, the territory is slightly
different.
Though that is why MRI of the brain.
And another thing is, first thing is, posterior foraminotomy, your choice of selection has to be right. This is like C4-5 foraminotomy. It may be a good case, but 5-6 is
exactly. As
contraindicated.
Rightly pointed out by sir, it was a hard disk. It should be attended at C4-5 rather than at C5-6 level.
No, it was a vertebral dissection only which has caused this.
And to me, the first indication as such, 0/5 deltoid with such a small C4-5 compression doesn't set in the mind for day one. Surgery only it doesn't set in. I would leave the patient. Means 0/5.
I will just finish off as time is closing. So as it was not correlating with the MRI brain finding, correlated with the, and this was a CT angio done 2 days later. It showed there is V2 to V3 segment, there is no flow, V2 to V4. And it was definitely a case where vertebral was injured. But gradually she improved over the period of 10 days. Tricep was 2/5. Left shoulder was still there. On the 4 weeks, tricep was 3/5. And at 6 months, she improved completely.
Thank you, Ali. Regarding your first clinical correlation, sometime root anomaly, or even I have seen the 2 patients having for neck pain, there is a manipulation that associated brachial plexus injury by manipulation. Still 1 patient recently under treatment. Mild neck pain, upper limb and everything is manipulated, brachial plexus injury occur. Confirmed with MRI as well as EMG and CV. So history of manipulation is is also important when there is a no clinico-radiological correlation or root anomaly also. Anyway, thank you.
Thank you, sir.
Now I request Dr. Arijit Vasista.
Good afternoon, everyone. So I come here again to present two cases. So my first case, I'll start. So a young male, 20-year-old male student came with left grip weakness that is there since last 5 years but has worsened recently. He has mild tingling numbness in left upper limb, but there's no pain, no lower limb symptoms, no signs of myelopathy. And clinically, he had wasting of the distal forearm and first dorsal interosseous space and weakness in the finger abduction and grip as well. These are the radiological images showing no gross instability. And these are his MRIs in the neutral, extension and flexion position. So to summarize, a young male with unilateral distal wasting with no sensory symptoms, grip weakness and no features of myelopathy. So I guess that would bring the diagnosis to your mind. If not, then this picture will. So we are talking here about Hirayama disease. Many theories have been postulated regarding the pathogenesis of this dural sac dysplasia. There is disproportionate growth between the cord and the spinal canal, which tenses the posterior dura, and during flexion, the cord oppresses over the posterior aspect of vertebra, and hence there is ischemia over the anterior spinal artery, and the anterior horn cells, they are very susceptible to ischemia, and hence they are affected, resulting in the symptoms. Other theories such as nerve root dysplasia, spinal ligament abnormalities, and venous dysplasia are also described. So this is the diagnostic criteria for Hirayama disease, the Huoshan diagnostic criteria, and our patient did fit into all this. But what to do next? Should we just observe? Should we try conservative management with a collar to prevent flexion? That has been described quite enough in literature. Or we have to go for surgical management considering the recent worsening of symptoms. So many surgical options have been described from posterior. It ranges from just facetal fixation to laminectomies to just fixation followed by removal of implants, or you can do anterior multi-level ACDs. So this is what we did. These are the immediate post-op images. And this is the 6-month follow-up of the patient. His grip has weakness, but still there is difficulty in abduction, and wasting is also there. So these are my literature supports. I'll rush through my next case. Again, 36-year-old male manual laborer, right upper limb distal weakness, but this time he has myelopathy as well. These are his images, and these are his MRI images, showing anterior epidural hyperintensities, which is hypointense on T1, and it is extending right till the middle or lower dorsal area. So we thought about differential, what could it be? Whether it could be arachnoid cyst or spontaneous CSF leak. So then we went ahead with CT myelogram. So we can appreciate there are two calcified discs, and if you can see in the axial section, there is a maintained dye within around the cord, and when it goes across this calcified disc, it starts communicating to the epidural space, and then the dye flows out. So what next? Whether to approach it from anterior or posterior? So we went from posterior, approached, did the laminectomy, went transdural, retracted the cord, found the dural tear that you can see in the first video. Later on, we placed a tissue patch lateral to the dura into the anterior epidural space, and then through the dural tear, we brought it inside the cord. So kind of plugged the defect. And then we also did the fascectomy, so we fixed it. These are the 6 weeks post-op clinical images. clinical video. His grip has significantly improved, myelopathy has improved, his balance has improved. And this is the MRI at 6 weeks. So these are again the literature supports. There are some proposed classification system for CSF leaks where the type 1 dural tears are more common. Thank you.
Thank you, Dr. Arijit. Any questions from the audience? So we will be moving on to the next case. The next case is rotational instability in CV junction by Dr. Yaksh Sompura. Sorry. CV junction case by Dr. Hitesh Chitroda.
Good evening, everyone. Today I might discuss case of the CV junction anomaly. Young male presented with me with the imbalance while walking, difficulty in walking, and bilateral grip weakness with quadriparesis. Patient investigated, and in MRI, patient having a complex CVJ anomaly, atlantoaxial dislocation with basilar invagination with posterior cerebellar tonsillar herniation along with the syrinx formation. I further investigated and do the dynamic CT-CVJ. In dynamic CT-CVJ, there is the upward migration of the dens along with the atlantoaxial dislocation with the tight foramen magnum, and in the coronal section there is the developmental defect in the atlas, and atlas is occipitalized and assimilated, and along with the C2, C3 and C4, 5 fused vertebra. This is in the flexion extension. In flexion extension there is the reduction of the AID in extension, and the AID will be increased in the flexion. This is in the 3D. There is the rotational anomaly AID with BI with the fused vertebra. This is the CT vertebral angiography. In vertebral artery, there is the left in the both the side course is the normal, but in the right side there is the intracranial portion of the vertebral artery may be the absent, or there is a less flow. So in that case, I plan for the posterior decompression and fixation. So I go for the occipital C2 fixation with foramen magnum decompression. And the patient will be improved post-operatively, and patient will be discharged within 4 to 5 days. And in follow-up after 7 days, patient will further deteriorated. After initial immediate post-operative, patient will be improved and then discharged. But after 1 week, patient will be deteriorated. He will be land up in the wheelchair. Then I further investigated. In further investigation, there is a still compression. There is a still compression of the CV junction with the tight posterior fossa. With there is the cerebellar tonsillar herniation. In a pre-operative, there is a cerebellar tonsillar is roughly around 10 to 11 mm. But in post-operative, there is the migration of the cerebellar tonsil around 25 mm. This is the post-operative scan. Then next what? Patient is then I admit the patient and initially manage with the medical management. Give the high dose of the methylprednisolone and strict bed rest. Some amount of the weakness will be improved, but not that much of initially improve in immediate post-operative period. Then next what I plan for, either I go for the re-exploration with foramen magnum decompression with augmented duraplasty or tonsillar debulking. Then other option is anterior approach for transoral decompression. Then I go for the transoral decompression. In transoral decompression, patient is in supine position after given the general anesthesia applied for the mouth gag retractors. In transoral decompression, uvula is retracted upward. Then the uvula is retracted upward, tongue is retracted downward, and there is an incision of the midline mucosa in oropharynx. And then the muscle is separated from the midline. Then using the high-speed drill, decompression of the dens was done. And this is the amount of the transoral decompression was done by the transoral. These are the two dissector. This much amount of the dens was decompressed. After the decompression, adequate hemostasis is achieved and layer-wise closure was done. This is the post-operative CT scan. In CT scan, there is a release of the pressure over the CV junction, and there is a adequate decompression of the transoral was done by the transoral decompression. This is the construct of the surgery.
How was clinical post-operative? Did patient improve after transoral surgery?
Yes, sir. Patient will gradually improve after the transoral decompression. Yes, sir.
Yes.
In second surgery, when I do the transoral decompression, I have nothing to do with the cerebral tonsils.
No, but again, foramen magnum was again expanded to accommodate the descending cerebellum. That's why it got cervical.
Yes, sir, right, but still there is the compression of the CVJ by the C2 dens. So I think if I not done the posterior foramen magnum decompression, patient has still symptom.
So two things. One is very important. What he said is very rightly said. If you do very aggressive posterior foraminotomy or suboccipital decompression, like traditionally it was said 1 inch into 1 inch, but it is just what needed is just to 5-6 millimeter of ream of posterior foramen magnum.
Yes.
As yesterday Dr. Satish Rudrappa explained, when you do a larger decompression, the cerebellar sag happens and that would cause recompression. So I have two patients where patient deteriorated later on. I had to do posterior fossa cranioplasty and then those patients improved.
Posterior decompression is not a replacement for getting that odontoid in the front.
Yeah. And probably would have put us. And putting a spacer on a joint would have probably two things means. FMD would have been smaller and spacer or a bone graft into the C1C2 joint opening is very, very essential in this kind of cases.
Okay. Yeah. So according to you, in that case, transoral decompression was not required.
That's what I feel, yeah.
Complication would not have happened.
Thank you. Thank you, sir.
Moving on to the next case, rotational instability in CV junction by Dr. Yaksh Sompura.
So very good afternoon. 40-year female presented with neck pain, interscapular pain, both hand tingling numbness, severe upper back pain, and difficulty in standing from the floor since last 12 years. And all these symptoms increased for 5 years. Pain assessment score was very severe, approx 8. So on examination, spasticity was present in all 4 limbs, or reflex were hyper, and UMN signs were present. So when I did the MRI showed no any compression, means there was no any cord changes. So what could be the cause? Then I rule out the nutritional deficiencies. It could be idiopathic psychiatric opinions, but Then I look for the parasagittal section of the MRI, and it showed that condyle C1 and C2 were not in alignment over the right side parasagittal section. Then I did the CT scans. CT scan also showed the right side parasagittal were not in alignment, left side they were in alignment. After that, I did the 3D CT cut in which rotational means I rotate CT cervical spine was done 90-degree rotated right and left lateral, and in that C1 C2 joint over the right side it was 70% outside, while on the left side it was 62% outside, and lateral and atlantodental interval it was far more higher over the left side. Angio was normal. So lateral anterodental interval was left side was 4.2 mm, while over the right side it was 3.4. So difference was very high. And rest of the CT morphometric parameters were normal, like anterior atlantodental interval, power ratio, Chamberlain's line, all were normal. And patient was complaining of severe upper back pain. So I did the X-ray. It showed a little bit of scoliosis. So due to the CVJ anomaly, the scoliosis could be there. So then I operated for C1 C2 fixation. I planned for it. Can the video be run? As you can see, when I open the muscles, and this is C2 spinous process, and I try to mobilize it was very much unstable. On movement, instability was too much present. And intra-op, we did the ganglion sparing C1 C2 fixation. As you can see, while putting the spacer, we displace the ganglion towards the upper side. Can you run the video? This is from the left side. Run the video. And while putting the screw, I displace the ganglion towards the lower side by the dissector. Yes. It's not running. Yes. So both sides, left side spacer was little bit outside, but that was fixed, and it could nothing I did further because there was no any mobility, or it could not be removed easily. So this is the X-rays. So patient, what was the result? Patient showed immediate neck improvement in terms of neck pain, interscapular pain, and her upper back pain was reduced from score 9 to 3. So after 12 years, she was substantially pain relief and showed positive outlook towards the recovery. So my literature goes with the Atul Goel sir, in which atlantoaxial is the most unstable joint, and it has both sides convex. Generally, joints should have concave or convex for the stability, but atlantoaxial, they are both sides convex, they are highly unstable. And facts is there, joints provide, for the joint stability for C1, C2, transverse ligament and alar ligament are the main ligaments to provide the stability for C1, C2 joints. When this ligament laxity is there, That leads to the facetal instability, and that leads to the CVJ anomalies. And C1, C2 facial listus is generally of three types. Type 1, in which C1 lateral mass is anteriorly displaced. In type 2, it is posteriorly displaced, C1, which was in our case. And in type 3, both facets, they are in alignment. So how to check the ligament laxity? For that, generally 3 Tesla MRI is required with proton density, high definition proton density images, in which the signal changes can be seen. This is just the normal MRI for reference of 3 Tesla MRI proton density image. So treatment protocols, generally this type of patients initially should always be undergone for conservative treatment for minimum of 6 months. Hard cervical collar, restrict neck movements, oral medications should be given. If symptoms still persist or if they still deteriorate, then surgical intervention is suggested. Before undergoing such surgical intervention, all other causes of hereditary any spasticity, family history, Hiramaya disease, nutritional deficiencies should be ruled out. So rotational instability, evolving concepts, they are that traditionally it was still said that 50 to 70% if C1, C2 are displaced, then they are high suspicious of instability. If they are 70%, greater than 70% they are displaced, then highly likely of rotational instability. But still, I have seen many asymptomatic instability, but patient do not any complaints. So still, the relationship between the clinical findings and imaging,
Okay, Dr.
they are
Yash,
unclear.
yes. The time is up.
Yes, sir.
Just put a short question to the house. This was something new. So, Dubey sir, Rakesh bhai, Nimesh bhai, how many of you get a rotatory CT scan done regularly in C1, C2 cases? This was something new for me also and anyone else in the house also.
So it is very recently proposed by Dr. Atul Goyal sir. Only last year, probably in first time he had proposed. So it's very new. We just got couple of patients as a trial, but haven't intervened in those patients so far.
Same here.
Means patient upper back pain has been much significantly being reduced. So, no sir, I will wait for 6 months and do the X-ray again to see means patient is still in follow-up.
अर्जुन ने खाली आंख देखा है.
So the maximum literature on rotatory CT scans is by Dachling Pang. Okay, and there's like extensive paper on it for atlantoaxial rotatory subluxations, and it's a very interesting read also. In that paper, he describes what is a normal C1, C2 rotation as well. So he took a bunch of normal controls and then did rotations in them and then checked how the C1, C2 rotates left to right, you know. And I find that this sort of contradicts that because all these kind of rotations are seen in normal people.
Yes.
Correct. So it has to
So
be
clinical,
with a pinch of salt. That is what I felt also.
Yeah. So clinical, patient's clinical and examination is must for proper
I understand,
understanding.
but
Yes, sir.
that kind of normal anatomical change for us to explain that leap of faith that all your neck pain, numbness, fibromyalgia symptoms are because of a rotatory subluxation.
That's exactly the
is
point
a little bit far-fetched because
that to get a conviction of it and to
and
leave
then
the patient without any rotations after the surgery.
And then I have had patients who have, now this is a real thing because I've had patients who have taken stem cells for craniocervical instability in United States. Some person is giving stem cells for diagnosis of craniocervical instability in this manner. Like the diagnosis is that way. So that kind of, and then they are obviously not better because they have this myofascial pain syndrome and fibromyalgia symptoms and it all escalates, or sometimes it works like a placebo and then some people say I'm look very, very fine.
So yeah, that's very valid point. In fact, I had seen few patients who have been operated C1, C2 fixation and they are roaming around in whole city. So this kind of fixation fusion has been proposed by Dr. Goyal sir, but I think has to be very judicious.
Yes, sir. Very
over indication.
There is a role of diagnostic blocks. There is a role of diagnostic blocks if you are really want to be sure if you are doing these new procedures. Until that, don't. I think
Yes,
it is
sir.
not right to do it in our hands.
True.
Maybe
Yes, sir. Because
as a gold
patient
standard.
were classical UM and reflexes were very hyper, so I proceeded
Correct.
further.
Correct. So that's not a nice case, but right. So
Yes,
it's a nice case, but to the house it
Yes,
has to be
sir.
taken with a pinch of salt, not to go in this for every case. Thank you. Thank you, Doctor.
Moving on to the next case, navigation assisted C2 osteoid osteoma excision by Dr. Mallikarjun Rainath.
Good afternoon, everyone. I will be speaking on navigation assisted C2 osteoid osteoma excision, a precision surgery in the upper cervical spine. This is a 30-year-old male who had come to our OPD with neck pain and restricted movements for the past 3 to 5 months. He had occasional shoulder pain, and the pain was more at the night times, and it was relieved on taking medications. There were no upper limb complaints, there was no gait disturbances or any fine motor skill disturbances. Patient had no limb weakness also. On examination, there was paraspinal muscle spasm present and localized upper cervical tenderness on the right side. Neck movements, right-sided rotational movements were painful and restricted. Other movements were terminally painful. A neurological examination was essentially normal. So we got a preliminary investigation X-ray which showed subtle changes involving the C2, C3 joint with a radiolucent lesion, and there was no instability whatsoever. And MRI mid-sagittal sections showed no cord compression or canal stenosis, and the disc appeared to be normal. And however, the right-sided parasagittal cuts they show on T1 weighted images. We can see there is a hypointense lesion surrounded by bony sclerotic lesion. And on T2 weighted images, we can see that there is a hypointense lesion which is surrounded by soft tissue edema along with marrow edema. So in the coronal sections also we can see that there is the lesion is around the inferior articular process of the C2 with surrounding soft tissue edema and bone marrow edema. Similarly, we can see that the axial section shows the lesion very close to the C2, C3 joint on the right side. You can easily make out on this. So next we went ahead and did a CT scan, which is a gold standard for osteoid osteoma. We can see that there is a lucent nidus surrounded by halo and with the sclerotic margins. So in the sagittal sections, we can see that the lesion is very close to the C2, C3 facet joint. These are the axial sections showing the same lesion. Looking at the clinical and radiological parameters, this patient fitted into the WHO criteria of osteoid osteoma, which has two parts, essential criteria and desirable criteria. The essential criteria mainly has imaging appearances with nidus less than 2 to 2.5 centimeter with surrounding sclerosis, histological evidence showing bone with good vascularized rim. However, the desirable criteria are nocturnal pain relief with NSAIDs, and there is a narrow transition zone between the central nidus. So before the patient came to us, he had multiple consultations, and his main demand was that he wanted to preserve his neck movements. So that was the patient's demand. So we gave him the multiple options of non-operative and operative. In non-operative, it is mainly physiotherapy and NSAIDs. In non-operative invasive techniques, there are for long bones we can use radiofrequency ablation and laser photocoagulation. However, in operative, these are the important points to look after when we choose operative: the preservation of joint and neck movements. However, during the procedure, if there is a facet violation, then what are the other options, whether to fix the segment or not, and whether to do open surgery or minimally invasive surgery. So patient was counseled about the various options, risk and benefits were explained, and we told him that if at all the facet gets violated, and we might need to fix the joint. So we chose to do navigated assisted tubular microscopic tumor excision. So why the navigation? So navigation provides precision, sub-millimeter accuracy in critical anatomy. It provides safety because there is a real-time visualization of the vertebral artery and spinal canal. There is minimal exposure with less muscle dissection, and confidence that before closure we can take one more spin and we can confirm that the entire nidus is removed. However, it is particularly valuable in lesion which is very deep within the bone and adjacent to important neurovascular structures, and revision surgery with distorted anatomy. So this is the OT setup. Patient was put in prone position and with a horseshoe head support. The reference tracker was placed over the C7, and the docking was
please
done.
Speed up.
Yes, sir. The docking was done with the help of navigation probe, and a 16 millimeter tube was used to dock at the C2 inferior articular process on the right side. So soft tissue dissection was done. We could localize the nidus, and the entry was made with a 3 millimeter burr, navigated burr, and for each and every step we used the probe to exactly localize where the nidus was. The outer sclerotic bony margins were removed, and then the thin pointed 2 millimeter burr was used to remove the entire nidus, keeping in mind about the articular facet. So curettage was done to remove the sclerotic margin, and then the inner nidus, which is a hypervascular structure which appears like a cherry, was removed with frequent curettage. So en bloc removal of the nidus is very important because if at all there is any residual tumor left, it might cause recurrence of the tumor. There are 5 to 25% of the recurrence rates in osteoid osteoma. So this is that nidus which was removed with the help of the disc forceps. So once the nidus was removed, hemostasis was achieved, and the cavity was plugged with thorough wash was taken, and Abgel was placed within the cavity to achieve hemostasis. So this is a pre-op intraoperative OAM images which shows the nidus and surrounding bony sclerotic muscles, and we can.
Okay, thank you, doctor. Yeah.
Yes, we can clearly see that the complete removal of the nidus was done. So this prevents the recurrence of this. Thank you.
Is there any other option?
So we could go for open surgery, but however it might risk the facet violations.
With navigation assisted, percutaneous, or even open, radio frequency ablation will help or not? I don't know,
Sir,
but that
in
is
this
one modality.
Given the proximity of the important neural structures like vertebral artery and the spinal cord, radio frequency ablation and laser photocoagulation is less preferred when compared to long bones, where it is the most preferred method to do that.
And another quick question means you used OAM navigation, right? And
yes.
Did you put your patient prone on the Mayfield, or it was just a prone position?
Prone position with horseshoe head stabilized.
It is very well documented that in cervical posterior, if you just push through the I am not using it, but people you use, they say that cervical posterior, when you just push through with the drill, it moves and the direction changes. Everyone have noticed that. So there is just a point that they use Mayfield tongs just so that the head stabilizes. Those who are using can elaborate more on that.
Here we didn't use.
Yeah, just on a horseshoe it would move and then you might miss the mark.
Yes, we taped the head, stabilized the head properly, sir, and then we used a high-speed burr so that there was no giveaway while making the entry into the lesion.
And that is what I heard recently yesterday at BSSCon, that it is not approved US FDA for cervical spine OAM. It is only approved for dorsal and lumbar spine. US FDA doesn't approve OAM navigation for cervical spine because of the same reason.
So more than that, without that, you cannot put the graft, because if you removed such a big lesion from there, if you do by open technique, or I don't know whether navigation or not navigation, but then you need to put a graft there.
It is,
otherwise, it is going to become unstable after some time.
So usually the
Bharat,
lesion.
yes, Bharat.
Can I?
Yeah.
Sorry, okay.
Can I? Yeah. So, two ways to rectify this. Before putting the reference frame, you have the instrument, you have to verify the instrument. Do not put the frame and then verify. So there is practically zero movement. Second thing, when you put the reference frame, there is 3-leg clamp is available. So C2, it's only 1-leg clamp. But if you want to extend from C5, 6, 7, the 3-leg clamp is there. So it gives better accuracy and more grip. So then the reference frame movement is practically
Chances
zero.
of error are decreased, yes. Thank you. Thank you, doctor.
Thank you.
So now I request Dr. Sarvin Sheth, post-irradiation cervical deformity correction.
Good afternoon. I thank Dr. Rakesh sir and SAG for providing me this opportunity for the case presentation. So this is a 53-year-old male who had a past history of glottic carcinoma. In December 2020, he was operated for the same with the excision surgery followed by radiation and chemotherapy. Post that, he had a tracheostomy scar as well with a purulent MRSA infection, and the patient was seropositive as well. We can see the pre-cancer excision MRI on the bottom here with the glottic mass, and this is the immediate post-operative MRI after the cancer surgery that was done. The patient had no cervical complaint so far. The patient presented to us in February with persistent neck pain and occasional bilateral upper limb paresthesias. He did not have any neurological problem or a myelopathy kind of a picture. The MRI showed post-radiation marrow changes, and conservative management was advised because of just the neck pain. The patient presented again in August with the persistent neck pain, and again the CT scan showed destruction from C3 to C6 with a kyphotic cervical deformity. The conservative management went all for a year, after which he presented with quadriparesis and a nuric 5-6 of a kind of a myelopathy where the patient was not able to stand or walk even with support. He had a severe cervical kyphosis with a chin on chest kind of a deformity and a persistent discharging sinus from the tracheostomy scar and a left sternoclavicular joint region. So this is the MRI of that time when he presented with the myelopathy. There is severe destruction of the cervical C3 to C6 or 7 vertebral bodies along with pre and paravertebral collections and significant compromise of the cervical spinal cord. So this is the clinical picture with the X-rays and the MRIs. We can see the patient as well. There is a severe deformity. There is a tracheostomy scar here with a discharging sinus at the same level. And the anterior, the neck region the skin is severely compromised. So the challenges here for the anterior approach were quite a few. There was a severe fixed deformity which was not moving. There was a poor skin and soft tissue condition and coverage because of the fibrosis, poor vascularity post radiation, and the skin was significantly atrophied. And there was a chronic discharging sinus with an active MRSA infection which was proven on culture sensitivity reports. So the plan was to go for a posterior cervical approach with cervical pedicle screw instrumentation, laminectomy and fusion. So this is the immediate post-operative period. The fixation was done from C2 to T1 with pedicle screws, all pedicle screws on one side and not all on the other. And there is a significant correction of the deformity along with decent enough decompression of the spinal cord spinal canal. And we can see the chin on chest deformity has also corrected with quite a few, the gap between the chin and the chest has increased. And this dressing is of the persistent sternoclavicular osteomyelitis. The patient showed gradual recovery of neurology. He started walking with support, started gradually. There was a lot of improvement in the neurological power as well. And the wound also healed by the same time. And recently the patient showed with a 4-year follow-up with absolutely no neurological symptoms, independent walker, doing all of his work independently, no active MRSA or spinal infection of the time. The sternoclavicular infection is still there, but he's doing daily dressings for it by himself. And we can see the correction has held. Looks like the cervical spine is also fused with a decent 6 degree of kyphosis as compared to the 65 degree pre-operative kyphosis at the time. And this is the entire course of how the patient presented to us right from this point of time, where it gradually progressed and then it was corrected. So to sum it up, radiation-induced changes profoundly alter the surgical anatomy, vascularity and healing potential. So that has to be factored in. MRSA discitis in post-iridatic cervical spine demands a multidisciplinary approach. Anterior approach may not always be a default for cervical spine pathology. Posterior fixation and decompression and fusion can achieve excellent neurological recovery even in complex contaminated post-radiated field. Thank you.
Excellent case. Any questions from the audience? So we will be moving on to the next case by Dr. Parth Jani, complication of CV junction.
Good afternoon. Please play the slides. I think this is a different case. Please play Dr. Parth Jani case. Good afternoon, sir. So I'll just start with the history. She is a 21-year-old female who presented to us with spastic quadriparesis and wasting of both the upper limbs. On MRI CVJ, we could see a classical type 1 Arnold-Chiari. Clinically, sorry, I forgot to mention that she had a very short and webbed neck. So it was a lean and thin female with a very short neck and a small mandible also, which was a recessing mandible. And na ayush hai emna ma nakhi tamara pen drive ma na aa wala pen drive ma yeah Harshil bhai,
Dr. Harshil.
again just it's there. Next slide, please. Okay. So she also had bladder involvement, so increased frequency of micturition and hyperreflexia with webbed neck and spasticity on all 4 limbs. Looking at the MR picture, she was having classical, there was a crowding at foramen magnum with a syrinx in the lower cervical cord. This was the syrinx, and there was no tethering lower down, and we also got a CT to rule out hydrocephalus. So there was no hydrocephalus pre-operatively. Even the temporal horns and like there was the ventricles were quite chinked. So this was the CT CV junction, and there was no significant instability. And although the tip of the dents was around 18 millimeters above the Chamberlain line, but this was the CT CVJ. So we basically planned a foramen magnum decompression with duroplasty and a fixation with that. So we did a FMD with MRI. Yes, sir. So this was the MR picture. Yeah. With a very short neck and a very high riding odontoid. So, and syrinx in the lower cord, a large syrinx. So we did a foramen magnum decompression with a patch duroplasty, and we also did a fixation with our ortho team, the occipito C345 fixation. That is what we did, just to stabilize. So now the complication I would start. So on post-op day 0 only, she was extubated. After extubation, she was conscious, alert, no added deficits. She complained of dysphagia with throat pain and a difficulty in swallowing with some liquids, and also in the late evening, by 10 p.m. in the late evening, she had difficulty in breathing with desaturation. So this was one of the first issue, that it was already fixed CVJ and we had to intubate this patient. So it was the most difficult thing that we faced, and we did a urgent fiber optic guided intubation. Her intubation tube size was also 6 only. So it is very difficult to intubate a 6 thing with a adult fiber optic. So we had to get a pediatric fiber optic bronchoscope at 10 p.m. in the night to intubate this patient. Then we get, after securing the airway, stabilizing the patient, we get a MR CVJ and CT CVJ done the next morning. So this was the CT CVJ, which was looking more or less okay, and this was the fixation. But when we look at the MRI, so there was actually, we had fixed this patient in flexion. So this patient had a pharyngeal outlet obstruction because of fixation in the flexion. So this was one complication which was completely iatrogenic, that it was because of our fixation in this way we had made this complication. And the other thing is, we also did a brain screening. It showed temporal horns and gradually increase in the size of the ventricles as compared to the previous one. So this was another complication, that after FMD this patient developed hydrocephalus or a developing hydrocephalus. So we had, first thing, we had planned for a re-exploration and correct the deformity to the neutral or extension as much as possible. But then I also had a doubt that we should do a shunt also, because the hydrocephalus is developing, might worsen, might not. So it was a benefit of doubt that we had given. So we did a VP shunt also on table and re-exploration, and we fixed in the extension. And this was at 1 year follow-up. The syrinx had completely disappeared, and there was nearly complete resolution of the myelopathic symptoms, and the gait and the balance was normal in this patient. So the things to learn is, first is fixation is flexion. It was completely iatrogenic. It was our mistakes. We missed it at the time of fixation. Airway management, again, it's one of the most thing we learned from this case. And this thing, development of hydrocephalus after foramen magnum decompression, we saw 2 cases in last 1 year, 1.5 years. So this was something that was new. The other case had a frank hydrocephalus with raised ICP features. So that is something that we could learn from these cases. Yes, sir.
Everything you can explain only because of the technique, because you didn't decompress it adequately.
Yeah.
The pharyngeal was because of lower cranial nerve.
Exactly. Exactly.
And because of edema which was there, so everything was because of...
It was the wrong technique and the over flexion. Yeah.
Correct. Exactly. That is what, it's not the pharyngeal outlet obstruction, lower cranial nerve palsy which has caused this rather than the pharyngeal outlet obstruction. It seems so.
Sir, sorry, could you notice the pharynx part, because of the flexion, it had already narrowed quite? You don't agree with? Okay, sir. This is what I had thought, maybe I had thought wrong. So.
But then it should desaturate immediate post-op.
This won't happen immediately. That's pharyngeal, your neck and flexion extension, your breathing doesn't change.
Yeah.
It won't change ever. It is, if you're doing this procedure, we should always think complication caused by us, sir. Not by the anesthetist first.
Okay.
Then we will be better surgeons.
So desaturation and dysphagia, both are including lower cranial nerve. So both together, it seems to be lower cranial nerve palsy.
Okay.
Thank you.
Thank you.
May I call upon the next speaker, Harshil?
Very good afternoon to all of you. Thank you SAG and Rakesh sir for this opportunity. And as we are near to the end of the conference, I will try to be quick and to the point. I have two cases on pediatric cervical pathologies. First case is of a 4-year-old boy who was unable to walk since last 6 months due to severe spasticity in both lower limbs. He also had right upper limb weakness. He was unable to move his legs voluntarily. Normal investigation which we all do, MRI of cervical spine and CT scan. I don't have the X-rays right now. It showed atlantoaxial instability, basilar invagination, compression at CV junction and myelomalasic changes. Next step, to do the MRI inflection extension. Here you can very well see the compression getting relieved in extension. In CT scan also, you can see the changes in extension. So these are the investigations which we all do. The point to be stressed upon in this case from my side is to get multi-planar CT scan images, just like the way Dr. Kshitij showed in his lecture, all the sagittal axial color image in one screen, in some another DICOM software by the surgeon himself, because always the radiologists, the images they provide, they are insufficient while planning such pediatric CV junction cases. So just it proved to be of great help in our case also. Here on the left side, you can see the high riding vertebral artery which was dominant. So we could not place C2 screws, pars or pedicle screw. So we planned, yes, and this paper is also given by Dr. Kshitij, who is present with us today. So we went ahead and did OC fusion with C2 laminar screws, C3-4 lateral mass screw. We also tied one sublaminar vial because on one side, because the hold was not that much on the left side. So this was what we did in this case. This was pre-op, and after the surgery on day 1, spasticity was improved. He was able to move his legs voluntarily. So in such cases, we should spend more time in planning, which we spend in rather than operation theatre. And the second case, 10-year-old boy with spastic quadriparesis, wheelchair bound for 1 year, unable to abduct arms over his head. Yes, the CT scan. This was also unusual. We have seen such case for the first time. C2, C4, both vertebrae were fragmented. C6 vertebra, which was the culprit here, it was hypoplastic, retropulsed completely in the canal, C6. This was the MRI. Boy was 10-year-old. He was quite fatty, and we found the clinical features quite unusual. So we also got genetic evaluation done, which came out to be sickle cell disease, nothing much complex. Dynamic CT we tried getting in this case, and there was some improvement in alignment on CT scan in extension. So while planning, we kept him in halo. This was the clinical image of that. He had very short neck. We kept him in halo traction for 2 weeks. This was the alignment after 2 weeks. Quite improved. So then, in final surgery, we got in anterior first. The size of the vertebra were very small. So we had to use mini T recon plate, the size, where only 2.5 mm screws could be used. And in the same sitting, posteriorly, fibula graft was placed anteriorly, and the same sitting posteriorly, 3.5 mm lateral mass screws were placed. This surgery was done by me and Dr. Ajay together. So halotraction can be quite handy. So take home messages from these two cases, multiplanar 3D reconstruction on different software by the surgeon himself adds a great value in planning such complex cases, and varied and extensive fixation options should be kept in CV junction. That is, apart from screws, hooks, sublaminar wires, Marcelin tapes, always. And halo traction in selected such complicated cases produces remarkable results. Thank you very much.
Very, very well demonstrated case and technique. Any questions?
Anterior plate, you use the locking screw?
Yes, sir.
Locking screw.
Hold, but still hold was not that
Screw
satisfied.
lock with the plate, threaded screw with?
Yes, sir. Thank you very much.
Our next speaker is Dr. Vandan Rayani. He will be speaking on cervical medullary peripheral nerve sheath tumor.
Good afternoon, respected teachers and colleagues. I am very thankful to Spine Association of Gujarat for giving me this opportunity. My patient is 21-year male patient. He was referred to us in intubated and tracheostomy state. Prior to that, he had complained of headache, giddiness and generalized weakness for 1 month and progressive quadriparesis over 15 days. And on 4th of March, there was sudden loss of consciousness. And outside MRI was done, was diagnosed with posterior fossa cervicomedullary lesion and was referred to us. On examination, he was conscious, arousable, obeying commands. He had weakness of all 4 limbs. Power was 2 to 3 by 5, and reflexes were upper limb were brisk and lower limb were absent. Planters were extensor. And during the pre-op course, bronchoscopy was done and it was negative. There was bed sore for which plastic surgeon reference was done. And preoperative challenges were, there was bilateral lung consolidation, right lung collapse, pneumothorax, for which ICD was done. So pre-op optimization, we had to do very much pre-op optimization. And the chest X-ray suggestive there is right side consolidation. And once the patient was optimized and relative were counseled, we proceed for surgery. On CT scan and MRI, we were suspecting either to be a exophytic brainstem lesion or second was ependymoma and medulloblastoma. So surgery was planned, midline in prone position, midline suboccipital craniotomy was done. Can you please play the video? So after the proper exposure, here the lesion is, we can see the lesion, it's a very globular lesion, and so first after piecemeal excision was done and QSA was used, there was well defined plane all over the lesion, and here we can see there was attachment to C1 nerve root. So the lesion was attached to C1 nerve root and there was well defined plane all over the lesion, and in piecemeal the lesion was excised. So almost gross total excision was done, and floor of the fourth ventricle, after the excision, floor of the fourth ventricle is seen. So this is the tumor removed, and it came out to be benign peripheral nerve sheath tumor, schwannoma. Immediate CT scan done suggestive of complete excision, and MRI was done later on, which also showed that the lesion is excised. But however, there were many post-op challenges. In form of that, patient had developed infection. The blood culture was done suggestive of blood culture, and even bronchoalveolar lavage was done suggestive of Klebsiella pneumonia. Patient had seizure, meningitis, septic shock, and peg placement was done. After that, patient gradually stabilized, but 10 to 12 days after surgery, again there was drop in sensorium, and CT was done, suggestive of there appeared to be a collection at the post-operative site. So what we did was we aspirated from this side, and CSF was sent. It was turbid, and the it was turbid, and it came, and gram-negative bacilli was seen. It was diagnosed with meningitis, and accordingly antibiotics were given. Gradually patient improved, shifted to ward, and just 3 days back patient had seizure. When shifted to ICU, CT was done, and there was hydrocephalus. Can you please play the video? So there was hydrocephalus, and immediately shunt surgery was done. So just at present, patient is M4 status, eye opening is present. So what we want to emphasize is, even in such a benign lesion, the location of the lesion is very important, because it was at the cervicomedullary junction. It was a large lesion. Patient had already come in a in a state where power was compromised. So gradually, all the team, that is critical care team, pulmonologist, everyone is working towards providing better result to the patient. Patient is still admitted in our institute. Thank you.
Thank you, Dr. Vandan.
Thank you, sir.
Any questions?
Yes, sir.
All pulmonary cultures and blood CS also.
Yes, sir.
Thank you, Dr. Vandan.
Thank you, sir.
So, next case is by Dr. Michelson on odontoid non-union with myelopathy.
Good morning, everyone. I'm presenting a case of 3-year-old female who came with complaints of imbalance. 7 months postpartum, again, imbalance started. 31-year-old female, complaints of imbalance, 7 months postpartum. Imbalance started and progressed in the postpartum period. History of odontoid fracture was there 23 years ago, which was managed with C1 to sublaminar wire fixation. Neurology gradually recovered after that one. But again, now she is presenting with neuric grade 3, but no, there is no motor deficit. X-ray and MRI is as showing here. Showing odontoid non-union with compression at the foramen magnum region and causing myelopathy. Dynamic X-rays are not showing any movement. We applied traction, tried to reduce it, but tried to find any movement in the non-union region, but there was no any movement available there. This is the CT scans. CT angio also showing normal vertebral arteries. So this plan, we were thinking about the only anterior release and then posterior, or only posterior approach, or both. Finally, we decided to go only posterior approach. We used O2 C5 fixation with multi-rod construct using C2 laminar screws and C4 and C5 pedicle screws and OC plates, plate rod constructs. Post-op MRI is showing a good gap near the foramen magnum region, and decompression is good. Thank you.
Excuse me, any reason for going up to C5, number one question? And number two, if you have not released, the CT scan seemed that it is a old, healed, very well rounded sclerotic C2, then odontoid also.
Yes,
so type 2 fracture. So if it had without anterior release, how did you expect that? Because it was not moving on flexion, extension, X-rays too. So what was the rationale for doing just posterior without releasing anterior?
The screws, first of all, the screws are, we usually check in the navigation, the trajectory of the pedicle screws. if we are not getting the good trajectory or the pedicle is not well formed or we don't find it very good for putting pedicle screw, we avoid that level. That is the reason for avoiding the C2 and C3. We got only in C4 and C5. We are well versed with the posterior only approach, sir, always, and we try to get it. Most of the cases we do well with foramen magnum decompression. Thanks.
Thank you.
Moving on to the next case, an interesting case presentation by Dr. Varshesh Shah.
This is good evening, everyone. This is a 65-year-old male presented to us with paresthesias in all four limbs and also associated with spastic quadriparesis. As motor power was 4/5 and all plantars subgoing with hyperreflexia, and sensory level was around C6, C7 with GOA of 11. This is the MRE of that patient. Who presented to us with 6 months complaint, exaggerated with 3 months, since 3 months. Here you can see the cervical spine with CVJ, and there is a compression from anterior side at the level of C2. There is a space of occupying lesion. You can see over here, iso-intense to the ligament and hyper-intense and looking like a CSF-like intensity. Anterior to the cord. Here you can see it better in a zoom image. And this is the myelogram showing the anterior compression. This is the axial imaging showing the same anterior these lesions, space occupying lesion with some cystic component looking like a CSF intensity. This is a zoom image. Any guess from the audience? What is it like? Huh? Okay.
It's a cyst which formed because of instability.
Yes. Very well diagnosed, sir. Thank you. What can be the plan, sir, if we can do anything for this? Like, okay.
It is better to grow posteriorly. You can take out from lateral part, you can take out that cyst very easily and do a fixation for instability.
Yes. Thank you very much, sir. For this case, what we have done is, this is a sagittal spine CT scan, flexion extension. And what we have done is, we have gone from anterior retropharyngeal approach, and we have removed the solid and cystic component from the anteriorly and then fixed it posteriorly. This is the anterior X-ray showing we are reaching up to the orontoid. Remove the part of the orontoid and remove the synovial cyst. And this is the sagittal CT. And then we, in second stage, we went posteriorly to stabilize and fuse the spine to prevent the recurrence. And C1, C2 fixation was done. This is, sir has rightly pointed out, this is a facetal cyst, not much common in CVJ, most common in the lower spine where the movement is maximum. And about the review of literature, regarding 63 cases presented by the Dr. Atul Goyal sir and the Abhidha Shah madam, the most number of cases in this series, and what they have found is just posterior cystic and solid component were there. They also called it whether retroodontoid pseudotumor, pannus or cyst. They have also pointed out the solid and cystic component. Most of they have 53 patients have the follow-up, and they have done MRI, and regression is seen in almost most of the cases. Around 20% of the cases shows the partial regression, and in the cases where there is os, there is highest chances of this facetal cyst. They have seen in 200 cases of 28 cases of they are showing this kind of cyst. Another case series by Dr. Nakano from Japan. They have also have around 28 patients. What they have done is they have seen this kind of cyst. They have measured the solid and cystic component, and they have done posterior fixation, C1 C2 fixation, and they have measured how much it reduces by posterior fixation. So they have seen that regression of the cystic component is maximum, is 100%, and in the solid component there is less regression, is around 9% only. So if solid component is there, there is less chances that only posterior fixation will help you out to relieve the anterior compression. Another updated review from Taiwan of in 2025, they have seen the cervical synovial cyst, including CVJ and the whole cervical spine.
Please
and they have.
Please speed up.
Yes, yes.
They
have almost 79 patients reviewed, and what they have seen is most of their synovial cysts were at CVJ, at C1 C2 or C7 T1, and what they have treated with is only decompression fusion. Only fusion and decompression fusion is done in only 30% of the patients. 60% they have done with decompression, and 2% they have done percutaneous aspiration also, and 9% they have managed conservatively also. That's all. Any questions?
No questions from the audience, so we will wrap it up. And
thank you, Dr. Vashish. We'll give the proceedings next to Dr. Rakesh Luhana, sir, please. You have wrapped up the session. Ajay, sir.
Vote of thanks you will tell now or what? Ajay.
So, the most exciting part for the day, prize announcement for best paper presentation. So before we announce the prizes, I would like to call upon all the presenters to come in the front. Every one of you. So all the papers were fantastic. There was tight competition. And for judges, it was, bit difficult to decide which paper should be given the prizes. So for prize distribution also, I would like to call upon Dr. Sudhir sir, Dr. Niraj sir, Dr. Ajay sir for the prize distribution. All presenters are here. Dr. Sachin, Karan, Jhalak, Margi, Dr. Mohammed.
Jhalak is not here.
She is not here.
Jhalak, you're not here. So who in behalf can collect the prize? Pratik, aajana yaar. So Jhalak, she is third prized with 64.33 out of this scoring with the topic of role of intraoperative neuromonitoring and efficacy of signals in cervical spine surgery. Good. Hitesh, indirectly it is Hitesh and Niraj. Good.
Sit down, please. The second prize goes to the topic, which is evaluation of clinical and radiological outcomes of anterior cervical hybrid surgery for multi-level cervical disease. Dr. Saurabh Kulkarni.
So the third prize was 5,000. He receives 11,000, and the first prize will receive 21,000, and the winner is Arijit Vashisht. Multiple rod constructs for occipital cervical fusion. Good paper and very good presentation. All the papers were very good, although there were some flaws in presentation, which some of the participants did approach and try to understand what was the issue with their presentation. So I think we have a good set of papers coming up from our members, but definitely need to encourage.
So I just wanted to add to all the speakers, first everybody must have realized that two of the speakers could not finish their presentation. So always be in time, because every phase of the paper has markings, right? So if you don't go to discussion, you don't get mark for discussion. If you don't reach up to conclusion, you don't get marks for the conclusion. And second most important thing, everybody says that material method. I think your focus in paper should be on aim, why you are giving that paper, what is exactly your material method. Statistical things, you just mentioned mean, median, you have to mention the rationale of using those statistical things. Discussion technique, this should be the least time taken. Your material method, result and conclusion, that should match your aim of the study. Some of them, started with some aim, conclusion was going in a different direction. So that should not happen. But otherwise, excellent papers. All were excellent papers. We were very happy and impressed. Ajay.
Over the years, what we have seen in last 15, 20 years, the Modi effect is already there. So the presentation from all quarters have improved to such a level that we really think that it is getting represented in SAG. That is one. Secondly, yes, presentation skills will also improve. I tell everybody of you to not see on the screen, but face the audience or the judge. You are remembering the data. Data nobody is reading through. You don't have to read through the data. You have to answer the data when the question comes. And you have to finish before time. And put more effort in saying the limitations. Because limitations वो question है जो वहाँ पे judge बजाने के लिए या anybody will ask. वो ज़्यादा बोल दिया तो you are likely to get saved. Because you know the limitation, he knows the limitation. You are already emphasizing that. Good. Anything amongst you want to speak?
So before we sum up, all the participants, the presenters will get the certificate and vouchers each. So I would like to call upon Dr.
I will announce, you give the certificate. So we'll start from first, Dr. Sachin Patel. Dr. Karan Chauhan. Karan, you can take on behalf of Margi as well. She is also not here. Dr. Margi Pandya. Dr. Mohammad Salar. Dr. Parikshit Godasra. And Dr. Udgam Bakshi. is not here, so okay. And one big round of applause for Nisarg, who has organized this entire thing. Thank you, Nisarg. Thank you so much.
Over to Rakesh sir and Ajay sir. Okay, so all the prize winners, you have to send your mail ID to the organizers so that they will send the Amazon gift vouchers to you.
Now just to wrap up with the अरे मौज ले लो सर. I would like to call Bharat Dave sir. Hitesh, भाई आजा यार. Hitesh, now joint vice president to vice president. So in SAG we follow a practice of sequence or automatic promotion, and we don't want elections. It is always better we don't have elections. I would like to call Nikhil Modi. Nimesh, please come on stage to honor our secretary, who is now going to be the joint vice president. 3 cheers. A wonderful program, a niche program, a national level program. Could not have been better than this. At short time also. Had it been done 3 months back, it would have been 500 participation, but it is not possible because members need to contribute timely. Still he did good. Now our Jigar, please be on stage, and I would like to call upon Apu. Please come on stage and felicitate Jigar, who is now going to be in the action role of secretary. Please, Kushal, come on stage, and I would like to call Amish. Dear, please come over stage to felicitate Kushal, who is right now the treasurer, and by sequence and automatic promotion becomes the joint secretary. Niraj, I will call you to felicitate Nisarg Parikh, the EC committee member. Nisarg has actively contributed. Mayur, please come on stage. Please felicitate Amish. He has been there always when called. Denish, you're not here. Kushal, please collect on his behalf.
Pharma has been big contributor. Abacus Meditech, Technoshine, and Globus Medical. We thank you all our sponsors. Our online partner, Ortho TV, who have been lively relayed this case. this whole conferences. And with that, we conclude the session. Thank you everyone, and we'll meet for GBM. So all SAG members stay here. Rest all soon become the members and then join. So event management people also, I think, thank you, we'll leave. And we stop Ortho TV here, yeah, and we'll proceed with GBM.